Please find your seat if you have not already. Welcome, everybody. My name is Matiange Sirleaf. I'm an assistant professor of law here. Really excited to see so many faces in the room. If you haven't registered already, please do so. If you haven't gotten food already, please do so. Really important pieces of information before we begin. The restrooms are located right here. Both the bathrooms are located right here. If you want a gender-neutral bathroom, they're downstairs. If you need to connect to the Wi-Fi, EduHome you can use if you are affiliated with an educational institution. If not, please speak to Taylor and Amber in the back, and they can set you up with the guest Wi-Fi situation. So we're going to begin with our welcome remarks, and I'm just going to throw it over to our esteemed panel over here, and we'll begin.
Thank you so much. Good morning. I'm Ariel Armoni. I'm the Vice Provost for Global Affairs and Director of the University Center for International Studies, UCIS. And it's a real pleasure to welcome all of you here today for a very important discussion on global health inequities. Today's workshop is part of the year of Pitt Global, and I can't think of a better, a more necessary topic. Highly infectious diseases make up 5 of the top 10 leading causes of death in low-income countries, but just 1 of the top 10 in high-income countries. Yesterday's New York Times published an op-ed piece alerting us about the shortage of specialists trained to diagnose and treat infectious diseases in the United States. And as the article says, this could not be happening at a worse time when superbugs are killing hundreds of thousands of people every year. This workshop aligns nicely with the global plan for Pitt. In particular, the workshop convenes a dynamic community of researchers and practitioners which will help advance the frontiers of knowledge and assist with tackling real-world problems. The workshop will consider the unique challenges in combating global health inequities for infectious diseases for a host of fields, as well as many sub- and cross-disciplines. It brings together scholars writing in human rights, human security, poverty and inequality, global public health, medicine and law, among other fields. The workshop will serve as an opportunity to network and facilitate outreach between junior and senior scholars and create linkages between students interested in the study of health inequities in infectious diseases. In this way, this meeting offers an extraordinary opportunity to help cultivate globally capable and engaged students toward lives of impact in their communities and beyond, very much in line with Pitt's objective of enhancing the global readiness and global competitiveness and competence of our students. I would like to thank all of you in today's event, including, of course, the School of Law, which is hosting this workshop, as well as one of our finest law professors, Dr. Matiange Sirleaf, who is the leading force behind today's event. Thank you so much for all your work. The University Center for International Studies, UCIS, is a proud co-sponsor of today's event, along with the UCIS affiliated Center for International Legal Education and 2 centers within UCIS, the African Studies Program and the Global Studies Center. In fact, the Global Studies Center now offers a certificate in global health for undergraduates, which empowers students to explore transnational processes impacting health inequities. One of our students is already doing so, Leah Petros, who is a 2019 Rhodes Scholar, and she began her international work as an undergraduate at Pitt. She engaged in a health program in Malawi, working with Dr. Gerard Douglas, and Leah graduated with degrees in neuroscience and economics clearly thriving in our multidisciplinary community. It's no coincidence that many of our finest students have impressive international experience. As I mentioned earlier, to continue striving for global engagement as a university, we have emphasized the Year of Pitt Global, which places global learning, research, partnerships, and events at the center of the university's mission. Throughout this academic year, the university has funded dozens of interdisciplinary conferences and workshops, such as today's, leveraging more than $1 million to support these initiatives. It's imperative that we take the strengths of Pitt as a global university to heart as we move on to our next goals. At the heart of these efforts is rethinking healthcare, not just for the United States, but for the world. We have the opportunity to bring together a wide range of scholars and departments to focus on grand challenges, closely aligned with the United Nations Sustainable Development Goals, in this particular case, to ensure healthy lives and promote well-being for all at all ages. I'm very excited to see that we continue to accomplish this as a shared community. And I want to end by thanking some of the other workshop sponsors, the Center for Global Health, the Ford Institute for Human Security, the Center for Bioethics and Health Law, the School of Medicine, and of course the School of Law. We could not be here today without all of you. I want to thank the presence of and support of Don Burke, the Dean of Pitt's Graduate School of Public Health, and our host, Amy Wildermuth, the Dean of the University of Pittsburgh Law School. Thank you so much.
Thank you all, and welcome from me as well. This is a really exciting day here at the law school. We are so happy to host all of you as part of this incredible multidisciplinary group of scholars examining global health inequities in the distribution of infectious diseases. As you all know, the person responsible for this amazing event today is our law colleague, Matiangai. And of course, she is the perfect person to lead this effort. As the Chancellor wrote in his letter recognizing her as this year one of the highest honors at Pitt, the Chancellor's Distinguished Research Award in the Junior Scholar category, her cutting-edge, multidisciplinary approach to global problems has formed a foundation to support efforts to find solutions in post-conflict societies. That is what we are after today. Reflecting her high expectations and pursuit of excellence, Matiangai has put together a well-thought-out and well-executed plan for the day. What she did not realize is that in showing such success at academic organization and administration, she will undoubtedly be called on again and again, making true the old adage that no good, or in this case, great deed, goes unpunished. Matiangai was not without help. I want to recognize the terrific Pitt Law staff, including Kim, who's in the back. Wave, Kim. There's your IT person in case you have any IT problems. Austin, Mickey, and then of course our wonderful students that were already introduced, Amber and Taylor in the back. Without them, this would not be possible. Please join me in thanking all of them for their I also want to thank our great sponsors for whom we are grateful in making this workshop possible because they are listed right here and they've already been announced. I'm just going to say thanks again. Finally, I want to thank all of you for being here and being part of this important discussion. I look forward to hearing from all of you. Thank you again for joining us today at Pitt Law.
Well, thank you, and welcome to you all to this workshop on global health inequities and infectious diseases. I'm the Jonas Salk Chair in Population Health. I knew Jonas Salk years ago. And I hope you all know that Jonas Salk developed the polio vaccine here at the University of Pittsburgh. That trial took place in 1954, and polio is almost eradicated from the globe. As the last count this year, there are now 9 cases in the entire world of wild polio so far this year, most at the Afghanistan-Pakistan border, in one of the most difficult places for health workers to work in the world. And that exemplifies some of the problems that we're going to be talking about at this session. But there are successes that are even more spectacular in this area of infectious disease control around the world in the poorest countries of the world. I'm going to do a quick show of hands, and if I embarrass you, that's okay. How many of you know Gavi? Have heard of Gavi? Well, this is good. This is good. Because when I ask other audiences, most people have never heard of Gavi, the Global Alliance for Vaccines and Immunization. Gavi was started in the year 2000 to address the problem of infectious diseases in poorer countries around the world. It's a partnership of the Gates Foundation, the World Health Organization, UNICEF, and the World Bank. And what they did was realize that what was preventing vaccines from getting to the poor countries was there was essentially a global market failure of ability to pay for vaccines in these locations that needed them. So they put together an organization that pooled the demand, got some long-term financing, and the result has been spectacular. That over the last 15 years or so, the number of children immunized is now over 600 million. The number of deaths averted is 8 million, and the under 5 mortality has dropped by 15 or 20% around the globe. So the answer is, when we put our mind to it, we can do things. And so the challenge here today is, you've identified some of the important problems that are still there in the area of infectious diseases, neglected diseases, and global health inequities. And the ones that remain today are the harder ones. So I expect that at the end of today, we will have some good discussions about how to address those. And we'll have other examples of maybe ways to bring us all together to address these issues. There's still much work to be done. And I want to add my welcome to the scholars who have volunteered to speak here today, and I look forward to an exciting workshop. Thank you.
The medical response program for Boston University's maximum containment biosafety level 4 program at the National Emerging Infectious Diseases Laboratories. She serves on national and interagency groups focused on medical countermeasures, the intersection between public health preparedness, research, and clinical care for emerging pathogens. Her research focuses on identifying safe and effective clinical interventions and infection control measures related to viral hemorrhagic fevers. During the West African Ebola epidemic, she served as a clinician in several Ebola treatment units. She worked with the World Health Organization and Partners in Health. She currently serves as the clinical lead for the Joint Mobile Emerging Diseases Intervention Clinical Capability, also known as JMEDICC, in case you're wondering. That program is a joint U.S.-Ugandan effort to create clinical research capacity to combat viral hemorrhagic fevers in Uganda and at the border of the Democratic Republic of Congo. And for those of you who have been following this, as you know, the Ebola virus is spreading quite scarily in the DRC. She's also served as a subject matter expert to the U.S. Centers for Disease Control and Prevention for the Department of Defense, for the Global Fund to Fight AIDS, Tuberculosis, and Malaria, and also for the World Bank. Dr. Bedelia is an assistant professor at the Institute of Human Security at the Tufts Fletcher School of Law and Diplomacy, where she teaches courses on human security and emerging infectious diseases. So I could think of, well, one other person that would be well suited to address this group today, but I'm really excited that Dr. Bedelia is starting us off because her work is really at the intersection of all of the topics that we're talking about today. And so she will be speaking on how we can leverage the global health security agenda to combat all neglected infectious diseases. If you could please join me in welcoming Dr. Nadeem.
Professor Sirleaf, the honor is truly mine. No, seriously, when I was invited and I looked at the invite list, I said, what could I possibly tell you that you are not already an expert in? But really, my path has always been the interpreter, because I ride these two different worlds of international affairs as well as medicine and public health. And so maybe let's just make my role today be the interpreter of bringing everybody to the same vernacular. And the other thing that I wanted to do today with these remarks are just talk about the problem from a practitioner's perspective, and really at the micro level, just so that we can go back to where some of the largest challenges are to getting quality care, timely care for highly communicable infectious diseases, as Dr. Berg was saying. So I have no disclosures, and all the images are mine, and when there are images of people, they were taken with their permission, as you'll see. So really what I want to talk about is what is this rising threat of emerging and particularly epidemic infectious diseases, so EIDs, and then global health security agenda itself, which a lot of you in this room might already be familiar with. And then really talk about what some of the issues are with the current global health security agenda as it's laid out. And particularly it's for what? What are we securing the global health security? For what population and from what? And then the common challenges across all neglected infectious diseases, whether they be epidemic or whether they be sort of neglected tropical diseases that often don't make it on research agendas or make it on policy agendas. And then how we sort of leverage that global health security agenda to combat everything. So just taking a step back, if you have noticed over the last year, over the last 15, 20 years, that every year or year and a half, you're seeing a new human pathogen on the international scene, it is not your imagination. And it is not just a detection bias, although we have gotten better at detecting emerging infectious diseases. Part of the issue is they are getting more frequent. And the World Bank, the World Health Organization, every month tracks about 7,000 new signals as reported by individual sovereign nations about events happening within their borders that might be of concern. And of those, at least 50 of them actually amount to physical evaluations in the field every month about what might amount to an outbreak that might be the new DRC, or might be the new West African outbreak that happened in 2013 to 2016. And it's becoming sort of a larger, it's not and on everybody's radar, because the proportions of the cost, when I think the numbers, you may correct me, are for the South Korean outbreak with MERS, where I think it was maybe 24 healthcare workers who were affected, and something along those lines. The overall cost to the entire country was in the billions. I think it was $3 or $4 billion was the cost of that small outbreak, because not only did they affect the immediate human impact, but they impact travel, trade, economics, everything else. And the estimated cost of an influenza pandemic in this day and age is thought to be $570 billion. And that's from the World Economic Forum, from a recent publication. And again, this is not, a lot of what I will tell you today are things you already know. I'm just setting the scene for everybody else who's coming after me. So the factors that are affecting sort of the increase in infectious diseases outbreaks are, all the things that you would imagine. When I was born in the 1970s something, there were half as many people on the face of the earth as there are now. So there's 4.6 billion people, and now there are over 7.6 or 7.7 billion people in the world. Same amount of land mass, twice as many people encroaching into natural habitats that have been balanced with themselves, exposing ourselves to viruses that are likely to sort of be, over time, become more and more likely to cross over, spill over into humans and cause disease. And to add to that, the levels of deforestation, the increasing sort of connectivity that we have, and someone mentioned SARS earlier. I think the SARS in 2001 basically went from 2002, basically went from Asia to North America and back to Asia within 72 hours. In 2017, 4 billion people got on a plane. The connectivity in the last 15 or 16 years after SARS is immense, right? There's good parts to that. We can travel everywhere, but with the good roads come greater connectivity. With better flights come greater connectivity. And with that comes greater responsibility between countries. And the other thing that we're noticing, just from perspective from my line of work, as Matianga mentioned, my work is really on viral hemorrhagic fevers and zoonosis in particular. And what we're noticing is that 2/3 of all the infectious diseases that we have that have come on the world scene since 1980 are something we call zoonoses. They have crossed over from animals into humans. And so 2018 WHO Research and Development Roadmap identifying some of these diseases that need more research, that need more evaluation are as follows. Crimean Congo hemorrhagic fever, Ebola virus and Marburg virus, Lassa fever, MERS and SARS, Nipah and Hendra viruses, I should say, Rift Valley fever, Zika virus, and disease X. And disease X, I think everybody sort of thinks of it as avian influenza, probably, whichever comes up on the scene first, right? And the interesting thing is how we relate, and this is where I'm crossing over from my law colleagues in this room, how we are beholden to each other as sovereign nations when there are infectious diseases is not something new. We have dealt with this for a very long period of time. Before there was international health regulations, we had the International Sanitary Conference in the 1800s really looking at cholera, right? How do we ensure that cross-border relationships don't break down, that we are honest to each other when it comes to threats within our borders, but yet not using it as a way of protecting our own products or limiting trade and travel. Which of course was followed in 1978, probably right now at 7 p.m. in Geneva, about whether or not the DRC Ebola outbreak should be declared as a public health emergency of international concern or not. And then the other thing that is required is that all the signatories have a basic amount of capacity to surveil, detect, and respond to emerging infectious diseases threats or any infectious diseases threats that might have trans-border consequences, right? And so it's adopted unanimously by WHO states, and the requirement is that those countries can detect that and then respond to WHO within 48 hours. Pretty stringent sort of, requirements. And then these are some of the public health emergency criteria. And you'll notice just how, in some ways, how subjective I've always felt that they are. But there's a more technical annex available to looking at this. However, dealing with cross-border issues and dealing with sort of these infectious diseases is not as simple as this, right? This is an image from, I took this image, this is in Uganda in August 2018, looking at the DRC border. The DRC border is just past this door. This is an image from the Kasese market in Uganda where on Wednesdays and Fridays, over 10,000 people crossed the border before noon, right? And this cross-border evaluation for Ebola patients after the DRC outbreak happened has been happening since August. Every single person that crosses this border gets evaluated for Ebola. And by the way, majority of the people who cross the border don't actually use this door. They cross informally with footpaths between the two countries. The other thing that makes it hard, aside from the fact that we're a very mobile species, is that less than 20% of the 194 WHO states that actually signed up have the capacity to meet any of those IHR requirements. And there's no way to actually enforce that countries are able to sort of meet all the requirements that they have signed on to for IHR, because this is soft law, this voluntary cooperation, right? That's always been sort of one of the big issues with it. And there's the other part is there hasn't been as much sort of sharing for best practices across the nations about what works and what doesn't work. So after the 2014 Ebola epidemic, the West African Ebola epidemic, in 2014, Obama signed a agreement with U.S. involvement as well as 60 countries at this point in 2018 to create something called a Global Health Security Agenda. And the goal of this was to push the envelope on the readiness, to push the envelope and get a common understanding of what's missing in each of the different countries that are part of the GHSA agreement, to be able to combat the new SARS, the new Ebola epidemic, the new Lassa fever epidemic. And a function of that was creating a joint external evaluations, which are voluntary assessments from outside experts. And the levels at which these countries are evaluated are 11 action packages. And you can sort of see that they all fall across three things: prevent, detect, and respond. And it's ambitious, but what's happened with GHSA is what happens with a lot of other, exciting international, new exciting international movements, which is now that there is no outbreak, now there is no threat, the funding is dwindling, right? The U.S. Political cycle has changed, and so the funding for GHSA actually was under threat as of just 6 months ago. Yeah, but we won't go into that. So I want to show you these are sort of the official neglected tropical diseases that WHO recognizes, right? But when I'm talking about neglected infectious diseases, I'm not just talking about these, the neglected tropical diseases as recognized by here, which the majority of them are bacterial and parasitic. I'm talking in general infectious diseases that are not under the GHSA. The problem with the GHSA is who is actually being affected by Ebola, right? What percentage of the people, so I'm working in Uganda right now. How many people die of Ebola every day in Uganda? Not that many, right? Is Ebola in the top 10 causes of death in Uganda? No. Right, when you look at what people are actually being affected by, the 17 neglected tropical diseases that I mentioned affect 1.4 billion people, which, as someone who worked in the field during the West African Ebola epidemic, I can tell you, it was heartbreaking to see 28,000 people get sick and 11,000 people die. But that's 28,000 people, and this is 1.4 billion people being affected. And then over 10 million people fell ill of TB, and 1.6 million died in 2017. And then again, 119 million people were reported to have malaria in 87 countries. So how do we leverage? So what is global health security? In some ways, it is our push, by our, I mean the global north, the European and American perspective, of ensuring that the diseases that scare us in other borders don't come over here, right? Let's be honest, that's what it is, right? So how do we make it more equitable? It's not a new thing that we have taken a prior vertical program, such as HIV or any of the sort of the one drug, sort of a one disease campaigns that have been in the past, and utilized it with something called diagonal development, diagonal programming. So you might have heard of this terminology by Julio Frank. So there's vertical programming and there's horizontal. How do we leverage high dollar impact, high sort of political impact programs like global health security to basically benefit the rest of the millions of people who are being affected with neglected infectious diseases, right? And I think there are ways to do that. There are ways to do diagonal development with global health security agenda as well. Because the challenges that actually affect us detecting, and by us now I mean those of us working in the emerging infectious diseases field, challenges of detecting emerging infectious diseases are very common, and responding to them are very common to what happens with every other infectious diseases in resource-limited settings, right? So why can't we detect outbreaks earlier? I'm going to do something that's very sort of basic, but I'm going to do it so that this is an exercise in just showing how ridiculous things are at the ground level sometimes, right? So to detect emerging infectious diseases, if you want to figure out if a patient has Ebola or Lassa versus malaria, you have to have that patient first realize that they're sick. They have to have enough time off work to be able to go and seek care. They have to have not enough stigma so that they have to not be faced with stigma so they can easily access care, right? Then they need to be able to actually access care. They need to be able to have a clinic close enough to them, and we know a huge percentage of the population doesn't live close to any kind of healthcare. It's a huge trek to get anywhere. Then you have to have a clinician who actually looks at a patient and says, oh, you're right, that is not malaria, that looks like Lassa. And guess what Lassa or Ebola looks like? Fever, nausea, vomiting, diarrhea. Everything looks like fever, nausea, vomiting, diarrhea, right? So most of the world, when they present to clinical care, when they present to someone like me when I'm practicing in Uganda, is they present with fever, nausea, vomiting, diarrhea. And actually a huge proportion of people are treated by symptoms only. They're said, here, there's a malaria medication. Come back and let me know if you get better or not, okay? If that's the case, if that person had Ebola, they're gonna go back, get sicker, not get better, and infect everybody else in their household and come back, right? Then you to have a laboratory to actually confirm the diagnosis. Now you have somebody who picked up the fact that, oh, this looks like it might be Ebola. And and this is what happened in Nigeria in 2014 when there was a case of Ebola that went from Liberia to Nigeria. There was a very astute clinician in one of the large tertiary care hospitals in Lagos, and she basically said, I don't think this is malaria, I think this is Ebola. They also needed, aside from that, a very quick response from a local laboratory at the Redeemers, I think, University that already had that capacity to test and then confirm that it was Ebola, right? So they needed that to actually sound the alarm that Ebola was in Nigeria. And that laboratory capacity is sorely missing. Then you need public health systems that are functional enough to report up the threat up and actually recognize the political importance as well as the public health importance of that. And then you need national governments to assign priorities and resources. Governance is an issue that I won't touch with a 10-foot pole. That's somebody else's job in this room. And then international health partners. Again, thankfully this is not my field. I can stay in my lane and leave this to the lawyers and the public health policy experts here. The basic issue is that at the end of all international surveillance for infectious diseases outbreaks are communities that don't have access to care. As long as you have no access to care in that last mile, you will always miss the first 5 or 10 or 20 people that have an emerging infectious diseases outbreak, right? So we think of it as a world where we detect outbreaks and we sort of respond to them. Instead, think of it as a world where probably there are tons of silent outbreaks that we don't actually detect because majority of the people don't get diagnosed and they die before they are diagnosed. So one of the things I think we could do is actually move global health security closer to goals of universal health coverage. We signed the Alma Ata in 1976 and we sort of left it behind in the dust with all the sort of more pressing issues that we had. By sort of looking at what points of global health security investments already can leverage the move towards universal health coverage to fix the last mile problem. I think you have quicker response. You have more resilience in the system so that you're not waiting for foreign medical teams to come respond to an outbreak. You have systems that are resilient enough. There's enough resources, enough infection control, enough education, enough everything that you have a quicker sort of response. And you're improving the quality of response and care. I know West Africa was supposed to be sort of not a good example, right? I would go around giving lectures after my experiences in West Africa, and 2 or 3 years after that, I felt like everybody's eyes are glazing over. Nobody thinks this is important anymore because things were so bad, right? In my first deployment in 2014 in August, there were about 4 MDs and about 8 national nurses and about 100 Ebola patients, just to give you an idea. Emory had the opposite. I'm pointing to Anita because she was at Emory then. And Emory had the opposite ratio where they had 1 patient and 100-something, 100-something healthcare workers. Is it any surprise then that the mortality of Ebola in my unit was 65% and the mortality of most expats that were actually sent back was less than 18%? How many other diseases do we know of that we think their mortality is high, that are potentially emerging diseases, infectious diseases that we're learning more about? But that mortality is more of a function of the kind of care that we've been providing in the field rather than what the disease manifestation actually is, right? And then you have, by doing these move towards universal health coverage, you are building greater trust in the communities you're working with. You mentioned polio, right? One of the things that polio, some of the global polio eradication initiative has done well when they're going into areas of high conflict is not just approach it as an issue of like we're coming in to vaccinate for polio, but really what are the other problems? Building sort of the trust by working with communities to recognize that it's not, we're coming in because we're afraid you have this disease and it's going to infect us, but going in and really sort of working on a collaborative approach. And you can see that in DRC. right? This is an issue, DRC is a complicated issue right now. The outbreak is happening in North Kivu, an area that's, for over 20 years has had sort of armed conflict, 100-something armed groups are in that area. You have great sort of distrust in the government. So yes, it's complicated. But in the middle of all that, you have basically public health workers going in with astronaut suits and white tarp tents and saying, hey, we want to take your family members and put them behind these closed doors where they may probably never come out in a stationary area. And by the way, they may get attacked by rebels while they're in here. Who would send their family members into a situation like that, right? And so it's completely logical that people are not going to care. It's just how do we go from that space to more trust? And I think one of the things is to not do it in the middle of an emergency. I mean, this is obvious. I'm just, as I said, majority of what I'll mention to you today will be obvious. So, someone mentioned the Sustainable Development Goals, and there is, when you look at the overlap between global health security and SDGs, there is a lot of overlap between the programming of the two, and I won't go through a lot of these things, but there is a way to sort of link these better, and I think that there have been academic effects, academic sort of papers and such that sort of evaluate this, but there needs to be greater functional evaluation of this. In Uganda, the Global Health Security Agenda, Uganda's been a great sort of leader in this, in the equatorial and eastern African region, and you can see that they're doing a great job of trying to link this with some of the other programming, but GHSA has become a beast of its own. It has its own representatives and everything else. We need to sort of cross this and make it a little bit more wholesome. So the other problem, so aside from the last mile problem, the other problem is the whole nausea, fever, nausea, vomiting, diarrhea issue, right? Everybody has that symptom. So how do you find the epidemic needle in the endemic haystack? This is a picture of a ward in Kono, Sierra Leone. They're in the hospital, the Kono General Hospital, and when there's one ward in that hospital, which the whole function of that ward is infectious diseases that nobody's diagnosed. They don't have the tests to actually figure out and name the disease that the people have in that room, but they know is highly contagious or something they're not aware of because people are getting sicker. A whole ward full of people that have an infectious diseases, but I'm sure that if we went in with a PCR, Anita, I'm sure we could just diagnose what it is, right? But these are people who potentially have absolutely no diagnosis with care or with or any sort of guidance for treatment. So, and it's not just important here, it's not just important that we sort of tease out what is Ebola and what is Lassa in general setup at the beginning of an outbreak, right? So we can sort of sound the alarms early. It's also important once the outbreak has started. So this is an anatomy of an Ebola treatment unit. This is an image from Doctors Without Borders, and a lot of you all would already be familiar with this, but I'm just gonna play this out for you a second. So people, when they were brought into Ebola treatment units, and this is still true, this is happening in DRC as well, when people get brought to the Ebola treatment units, they fit a case definition. So the case definition for WHO in the epidemic setting is fever and 3 symptoms, fever and contact with an Ebola patient, or fever and hemorrhagic features. You get brought in, you are placed in a suspect ward, depending on whether you have nausea, vomiting, fever, diarrhea, you're more producing bodily fluids, you're in the wet area, or you just have fever, you're in the dry area. Here you wait to get tested for Ebola, okay? If you're negative, you leave the suspect ward. If you're positive, you go to the conform ward and you're treated probably not any more differently because all we have for Ebola is supportive care until recently. So you're basically waiting here without any personal protective equipment if you have malaria, among other people who will go on to be positive for Ebola. Guess how long the wait was in 2014 in Sierra Leone in one of my first deployments there. For a lot of Ebola treatment units, it was up to 3 days. Imagine being the patient without personal protective equipment on in that hot zone around people who had Ebola. I mean, I couldn't imagine. Think about the amount of investment that we've spent here to keep healthcare workers safe, right? So this is the other area why we need multiplex diagnostics. We need diagnostics that not just allow us to sort of tease apart stuff at the very beginning, but when people come into this field. So the other thing that we were doing, so this was terrible. This is, I think, in my mind, was one of the biggest human rights issues during that outbreak. But here's the other terrible thing. We told them, hey, you don't have Ebola, but bye-bye, right? If they had something, and we had no other way to diagnose them for what they had. So majority of the time, we would send out the infectious diseases folks, the people who had infectious diseases with a course of antibiotics for what our best guess was that they had, and they had nowhere else to go because during that outbreak, most of the hospitals had shut down. Guinea saw about 80% drop in clinic visits. Like there was nowhere, and we would see this. People would come to ETUs to get, to get HIV care, to get tuberculosis care. So multiplex and easy diagnostic, point of care diagnostics are an important part that not just help emerging infectious diseases, but we need to add on the other infectious diseases. You can't just be looking for the Ebola. You need to make sure you're looking for all the other diseases that people might have when they come in. Because in reality, they don't look like this. Ebola treatment units look like this. This is a picture from my Ebola treatment unit in August 2014. This is one of my colleagues, Dr. George Reese, who you know. In Ebola treatment units, in reality, people provide care to each other. They take care of each other. It's a very human thing to do. They don't stay in these separate areas and don't infect each other. They try to take care of each other and their family that are in there. So, like I said, it's not so much a world where we're detecting outbreaks. It's a world of silent outbreaks, and we pick up one once in a while, is really how I started seeing it after seeing all those different units that basically have no diagnosis. The other reason diagnostics are important, and diagnostics not just that are multiplex, pick up a lot of things, but diagnostics that are point of care, available, cheap, at the site of where patients are getting care are important, is that if you don't get diagnosed, you don't get counted. And if you don't get counted, we don't know how big the problem is. This is an issue with emerging infectious diseases. So for Lassa, for example, another viral hemorrhagic fever that's endemic to West Africa, and Nigeria is having a big issue with it. They've seen sort of a huge rise in Lassa cases. And the question is it because there are more diagnostics available, or is it really that there are more cases? And the thought it actually might be that there are more cases aside from the fact that there are more diagnostics available. But there's a huge percentage of people in Nigeria who still don't get diagnosed for Lassa. So we don't actually have an idea of how big this outbreak is. This is a disease that's transmitted by multi-mammoth rats in poor households where rats may leave defecation or urine in food sources and things like that. And so these are the very communities who would not have access to care, right? So there was a recent paper in Science that talked about how they figured out the pattern of where those diseases are coming from. The concern was, are there so many cases of Lassa because Lassa all of a sudden is also being transmitted human to human. So they did a metagenomic analysis of basically trying to figure out were these human-to-human transmissions or were they rat-to-human transmissions, right? And then they said, oh yeah, it doesn't look like human-to-human transmissions. But my question is, and that might be accurate, that might be what it is, but all their analysis was done on people who were actually diagnosed. What percentage of Lassa people are actually diagnosed? We don't know that. And if you don't know that, how can you have a realistic understanding of what the epidemiology of this emerging infectious diseases is? So that's the other reason that I think that it's important to sort of have better diagnostics for both emerging as well as other neglected infectious diseases. So in terms of numbers of how many people are not diagnosed for just even common infectious diseases, right? 2.5 million of the 9 million tuberculosis cases each year are not diagnosed or not notified, and 1/3 of those are multi-drug resistant tuberculosis patients. And then, only 1/3 are actually diagnosed that are MDR. And then more than 80% of malaria patients are diagnosed based on signs and symptoms. And remember I said, Ebola, Lassa, Henipa, CCHF, Rift Valley fever, they all look like malaria. So if 80% of malaria cases are not being diagnosed, what else are we missing? And then more than 50% of people are living with HIV and are not aware of their diagnosis. So the importance of diagnosing both endemic and epidemic diseases together, it's the same populations, as I've sort of tried to speak about throughout this talk. It's the same populations that are affected. And the efforts to diagnose and combat neglected tropical diseases, I think need to be better aligned with the efforts that are under GHSA for those reasons. And I think that when we control the other reasons for why febrile illnesses, fever-borne illnesses occur, we have more chances of picking up the epidemic needle in the endemic haystack. So really, this should be seen, the efforts for combating neglected tropical diseases should be seen as part of GHSA because it's helping us recognize that rare case a lot more commonly. And I won't go too much into this, but there's also importance of, the co-infection between a lot of these diseases. There's now new science in terms of how there was interesting data during the Ebola outbreak in malaria and Ebola, right, co-infection, but as we learn in general, we're learning how viruses and bacteria, for example, interact and cooperate to worsen a disease, make transmission easier. When two arboviruses, mosquito-borne infections, when they co-occur in the same area, there are definitely dynamics that they follow, and we don't know anything about this because we are not actually diagnosing the humans who have them. And then the last bit of this is why we need a longitudinal presence. GHSA has to be about a longitudinal presence in the countries that it's been working with, right? This is an image of Ebola survivors. My third trip on Sierra Leone during that epidemic. I was training with a couple other colleagues from WHO. We were training Ebola survivors who wanted to go back and work in ETUs, in Ebola treatment units. They saw how terrible sort of the care was, how few people there were. They wanted to go back and help. We think they're immune, but we want to make sure they have the best infection control training that they can get. 50% of the people in this image had something called post-Ebola virus disease syndrome. So that is an entity that we didn't know about. Ebola was discovered in 1976. We didn't know about post-Ebola virus disease syndrome, which is when people survive Ebola, they still have long-lasting joint pains, memory issues, neurological issues, right? Some of them, they may even have the virus still in their immune privileged sites. We didn't know about it until 28,000 people got sick and 11,000 people died. We didn't know about it until one Scottish nurse was evacuated, got better, recovered, and then 9 months later, she had a meningitis type picture. Somebody looked in her central nervous system and said, oh my God, Ebola can do this. And when you talk to my West African colleague who were taking care of a lot of Ebola survivors, they're like, yeah, we've seen people die of this all the time. We just had no way to diagnose them, right? The reason we didn't know about post-Ebola virus disease syndrome is that we don't stick around after outbreaks. If global health security is only focused on outbreaks, it's not going to do well because it's in some ways it's on our own self-interest, particularly with these emerging infectious diseases, to stick around because we get to learn about the pathophysiology of these diseases. We learn the longitudinal presence or manifestation of a lot of these diseases that we don't know much about. And make no mistake, we don't know a lot about Ebola virus disease, as those of you who know the virus in this room can tell me. And this is sort of an issue that's across the board an issue for all emerging infectious diseases, right? We're dealing with clinical care while the guidelines for that clinical care are evolving. This is really hard. It's a default N of 1 trial because the first 100 patients we take care of with a lot of these infections are basically impacting the care of the next 100 patients that come in with that disease. Everything from what kind of fluids should we give them. We still don't know what the right fluids are for Ebola or Lassa or any of these viruses. When do we give antibiotics, which we're giving to all of these folks? We don't know anything about those. And by the way, the data that was coming out of a lot of those Ebola treatment units in West Africa was terrible because there just weren't enough people collecting that data. That's improved now in the current outbreak. This is me. I'm usually the shortest person to any photograph. You can always and the research is not about just diagnostic and medical countermeasures. It's really about clinical presentations and disease manifestations, right? It's really about the core basic things about what is the best supportive care. We don't know a lot about any of these diseases. And the other thing is for many of these diseases, we don't have facile diagnostics. For Lassa, it's hard. It depends on what strain you have, and what disease, what diagnostic you're actually using, whether or not you're going to pick it up or not. And then you have to, every single time this happens, we're balancing research with response activities and the ethics of it. And I don't blame, I completely do not envy the CDC during the West African outbreak because if you remember, there was a lot of distrust against the CDC because they were seen as changing guidelines and not knowing what they were doing. Well, they were basing their guidelines on stuff that we were learning in the field. The personal protective equipment was changing based on our experiences. They should really tell you how fluid that situation is, how fluid sort of our knowledge of these diseases and infections are. So when it comes to people with emerging infectious diseases, I think it's sort of a separation of clinical care and research is kind of a false dichotomy, right? Because there was a Ebola treatment unit that started giving people high doses of non-steroidal drugs, which potentially could make the bleeding worse in a hemorrhagic fever. And it's something that you would give as a supportive care measure, right? But they were giving high doses. and it was not under research. Isn't that research? Right? Any clinical care that you're providing in a disease that you don't know much about, the care itself is in some ways research. So, but it's not just emerging infectious diseases. We started the talk with cholera, right? We've known about cholera since, we've been dealing with it in international states since 1800, if not before. But there's a ton, when you hear my colleague Dr. Lupernara speak, she is a pediatric emergency room doc who works with MSF and CDC on cholera, has basically response to cholera outbreaks around the world all the time. She'll say, we don't even know how cholera manifests or what the best care is in special populations in cholera. Severe acute malnutrition, pregnant women, HIV, any kind of immunocompromise. Cholera is a disease that we've lived with as a species for a very long time. There's very little research on cholera. Like, there's no good data, clinical data that we're collecting from a lot of the cohorts that we're treating. Isn't that insane? We've known about this for such a long period of time. So the other thing that I think, and I'll end with this, the other thing that I think we can do with global health security is, in the aftermath of the West African epidemic, there was a lot of money put to developing research capacity as well. So in Liberia, NIH sent out the largest cohort of Ebola survivors in history, something called PREVAIL, the Partnership for Research on Ebola Virus in Liberia, and it's done its job. There's incredible broader knowledge that's coming in about sort of how, over time, the experience of these survivors occurs, but it's giving us a lot of sort of information about about other diseases, and both epidemic and endemic, because that infrastructure is being used to train the next generation of Liberian researchers, allowing medical students, allowing PIs to sort of put in more research to do work around epidemic viruses, right? Which is good, because, by the way, the budget of PREVAIL is higher than the GDP of Liberia. So we should do that, right? It makes sense, because I think that you're gonna get to a point where this will run out, and we should sort of maximize the diagonal development, as I mentioned earlier. And we do the same thing actually in Uganda, where we are JMedic, which Matiange mentioned, is a US-Ugandan collaboration where we are basically doing sepsis study during peacetime, non-outbreak time, and this is where there are Ugandan PIs who are doing work around common diseases, but they're also being trained around the staff, the nurses, the other ancillary workers are being trained around clinical research to also respond to viral hemorrhagic fevers, and you can see sort of some of the images from our trainings, and so they have that research capacity is being used not just for VHF, not just for global health security, but also for sort of some of the endemic infectious diseases that are there. So I'll end there. I just want to thank all the teams that I work with who have just taught me immensely, both here in the US as well as in Uganda and in Sierra Leone. Thank you so much.
So we have lots of time for questions, and I'll keep the queue. So
Or discussion, doesn't it?
more discussion, yes.
So really great summary and kind of overview of all the stuff that we deal with, which are many, many challenges. It's kind of sobering, actually. I'm really interested in your thoughts on, so during outbreak settings, there are lots of partners internationally who want to get involved.
Yep.
For maybe their own motivations. Right?
Yep.
What about the idea that the recipient country demand of the partners who want to participate to bring multiplex diagnostics, not singly focused diagnostic testing?
Yeah.
Is there any discussion about that? Is there any push from the sort of recipient countries to really ask for more, rather than us just say, you know what, hey, as a community, we should think about giving more?
Yeah. Not that I'm aware of. I mean, there may be behind that, nothing in the public sphere, nothing in the discussions out of WHO, nothing I've heard from colleagues in the field. I know that there are a lot more, the ALIMA, the folks at ALIMA, so right now in DRC, by the way, MSF is pulled out, so the only organizations that are working are Ministry of Health and ALIMA. And ALIMA's ETU, I know, has a few more diagnostics than just the PCR and the gene expert and stuff for Ebola, but I don't know what they have. But yeah, I think that's a fantastic idea. That should be part of the terms of engagement with involvement of WHO or other partners. Okay.
Thank you very much. That was really interesting. And I don't think everything was obvious, at least not to me, so very much appreciated. But sorry if this question is abstract, but I'm a lawyer, so I'm going to go for it. but to what extent is the underlying thrust of this presentation really the global health security frame was maybe a mistake or maybe a necessary evil that we should just leave in the past, right? Because it's just rhetoric, whether we call it security or not, but it has real implications. And you mentioned one of them is the IHR, right, which uses this emergency powers framing, which is not helpful.
Yeah.
And maybe another one is sort of the recent, the Security Council in, I don't remember if it was 2016, sort of lurching into the Ebola space and the UN here.
Yep.
Yeah. So I don't know if you could tell, if I'm writing a piece right now on global health security, and if I were to cite you and suggest moving
We're not
away
doing
from the
Paramount
frame.
rules? Oh my God.
Yeah. No, hypothetically. I'm a lawyer, I like hypos. Would you send me an angry letter if I said you suggest moving away from the global?
No. So I would say it was a necessary evil, right? So here's the issue. I mean, I'm going to put on my policy bit. As you mentioned, I teach a course in human security on this as well. And so one of the basic premises is was it a good idea to begin with, and not just for global health security, but in general, to introduce the security framework into health? And the issues are, it's introducing non-traditional actors on both sides into the discussion. And now it's getting a medicalization of sort of the field, the security field, and vice versa. Because in some instances, that's meant actual involvement of security actors, right? And so the presence of the U.S. Army in Liberia or the British Army, what's sort of the impact of actually involving traditional security actors into the discussion. The other problem is it moves away from a rights-based approach to health. You're now saying we want something out of you. What it's been good for, and I'm sure others will say this around the table who know more about this than I do, is that it's a political impetus. It allows resource-rich countries, those within us that care about it in resource-rich countries, to say, hey, this is in your national security interest to work on it, right? Just to give you an idea, the J-Medic program, and this you cannot quote me on, is funded by Department of Defense, because this is VHF is a huge important part of the national security framework for the U.S. as well. But don't tell them Ebola is really hard to get, by the way. The R-naught for Ebola is like 2, and R-naught for measles is 20. So, but yeah, it's a necessary evil that we need to ensure doesn't become another vertical program that dies on the vine once the funding goes away.
So Liza?
So I love your presentation. In thinking about the institutions that are involved, I've noticed, and maybe I'm wrong, but I've noticed there's a lot more rights-based talk in the WHO and some of the sort of those types of multilateral institutions, and and then move away from that with the global health security agenda, which I saw as sort of an effort to align with where the money is and align with the business case for global health, and sort of put it in the discourse of nation states, and where rights-based discussions, particularly here elsewhere, is going down, or at least not going up. And so if we're thinking about institutional responses, because I love this idea of the sort of the horizontal and the vertical, and that's really looking at leveraging sources of money, who are the institutional players that help to make that happen? Is it Doctors Without Borders? Is it, right? So where is that coming from?
I hope everybody's answer in this room is it's the ministries of health and the sovereign nations, right? I feel like that's where the ask needs to come from. That's where and some countries have been fantastic at it. Nigeria, the CDC, Nigerian CDC, and Chukwu, who is the CDC director there, has done a fantastic role of utilizing global health security to sort of mobilize the rest of their, not just the Nigerian CDC, but also the role of the African CDC that's been created as well.
Just a follow-on. I'm at Emory, and there was a project working with Africa CDC to look at guidelines for what types of, what should a National Public Health Institute look like in different countries and their best practices. And I was amazed at how, the people who are involved in it are amazing, but how underfunded those exercises are, which goes back to your point about best practices. With that, if you were thinking about a priority list of how to increase the horizontal sort of expansion of these different strategies, where would you start? And would it be something like that, or because you have to prioritize, right? Where would you?
One of the things that the success story of more regional sort of management of problems is PAHO, right? PAHO did a fantastic job, and a lot of that was a better maybe regional governance, and they actually had a history of potentially showing success over time of not just building an evidence base, but also distributing information and being a governing body in some ways for public health. And so I would say, you know, if there are success stories, regional success stories, it is bringing together the success stories and strengthening the African CDC. And really giving it that regional power, because right now, yes, there are people on the table, you know, setting the within the global health security agenda. There are people on the table from each of the different countries that are being affected, right? But there's no true research agenda setting or policy agenda setting from the regions that are being affected. As far as you guys may know more than I do about this, but I don't feel that there is, and that's what needs to happen, is better agenda setting from the regions that are being affected. Maybe that's too naive of me to say, but I can get away with it because I'm a doctor.
Well, this is a good segue because Marcelo had a question and
Right.
he just gave the PAHO, I think. So
Thanks.
that's good.
Yeah, sorry, I'm the necessary able to, coming from PAHO and WHO, so that's okay. But that's the question that you had was really a good one. Is the global health security agenda is a necessary evil for whom?
Yeah.
That's the first question.
Yeah.
For whom is the necessary evil, right? Second is I'm so disappointed at you that they didn't talk about governance. And
I
you didn't want
can't
touch it
touch
with a
that.
10-foot I guess that's what I'm going to talk about. But
It's
that's
so
okay.
complicated. It's too complicated for a humble idea.
No, the opposite I would say, but I think that that's where the key of the matter of all this, because that goes with the question and your point of view is, how then can you, based on your experience coming really from more medical perspective, clinical perspective, and yes, you presented a picture that it's more than that, but you didn't, I guess, push enough to the development agenda.
Yeah.
You combine the SDG agenda with the global health agenda, global health security agenda, but I don't think it goes far enough to say, okay, and what is the development agenda in this picture? And I think that that's really the next step, right? I mean, that's
Yeah.
what we're talking, because here we are still at the health services level. And even though in your last statement, in last point, you talk about public health, there is even, like a little bit what we mentioned is about development, right?
Yeah.
So the picture of development, which is predetermined, how do you see it?
I think if you're looking at just ROI, return on investment, I think everybody would agree that if we could just fix the social determinants of health, we would save a lot more lives, right? So, but you're right. But then again, you go to, as there's a saying in Boston, you go to Meineke, you get a muffler, right? You came to a doctor, that's going to be my solution. It's more on
great.
the.
That's what I'm saying, your point of view, yeah.
I think that there are. Who am I to come up with that would be my first term. I think there are more qualified people around the table to do that. I think in my point of view, though, the majority of my work is affected by things like climate change and sort of our push to get access to proteins, our push to sort of make a survival, at the border is what I'm seeing for a lot of populations that I'm sort of working with. It has to be more systemic things like clean water. If I were to put money anywhere, if you gave me limited amounts of money and they said just put it in one sector, it would probably be on social determinants of clean water.
Right, but
good
where
roads,
do you
possibly.
see the link?
Oh.
Coming from health services. and
Right,
coming
right,
from
right.
that, where do you see the link? So it's visible, it is real.
Yeah.
You get it as a clinician as
Yeah.
well,
Well, first and foremost, the only reason all these emerging infectious diseases are coming up, like I said, is because of all the damage we've done to the environment, right? It's very real, it's very forefront in my mind about why we're facing these issues. Even talk about the rise in population. Rise in population leads to greater increases in demands for protein. The protein that we seek the most, actually, as a growing population is poultry, because it's cheaper by unit, people are not going for beef, it's bigger, and the largest urban areas are now in Latin America and Africa, that's where it's growing, right? By the way, biggest losses of wetlands, we've already lost everything in the US we're ever gonna lose, but Asia is losing huge amount of wetlands, and you're seeing this idea of avian influenza. No surprise that my field is now interacting with all the same pressures of population and climate change that we're talking about. So I see it in that perspective, is that I see it more from preventative side as well as mitigation. How do we make it so that the development that we pursue, one element of this is building healthier cities. So when there are, respiratory infectious diseases and things like that, we can manage them more effectively. How do we bring resilience into healthcare systems into large cities as well as into smaller communities? I know that's not the answer you were looking for, not specific enough, but those are how they interact in my brain as a health services person more than anything else.
So we have a very long queue, and so the moderator is now saying no follow-up questions. We have 8 people on the queue.
By the way, ask each other questions. Feel free.
And so, Tweet.
So I would argue that the global health security is a wrong framework to look at this issue. I think it has increased the feelings of others and paranoia and xenophobia and all of that. So I think we need to move away from that, that framework.
I would probably, yes, I agree with you. I think we needed it to prioritize the funding, but I mean, I agree with you. For all the reasons that I mentioned, yes.
So what's the other framework that we should be looking at? Human rights doesn't work. Down from there is what?
I would say up from there, not down.
Well, okay. Well, to me, that's the
We're going to develop the framework today. So Scott is on the queue.
Well, I thought this was a great presentation, really eye-opening, and I better not say more because we have to get to questions. But otherwise, I would praise you for a few more lines. I teach my students about the global health security agenda and the sustainable development goals. We talk about, they're easy to insult for a lot of reasons, but they can be useful for mobilization of resources. But the way you presented to me, the phrase that came into my mind was, compared to what you suggest we do with the money, with what they're doing, was like the neglect of the possible and the pursuit of the hopeless. Like, they're not going to accomplish all the stuff on those agendas, we know that, and yet investment in diagnostic techniques and buildings, bottom-up responses would probably actually do a lot of good and lead to other things. So, you clearly bring a strong systems perspective to this, which is supposedly what it underlies these other things too. But really, they're just the wrong systems dealing with the wrong things. They're kind of fake systems approaches, in where they're organizing systems that aren't really designed to solve the problem.
Yeah.
So how do we? What's your thought about how we get WHO and other people and ourselves to maybe give less respect to these big frameworks and start to talk more about actually doing things that will make a difference in the lives of people in countries and cities?
Yeah. Well, WHO, I mean, again, I'm not telling you anything you don't already know. What, 25% of the WHO budget is actually something they can manage. Everything else is earmarked, right? Something crazy like that. And so they don't have a lot of, it's interesting, that's the body that we go to for all new threats and developing threats, and they have their arms tied by funding, by earmarking, right? Maybe one of the first things we do is to, maybe one of the first things we do is to let WHO actually be the organization with the freedom and the funding to be able to set a truly representative agenda, global agenda, that comes from not just the biggest funders, but also from other countries as well. I think it comes down to governance. I'm hesitant to say how else, because isn't that part of the problem, that we've always said, here's the solution? And even with joint external evaluations, right? You have these external evaluators come in, and I talked to some of the evaluators at this meeting, and I said, how does that process go? And it was very much like who's allowed at the table versus not allowed at the table in the countries that they go to, right? And so I was like, how much is a civil society really around the table in helping you evaluate if the JEE that you're doing is truly representative of what's happening or not, right? The reason I don't want to say anything is because I think ideally it should be more driven by good governance. And so that question for me always comes down to governance. And I say that because I wrote my master's thesis on governance, which is why I've dropped it. 16 years ago, I decided I couldn't do this, and I'm not doing it anymore. But there are very few organizations that actually help with public health governance development. Do you guys know of any organizations that work on public health governance development? The only one that I can think of in my field, narrow field, is Clinton Health Initiative. Chai was actually working with the Liberian government doing sort of accompaniment, if you will, during the Ebola outbreak to provide feedback and structure to how they organize their response to the Ebola outbreak. Are there others I am missing?
Somewhat.
IAMFI? Yeah, I mean, there's a IAMFI, there's a Partners in Public Health Institutes.
Yeah. And are they providing the individual like ministries of health and governance with sort of the governance
That's what this
development
project
stuff?
was with Africa
That
CDC.
is what it is.
It was, they were partnering with Africa CDC to try and develop best practices
That's
for whether
great.
national, how do you form it? What is the, what would your statute look like?
Yeah.
And which is tricky because
Yeah.
it's, each country is so different.
Right.
Yeah, they're getting at that.
That's the way that I would go. Like, I feel like that's where truly equitable sort of agendas come from, is actually empowering governance in those countries and then allowing a truly representative agenda for policy come through.
I guess WHO does public health governance as well. However,
Marcelo.
it doesn't come from infectious diseases. That's the problem, that we are as silos as really
Yeah.
the public health world is. So bottom line, if you go from the infectious disease unit or program, they will never talk to the guy that really, or the person that really does public health governance.
Yeah.
So
Sorry,
bottom line,
so
yes, you can do it.
I have 5
It's
people
like-
on the queue, and we're gonna get their questions up, and I'm gonna be a dictator. So here we go. So Renee, you're gonna ask her question, and then Eric, and then Moses, and then Don, and then Mary, and then that's it. And then you're gonna respond.
Oh my goodness.
No, there's another Mari.
Mary behind you.
All right, so we'll collect these questions, and then you'll respond and
Okay.
ask, and then we'll
All right,
also have
yeah.
the rest of the day to continue conversation.
So I guess mine is more in the nature of a comment about this problem of the issues presented by the security frame. Because I'm not even teaching a health law class this semester, I'm teaching an administrative law class, but I have a student in the class who was in the Army in Afghanistan and Iraq. And part of his unit was deployed to distribute vaccines, right? Non-starter with the population.
Yep.
So many people were suspicious of that source of the public health initiative, and and I take him at his word that there was it was intended to be kind of this good thing that the military was doing, and it's just the wrong frame to have any kind of really big impact, I think.
Eric? You're in the queue, so Eric, you're in the queue to ask.
Right, exactly. No, yeah, no, I know, right. Yeah, no, I know. It's part of that whole, yeah.
I either one of, sorry, go ahead.
Before she responds, I'm actually going to collect everybody's questions and comments, and then she's gonna respond. I'm trying here, so Eric.
Thanks. This actually relates to a great point you made about how the middle of an Ebola outbreak with spacesuits is not the time you build community trust. So sort of two related questions. One, do you know whether anyone is really thinking about, so how to do that, not then? And then just this one possible way is, you talked a lot about sort of the last mile problem as sort of diagnostic surveillance, but also trust-wise. Like, is a real way to build trust when the epidemic happens, building good, strong, community-based health systems.
That's what I think.
And that's,
Yeah, I think that's the only way that you're not going to always end up in that issue, because without that last mile issue, you're not getting people early, but then you're also reaching out to them when you're coming in with your army of, infectious diseases, docs, and astronauts. It's,
Moses?
So I'm going to put my military cap on. So
by the way, I love the DoD. They pay part of my salary.
looking at these outbreaks in these regions, it's a political issue. And I know people would say, well, it's an infectious disease. Inevitably, you're going into a political climate. And I think the global security framework is it's based on realism and situational awareness. I mean, that's really where it comes from. And in our ideal world, yeah, so doctors go in there, everyone's going to care, and everyone cooperates. People forget about their political differences, but that's not realistic. So, and I think the security element, it's really important because it allows those two warring factions to sort of at least work together in that moment. And I think that's really, really critical. You know, if you look at, because most of these governments, you know, people have this perception that everyone sort of agreed with that government that's in place at that time, but that's not what happens. That never happens in any of these countries. So the government that's in power, that's controlling the Ministry of Health, doesn't necessarily represent those individuals in that region that are affected by Ebola.
Yep.
So if you're saying they're going to be in charge and stand up that response to respond to their political adversaries, that's not realistic. So I think that the global health security, yes, it has its problem. Agenda has its problem, but getting rid of it, I think it doesn't really address the situation that people are encountering in those regions.
Yeah, I think my only, I can comment, right? My only problem with it is that it is basically, well, you said it right, that they're not all going to agree and follow to what? To an agenda that was set beforehand by somebody else, right? I mean, and so that is a global north agenda, and which is fine. I agree with you that there needs to be some changes, that we need to ensure that there is a certain amount of safeguards in the world so we don't end up with $490 billion worth of damage. But remember what I said was I think it's a necessary evil. My only argument is we need to now milk it for all it's worth and make sure that we get what we want out of it now that the actual funding is there in the right places, so that when it goes away, which you know it will, unless there is more recognition on the political level for our own governments and other governments, that we actually have some sustainable change for the real problems that would help not just for the issues raised by the GHSA, but for everything else in my small infectious diseases field. Okay. Now, do you want to
Yeah, you gave a terrific discussion on the barriers, the psychological barriers to people not wanting to enter the healthcare system. I was curious whether or not there's another problem, that the notions of contagious infectious diseases are not commonly accepted in many of these populations, that it's more of an animist or that the cause of the disease are not one-to-one person, the notion you need to put up physical barriers. Is that been looked at in any detail, and should we modify our procedures in any way to accommodate the more indigenous understandings?
I would say it's not so uniform. I think the understandings are completely different by what subsection of populations you're talking about, even within one region, right? I'm not sure if I'm going to answer your question right with this, but in the first ETU I worked in, I definitely had to there were patients that I really had to sort of go through hey, no, you don't want to come into bodily contact with this, and this is why. I know you're trying to take care of your grandmother, but here's how you want to do it. I know you're sick too, but you're both a suspect, maybe you don't have it, And then I would see other people in that ETU there was, remember this 16-year-old kid who was in college who was with it, he knew, what was going on and was I don't want to be in the suspect ward, can you hide? And I couldn't find him for a day and a half to give him his results, which by the way, he was negative, he had malaria, and he was hiding in a closet. So he understood very well about how, infectious diseases, contagions work. I think it's a combination of, so for the communities that really yes, you're right, there probably is not as much of an understanding of germ theory or a certain acceptance of infectious diseases as part of something greater than just something that was a result of activities or environment or things like that. But I think some of it is also distrust in the knowledge that we bring. I don't know if you saw the recent study from DRC, 1 in 4 people don't believe Ebola is real. And I don't think that's just a lack of knowledge, it's a lack of trust, And so maybe what you mean in terms of change of our approach, I don't know what that change is, but I think we probably need to change that in some way to increase that approach. Not just there, but here too. Look at what's happening. Lyndall and I were having this conversation. I said, oh my God, this infectious diseases aspects of the world. But we've made great strides, we have all these antibiotics, and I was like, well, and we're going to lose those. And we made all these vaccines, but oh, right, nobody's actually taking the vaccines anymore. I know.
A lot of people are taking other parts of the world.
Right. So the last question, Mari, and then
So this is fantastic, and thank you very much. I'm a historian by profession, and so I actually, a lot of what you're talking about syncs with the way that I teach my undergraduates the history of global health, and also health practice and public health policy in an African context, so I specialize in Eastern Africa. One of the things that I just wanted to mention, so to tag on Don's question, I would say that there are practitioners and professionals who are thinking about those questions of nosologies and diagnostics, understandings of disease, but they are primarily historians and anthropologists whose research agendas and research output are not often as compatible with
the silos.
Despite the heroic efforts of a lot of anthropologists of Western Africa in 2014, 2015 to integrate and to try to talk about local context and politics. So they're there, but I think the way that they interact is difficult.
Yeah.
But actually the reason I raised my hand to ask a question was just this question of capacity building and the sort of researcher. You mentioned the pilot project in Uganda that's trying to teach Ugandan practitioners better diagnostic capacities, sort of increase capacity building. I'm working on a new project on the history of NTDs over time. And one of the things we see with that is an emphasis early on rapid diagnostic tests for difficult diseases and ways to treat that are more innovative, that are easier to deliver. And so I'm curious if you, or I would love to talk to you later since we have no more time. I'm just curious about what sort of takeaways you have on good models for collaboration and training and increasing capacity in those individual contexts. Mm-hmm. And also, I would love to hear what you think of the question of portability or scalability. Whether these are portable lessons, is portability the right question, or do we need to be thinking about how these things work in country with different ministries of health in different contexts? I mean, this is a massive topic, but that's some of the stuff that I was just thinking about.
Yeah, and my purpose of actually showing the J-Medic thing was not to say it is one model, right? I'll ask you 5 years from now. This project has been going on for about 3.5 years or so, and it's great. Right now there's a DRC outbreak, so there is, all the work we've been doing in the last 3.5 years is finally coming to a payoff, because there is this capacity. If anybody comes into Fort Portal District or across the border, the MOH is sort of looking at us as potentially one of the first places that somebody gets admitted, because it's a ready-made capacity, right? I think there are definitely lessons. I do think there are probably context-specific challenges, and some of those are political, and so I don't think the same answer probably works everywhere, because probably not everybody has as a good relationship with DoD, for example, as Uganda does, right, with US DoD. And so I think the basic lessons of an exercise like this, or the exercise of Prevail using its resources, is we need to stop training mid-level folks. We need to empower leaders in a lot of these folks, right? So the biggest thing that I saw in Liberia was, it's funny, Prevail is this immense amount of research, and majority of the training programs that have been put into place before, as Prevail was ramping up, was training mid-level research technicians who would get 6 months of training, and then somebody from the US would need to come back 6 months later to train them again. Oh, and by the way, even if there was no job, they would just leave. That's how it worked. Why does a US person still need to come in 6 months later? Why can't we just build Liberian PIs? And it's both a supply and a demand issue, right? It's not just we need to create them, we need a reason for them to stay, we need jobs and things like that. And so if I were to say there's one common thing that can be taken away, it's probably to build local leadership. I don't think that's anything novel. Again, I'm stating the obvious. But I am excited to hear about what you guys are working on. I gotta say, we were behind the ball in West Africa with medical anthropology. Like a lot. and by the time that actually kicked into gear, you could tell the difference in the community response to the Ebola response. Yeah.
So please join me in thanking.
So we're going to be starting our next section of the workshop today. My name is Dr. Margie Luisius. I am an instructor of medicine at Harvard Medical School and an allergist immunologist at Brigham and Women's Hospital. I also have research interests in implementation science and also community-based work to resolve disparities in children with asthma. So I'm going to be the moderator for our panel, and I'm going to do a brief introduction of each of our panelists. The way we're going to be doing this panel is that there's going to be 2 presentations. Each presentation is going to be followed by a 15-minute Q&A. Okay, and so from the lively energy that I saw earlier, I know we're gonna have to rein you guys in. I'll try the best way I can with that. But I'll introduce our first panelist who will be giving a brief presentation, Dr. Bowie. So she is an infectious disease physician, an internal medicine physician, and has really focused her career on social determinants of health and refugee health. She's a director of travel medicine. Director of the Global Health Track of Internal Medicine Residency and the Social Medicine Fellowship here at University of Pittsburgh. And the second panelist, I'll actually just bring her up as well, so that I don't have to do a second introduction. Dr. Hadi is an infectious disease physician and has focused her care on the care of refugees and immigrants, and is a founding member of the North American Society of Refugee Healthcare Providers. And also Dr. Veldkamp, who will also be part of the panel as well, and aiding in with the presentation, is also an infectious disease physician and has and is also the director of the Travel Medicine Clinic here and the director of education and infectious diseases. But you could again look at their bios for more details about what they've done in their past. Okay, Dr. Bowie.
So you can hear me okay? I don't think I need a microphone. So I apologize that it's so clinically heavy. You got all these physicians which we shouldn't be here, so I'm sorry about that. I appreciate you inviting us. So we're gonna focus, I'm gonna try to go through the 10 slides very quickly, because I think the discussion is much better than what I have to say at all. So bear with me, okay? So we're gonna focus on health care, which is different than health. And as you know, healthcare is make up probably in terms of only 10% of the impact, the outcome. So that's why I'm not sure why we're here, because, so anyway, let's go through real quick to that. The Institute for Health Metrics and Evaluation have used findings from the Global Burden of Disease study and designated 32 conditions where death should not occur in the presence of effective medical care. So they came up with this HAQ index, which is a summary measure to evaluate effectiveness of health service delivery. So the causes represent a wide range, and I'm sorry you can't see very well, but infectious causes only in the top box there, and they range from mostly vaccine preventable diseases, some infections, maternal child health. And the index is divided into, its scale is from 0 to 100, but they divide it into decile. So this first ever global study finds massive inequity to access and quality of healthcare among and within countries. So if you get a group of kindergarten students and ask them to color the world map, I think this looks really nice. This is very good, but when we talk about equity, that's not good. Purple is the top decile, and the dark deep red is the lowest decile. And so you can see the highest is most European countries, Canada, New Zealand, Japan. We are in the 9th decile, and of course at the bottom groups is many countries in sub-Saharan Africa. So, well, the good news is that from 1990 to 2015, nearly all countries and territories saw their HAQ index value improve. But the difference between the highest and lowest HAQ index has grown. So disparities is getting worse, not better. And subnational inequities were particularly pronounced in China, India, Mexico, and in the US as well. Well, at least Pennsylvania is blue. Mississippi is always last, just so you know, if you don't guess that already. Okay. And if you look at the bottom countries in terms of HAQ index, there's actually a lot of variation among different conditions and injuries. So even, we talk about DRC or Central African Republics, they're actually doing pretty well in terms of vaccine preventable diseases, some infections, and some cancer. So I'm going to bring just very quickly the local context. This is Allegheny County on the county rankings in terms of clinical care. So we're not bad, but we're not the best. We have ways more to go. The only thing I can compare to for a country like Malawi, which is the same size of Pennsylvania with 1.5 more populations in terms of population size. Look at the mental health providers, okay? We complain here in Allegheny County that we don't have enough mental health providers, but in Malawi, there's one mental health provider. I'm not even talking about psychiatrists. One mental health provider for 4.5 million people. So the disparity is just mind-boggling. Okay. I just bring a little more of the local context. This is from the racial disparity studies in Pennsylvania that was published a couple years ago. So look at HIV, and the top graph is for African Americans, the bottom graph is for white. We have done a good job in terms of decreasing mortality among African Americans, but the number of deaths for African Americans is still 10 times that of whites. Okay. Why? I'm not gonna focus on diagnostic access because I think our previous speaker have spent a lot of time on that already. But we forgot that this is important. So people only recently have focused on this, and this is just a mobile unit that have been rolled out by AMPATH in Kenya. And we mentioned things like Gene Expert and point of care. We need to have, to develop and promote more of these tools in low resource setting in order to even to decrease the disparities a little bit. Okay, and information system, that's the other, I'm just focused on mainly these two because I think there's underinvestment in them. Health information is so critical. Many of these places are not on the grid, and cellular data is very spotty. So we have to invest in solar, in battery, and open source EMR. And these systems have had to be focused on public health, on patient care, and not for billing. Many of the time we model these systems after in the US, and EMR in the US exists for billing purposes. We need to know that, so, okay. So this is the last slide. This is the WHO building blocks, right? And I'm gonna add in there governance, ethics, and leadership after this researcher from Malawi, because I think he believed that we're missing the ethics part, looking at corruptions in healthcare and so on. But really, my question for you is, what should be the role of U.S. academic health center in supporting health systems, right, in low middle income countries? We need like Mr. Romoff to be here, or Dean Levine, people who could really answer these questions, right? We are all kind of the middleman at this point, right? I'm sorry, but more middleman. Well, I'm going nowhere. What is our obligation in terms of addressing health and inequities locally and globally? Many people said we should only focus locally where we are and not worrying about what's happened elsewhere. And what about our leadership as academic health center in terms of providing ethics to global health development? Finish. I got them.
And now we could go to questions from the audience with that. I think you set that up nicely.
I want to start with sort of a comment and
Sure.
then maybe a question from there. You asked what the role of academic health centers might be. And I just want to use as an example a program not started by an academic health center, but something I as an academic participate in. This is a program in Karnataka State in southern India that is run by Dr. Arun Kumar at Manipal University. It is an acute febrile illness project. So the goal of this project was to develop diagnostics for use for all kinds of different things. It's a massive array of diagnostic modalities that they're rolling out. And they have, since 2014 in the inception of this program, enrolled over 40,000 patients, and they're categorizing them: fever with diarrhea, fever with respiratory symptoms, fever with neurologic symptoms. And they're doing this huge cadre of tests, and it's largely supported by CDC efforts. But I was able to go there and train some of the graduate students, just a lowly assistant professor, right? Training some graduate students on how to do flow cytometry on some of these patient samples. And they were able to use that system, that is this massive diagnostic system that's in place in a low to middle income country, to identify the first cases of Nipah virus that occurred in Karnataka State. I don't know if this hit anyone's radar. Last March, I think it was. The first ever Nipah virus outbreak occurred in that state, and they knew about it and and we're able to respond to it in limited spread because of this diagnostic platform that Dr. Arun Kumar has established. So while I don't, like you say, I'm a middleman, I'm not somebody who can, throw a bunch of money and start a program. I think that's really our middle person role, is to provide support to whatever efforts are ongoing that are already in place, and to educate the next generation so they can do more than they could have done otherwise.
I agree, but is that enough?
Of course not.
Right, so we need to do more. And what is it that we can do more?
The question, he had a question in the back.
The issue of developing diagnostic for several of those neglected diseases is a constant debate, and it has innumerous challenges. One is how to validate and determine the performance of those tests. This is a constant problem. There is not very good panels of samples to validate that, and that's one point. So the quality of a lot of those tests are very poor. I'm not talking about flow cytometry, genomes. I'm talking about regular ELISA, lateral flow, this kind of point-of-care things. That's one. Two is that there's not much money to make in terms of diagnostic. If you look around, like any of those diagnosed for dengue, Zika, whatever, a lot of those diseases are bought at very bottom line price. And that's a problem. There's very lack of incentive to invest and distribute or whatever in this test. So the portion of validation and development is really poor. The third issue is that although the cost of the kit to whoever manufacturer is low, again, I will repeat the sentence that was said here a couple of times, the middleman or middlewoman, that costs a lot of money. You buy that test for, I don't know, $2, $3, $5, whatever, and sell the result for $100, like if it is a private lab. So this is a big cost in the middle, like the procedural part. Third, like after that, a lot of those tests, it's difficult for some, it's still difficult for many clinicians to interpret. And I can see that very obviously in the situation of diagnosing Zika during pregnancy. You have two issues to deal with. You don't need only to know if the woman have been exposed to Zika or not. You need to know when. You need to know if it was during the pregnancy or not. That in early on the gestation, it would be helpful actually if you knew if the woman has signs of a previous exposure that would indicate that perhaps she has some level of immunity that could generate some, let's say, mental relief in terms of stress. And finally, I think one direction is necessarily not to develop perfect, optimal assays for diagnostic in a hospital. I think it would be extremely beneficial if we had over-the-counter rapid tests at low cost for the population to use that as their convenience. And if they feel they're at risk and have the signs, then they would go. So that could be a step forward as well. And because you could have mass production and all this, it could become more interesting from the business point of view as well. So if I were to push in some direction, it would be in this.
Excuse me, one test that I thought was actually beautifully employed is the malaria test, where I think the WHO provided adequate malaria treatments in the right kind of combination, but only if the malaria test had came along, but it was positive. And the test, as you said, there's no absolute 100% correct one, but at least a lot of people who had fever would not have empirically be treated with the wrong treatment. And so I think you pick and choose a different test and a different sensitivity, but that I thought was a great example of a good testing strategy.
I'm going to keep it brief because I think everybody's sick of hearing from me. But I want to address the ethics part of your challenge. And I think that's an important one and one that we've ignored way too long as academic centers. So one of my colleagues is at the Needle at BU is Jerry Cush, who's the prior head of Fogarty. You might know him as well. And so Jerry said something at a meeting recently that just was so poignant. He said, we really need to make equitable academic partnerships, but not like we used to 25 years ago, like actual equitable academic partnerships, right? And I think one of the things that we need to do as U.S. academic health centers is really try to be a bit more ethical in the way that we have been partnering with resource-limited setting universities. Really try to, and the trouble is, and so that's one, we need to be a bit more ethical, but the second is the U.S. academic health and academic universities need to reward the kind of work that, Anita's doing or things like that. It doesn't count towards a promotion, right? So what does that lead to? It leads to what happened in Sierra Leone, which, if you might have seen, there was a wonderful article from Maren McKenna that she said the colonialists are coming for blood, literally, right? Public Health England basically admitted to taking hundreds and hundreds of Ebola samples of the genomics and genetics of the population they were collected with, and they're going to do research on it, and their professors are going to get credit because the only thing that matters in our system is publications and grant money. And until we only reward that and not the kind of stuff that we've talked about, I don't think that there's limits to how much U.S. academic health centers can do.
I think a follow-up that we were talking about here before the panel was how for a lot of us who do go abroad, we're doing it on our vacation time. We're not necessarily getting protected time to go, we're actually getting a reduction in our salary to actually go and do that. So really, what you were mentioning before in the beginning of your talk about having the leadership, it has to come from the leadership down and saying, okay, if we're really gonna have a global health impact, we need to put the money out there to support our faculty to be able to do this, and then doing it in a colonialism type of way and making it more equitable, right? So we're actually going to move on to the second presentation.
Good morning. I'm Christiana Hadi. I'm an infectious disease physician in Pittsburgh, and I get to talk about my favorite subject, that's bugs. This slide, This slide shows you the four main groups of organisms that we worried about in infectious diseases. And on the left lower corner, you see an electron micrograph of TB. So this is Mycobacterium tuberculosis. It's spread through the air, and basically you get it from another person. There's no vector, there's no animal involved, no other host. Humans give it to other humans, and it is not very difficult to spread. The second picture here, this is a reconstruction of the measles virus. And you probably have heard that there's currently a measles outbreak, actually multiple outbreaks in the US, 7 outbreaks in different states. And the cases of measles this year have reached 460, which is the highest number in quite a few years. The third organism right here, this is actually the fungus that was causing the outbreak in 2012, where infected steroids were injected for people who had back pain or arthritis, and people developed fungal meningitis, and multiple people actually died from that. So this was difficult to transmit because it's actually an environmental organism, but it was in a medium that then was injected in people thinking, this medication would help them, but it unfortunately was contaminated. And this bunch over here, that's Ascaris. This was obtained from a surgery from a young child. The child had bowel obstruction and underwent surgery for that. This is the adult worm of the parasite, and the way the child got this infection really is by eating contaminated food. there were fertilized eggs and the food, it was contaminated, and that's how the child got this disease. You probably think this is not very common, but it's not very common in America, in the United States, but approximately 1 billion people in the world, so 1 out of 6 is infected with that. So sometimes organisms, so I just made this point with these different groups that you have an idea of, the broad spectrum of infectious agents, but also the way they're transmitted in a different way. So sometimes the germs actually use airplanes to travel and get all over the world pretty quickly. And this is, if we reflect back, the 2002-2003 outbreak of SARS, the severe acute respiratory syndrome, which started in China. And this map is just showing you how quickly this virus spread, mostly via air travel, but I would like to just summarize the outbreak very briefly. So it started with an index patient here in November 2002. And this person had atypical pneumonia and was admitted to the hospital. This was reported to the WHO, but at this point, nobody really knew that this was something new and a new virus. In the next 3 months, about 300 cases happened in the same region and 5 individuals died. So this is not very unusual, the case mortality rate there, but the people who died were young, healthy individuals or children, so that makes it unusual. Things changed quickly when one of the doctors who was taking care of the patients here in China traveled to Hong Kong for a family event, and he checked into a hotel, the Metropole Hotel, on February 21st. Then he went shopping and spent time with his family. The very next day he went to the emergency room and ended up in the ICU, was intubated quickly and actually passed away 10 days later. During that time, during the one day that he had to spend time shopping and spend with his family, he infected multiple family members, and his hospital stay resulted in 50 infections. So this shows that this can be very contagious, and the spread is it's very effectively spread. Over the next 2 to 3 months, the virus spread to Canada, to Germany. It went to, the US reported cases in March. So the virus spread very, very fast, and it resulted in a travel advisory by the WHO, which is very rare. But that happened in March 2003. The virus was identified at the end of March, and the outbreak actually came to an end in July. So July 2003 were the last cases reported, and things more or less went back to normal. An enormous amount of resources and research went into this, finding the virus quickly and finding out how it spread and stopping the outbreak successfully. So since we know so much about how organisms are spread and treated and outbreaks prevented, why do we still have maps like this? And this is very much in conjunction to our previous speakers, but this is a map of the incidence of tuberculosis. So those are new cases. And the lighter the color, the less cases. If the color is darker, there are more cases. So you see the United States, we have less than 10 cases per 100,000 every year. And you see over here in Southern Africa, they have more than 500,000 cases per 100,000. I would like to show you similar information in a different map. So this is actually a program called World Mapper, and it resizes the territories or countries according to the number of cases. I think this is a fantastic visual reflection of what we're dealing with. So it's a little bit older data, but that's the most recent they had on TB. Unfortunately, not much has changed. But you can see the United States is basically shriveled up because we have so little TB. We have a pretty good handle on it. However, in Southeastern Asia, China, India, and also the whole continent of Africa, there is a lot of TB. When we look at a different disease, this is HIV prevalence in individuals 15 to 49 for the year 2013. And you can see the continent of Africa really predominates this map. Obviously, HIV has spread all over the world, but the vast majority of the burden of the disease is in Africa. So why is this? Why do we have a map that's so distorted? And this list is not comprehensive, and it's certainly not in order of priorities, but those are some of the questions that we should ask ourselves. What are the different factors that play a role, and what are the things that actually can be done to address this disparity? Is it the climate? Is it the presence of vectors like mosquitoes? Is it the income, public health infrastructure, the number of physicians and nurses? Is it the access to clean water, electricity, or vaccines? And what are those problems? Which one could have the biggest impact, and which one is solvable, and which one is not? I could argue maybe all of them could be somehow solvable, but we should pick our battles. Now, does this apply to infectious diseases only? Certainly not. This map shows the prevalence of diabetes, adults with diabetes, so this is mostly type 2 diabetes. And you can see a very large proportion in China and India, actually in the United States, Mexico, and Brazil have the highest absolute number of adult individuals with diabetes. In contrast to that, and this is my last slide, is actually the expenditure per year per person with diabetes. And the map looks totally different. If I want to go back one more time, this is where the cases are, this is where the money is being spent. The highest rate actually is in Norway, so all the way up here, where the country spends $13,000 per year per case of diabetes. Another one is obviously the US, you see this right here, and it's $12,000 per case per case per year. The smallest amount of money is spent in the Central African Republic and Myanmar, and this is less than $40 a year per patient with diabetes. So I think I have given you enough food for thought and ready for questions.
Dr. Hadi, I just wanted you for the group to clarify, since not everyone's a physician in the room, specifically about the diabetes and which type we're talking about, so they can understand how you would deal with that.
Thank you. So there are two types of diabetes. The first type 1 diabetes is usually diagnosed in children or adolescents, and there's a genetic predisposition, but it can have other causes as well, and that's insulin-dependent diabetes. Type 2 diabetes is the one that's associated with metabolic syndrome and obesity. Often it develops later in life, and occasionally can be treated with weight loss and diet change and lifestyle changes, but sometimes people end up needing medication there as well.
Any questions from the audience? No?
Do you think that there's a way to show if the amount spent by country is like having like an equivalent effect? Because I know if America's super inflated, that might just because we're really arbitrarily expensive compared to other countries. So what's your opinion on that?
Yeah, I think you have an excellent point. Healthcare in America is extremely expensive, but not necessarily effective. I think we know that. Unfortunately, the map doesn't reflect that at all, but that's a very good point. Yeah, definitely.
I think the mortality rates and the infant mortality will reflect that some parts of the United States are better than anywhere in the world, and some parts of the United States are worse than a lot of low and middle income countries. And it's the money gets spent very unequally, and it's unequally effective.
I mean, it's a public health question, right? It's so expensive because we spend it on clinical care versus public health. We should look at sugar tax, look at how processed food and marketed, things like that.
Yeah, I think that's a good point, actually. The children, you bring this up. Now, actually, for the very first time, we diagnose type 2 diabetes in children and adolescents because of the food they eat and the incidence of obesity at that age. That's a new development in the last few years, and I think the pediatricians are very worried about that.
Renee?
Well, that's where, if we're talking about things that we can all do here, that's where law can come in. Because one of the barriers to these things, well, first of all, there's the political problem of the lobbying by these, food interests, right, that prevent good public health policies around these things. But that's where lawyers could come in to try to make information and try to really develop legal theories that would make it possible to sustain a sugar tax or, some of these other things that actually might help direct consumption in different directions.
What about the right of clean water? To me,
Right.
So if we think about cholera, a lot of other problems, if people would have access to clean water, that may be in the human rights somewhere, but where can lawyers be helpful in the world, sort of making that a more effective policy?
You asking me?
That was a question,
She's like me. Well, this is another thing where the direction of the discourse in our country seems to have changed in a not a good direction. So, but I think, I guess one of the things I always see in all of these problems is education, right? Lack of science education, lack of education about how the government works and how policies are made. And I think that's a tremendous barrier to solving some of these problems, because then people are susceptible to, false information, misinformation about what is the cause and what are the solutions to some of these issues that they're facing. I know that's a really
trust in institutions.
That's right. That's exactly right. Yeah.
Lisa?
So I thought the maps, the visuals, very powerful. And I wondered how, if they go back in time, so it would be interesting to see how those patterns change over time. And that would get at this idea of where, have there been interventions, and could you visualize the impact of interventions in a way that would make more salient some of the, what works, what doesn't, where do you start, and also the connectivity, like what's the role of the connectivity in those patterns, where does it matter, where does it not?
Yeah.
There's this, I think a Swedish presenter, I think he just passed away, Rosling, most of you may have seen his dynamic videos of
Hans,
the bubbles. And his argument was always that with the decreased poverty rates, that a lot of things improve, even although the numbers look awful. But those are very dynamic and span a couple of decades. They're wonderful to watch.
That's what I was thinking of, yeah.
You can go ahead.
I was wondering what your thoughts were on comorbidities compared with, how like diabetes can be somewhat, compromising, and how that affects low middle income countries that are improving their socioeconomic status, but now they're dealing with this other problem. So, what are your thoughts on that?
So the question would be how, for instance, diabetes would maybe predispose those people to infections that may have been eradicated otherwise. Yeah, certainly diabetes or HIV would be another very good example. HIV and TB, the combination is still a very deadly combination of diseases. Even though we have good and effective treatment for both conditions, it is not available for many people, and there are complications with that treatment. But I think it's worrisome to all of us that diabetes really seems to be an epidemic, and the numbers have been getting worse, and now we have younger people with that diagnosis. And yes, they're predisposed not only to infections, but other diseases like cancer and heart disease, needing dialysis and things like that might not be available in the country.
I mean, to address both infections and non-infectious cause, double, triple, global burden disease, whatever you want to name it, I think there's mainly two things. One is if you strengthen the health system, then it will work for all the conditions and injuries, and then you address social determinants of health. I mean, it's simple to say. I know it's a lot more difficult to implement, scale up, whatnot, but we know what it takes. We just don't have the will, the power to do it.
Because I think even what you brought up in your first presentation about even the partnership with the academic medical centers, I think if we had those stronger partnerships to build a workforce, to also build infrastructure in the actual health systems in those low-income countries, we could then take care of those chronic medical conditions. Because I can think of times, and probably you guys can too, when you're on the front line managing the patient as a physician, and you're thinking, if I was in America, I would probably be able to save this patient because I would have the resources of an intensive care unit. I would have the resources of a follow-up with clinic. I would have the labs. I would have all those things. But in that setting, you don't have any of that. So,
well, I hope they never come to me.
Right.
Because if they have a good public health infrastructure, maybe they never
Right, they
got
never do
sick
come.
in the first place.
Yeah, so it's tough. It's really tough.
I wonder how those maps that you have on the inflatable maps, as they call it, it would look if you do it instead of country level as a geographic unit, you do it at the very municipality level geographic unit, because then you see the US with hills and valleys, and then you will see different countries, and I think that gives us the really realistic picture. Countries to say, in Latin America, for example, Brazil is huge, but the Amazon and Sao Paulo is like, saying Mississippi and New York.
Mm-hmm.
So I think that will really make the picture much more powerful.
Yeah.
Even within the United States or Canada, you can see that picture as well.
Actually, the program was redone in 2018, and they're creating more maps and adding more details. But I think that's a really good point, because it's a lot of diversity in our own country here, and certainly, we go from an academic medical center where we can have an MRI and PCR done to sometimes volunteering in a clinic where people walk in without health insurance, and you still have good resources and they have this option, but it's very limited of what can be done there, right here in the same city. So,
I guess I was just wondering, I really enjoyed both the presentations and was wondering a little bit, thinking about maps and kind of what you showed. We had shown the US, I think 100 years ago, many of those things where we're skinny now, we would have been big, and we've moved more into chronic diseases to some extent. Do you think that will be a global trend if we looked at it in 30 years? Or do you think, looking at your earlier talk, we're actually just going to have more of each, and they're going to be we're going to be dealing with all at the same time? And that's not necessarily too many questions, right?
I feel like it was 3.
Yeah.
It's like 3 in there.
It's going to be NCD with some infections,
Yeah.
NCDs meaning non-communicable disease.
Right.
Yeah.
But you think worldwide we'll see that?
Yeah.
It's a double burden right now with resources.
Yeah.
I think I always tell my students, if they want a career in global health, to probably not go in infectious diseases. Now, we still need outbreak controllers, but I think the mental health, as was mentioned, and diabetes, metabolic syndrome, that's really where the burden of disease, and people live longer and the population continues to grow. That's where it is.
I guess I'll just sort of adding into the conversation that our sense of demographic trends and a shift away from communicable disease and toward non-communicable diseases in the global north was based on demographic research that was done earlier in the 20th century. Some of it is really, really interesting and valid, but that question that Marcelo brought up about disparities within a nation, disparities within different populations, has always been with us. I mean, we stopped looking for tuberculosis because we thought tuberculosis was managed. It just wasn't being detected in populations that were living in the United States in a high-income nation. So that subtlety at the level of income disparities and wealth disparities nationally, domestically, both in the U.S. and in other countries, is something that I think we have to not convince ourselves that it is somehow coming back. It was there.
Right.
We're just measuring it.
Right.
We were measuring it in very different ways, or just not really willing to see it because we could all of a sudden do PCR and MRIs and all of these other wonderful things.
Just thinking about the Black maternal health mortality crisis. We're like, oh my gosh, it's always been there.
Look
Why
at that.
is it like news? Right.
Well, and also they sort of look at that. There's now drug-resistant tuberculosis in urban cities. Well, yes.
Right.
Like people weren't getting chest X-rays and they weren't getting treated and they weren't on good treatment regimens. Like it's not rocket science. We just don't have that. We don't maintain that sense of perspective, I think.
I think even I have a question for the panelists too about, because in America we kind of have an understanding of like the kind of like subnational inequities being related to like this backdrop of the social injustices we face in this country regarding discrimination and everything. Do we have a sense of, has that been really examined in low-income countries of like why are there differences? I mean, is it, I'm assuming it's political and maybe that's like an obvious question, but are there other things that we haven't examined for us to kind of help solve the problem for those subnational differences?
That's a good question. I think with back to TWE as well, I think for some of the diseases that are recorded fairly well, but then if you lot of good common health records and exchanges, and there's a lot of inequities that are missed and are not measured. So I think for the infectious diseases, it may be okay, but I don't think there are detailed maps of diabetes in Mexico, for example.
Because I'm just thinking about in the groups, is a lot of us are academics about like some gaps in the literature where we should be thinking about what we need to be thinking about as next steps for potential projects where we could collaborate, right, together and maybe think. Who had a question? No, I think you did. Yes, sorry. Tina.
So as we think about ethics and we think about leadership, I just wanted to raise the issue of the global pharmaceutical manufacturers and their role. What role do they play here, and how can we look to them? Because there's a lot of money there. And so we think about funding and we think about the resources that we need. I think that's a very, for lack of a better word, target that we need to look to.
But how? Because as a lawyer, I don't know. What do we do? I'm like, I don't know. What do we do? How do we?
Honestly, I think a lot of the way is shame, pressure. Maybe not that it's a law strategy, but
so like a lot, like
political pressure. Now we're having these hearings, in Congress about drug pricing and transparency. I think highlighting the spotlight on these manufacturers and how much money they're making and the prices they're charging for these drugs that are really not costing them a lot of money to manufacture, and that as they put them in the global market, that they're charging huge amounts and making huge profits, and how they should turn that back to the communities that need.
So how would we do that? Would we need more papers, or would we need to be going and literally in DC and showing up and lobbying? Yeah, we need to be there.
Advocacy. The papers would help too, and sort of looking at the financing, looking at how much money they're making and how little they're putting into R&D for some of these conditions.
Thank you.
Well,
Scott.
Just a positive example that I'd love to share because it's really cool, and it came from a law professor. I don't know how many of you have heard of CARB-X?
Is that BU?
BU? It's a BU thing. It's great. It started in part by a law professor, Kevin Otterson. And it came out of the need to develop new antimicrobials. But the model that they're using is really quite interesting legally. It's sort of so they serve as an incubator. Companies come in and they can get funding to develop new antimicrobials. And now to expand, the funding base originally came from NIH and the Wellcome Trust. It's now being expanded by going to countries of the companies and asking them to kick in. But the idea is basically the license, the ownership of the medication is going to be in the Wellcome Trust. And it is going to set the terms for the marketing and use. And that was an interesting way, in part, less to do with price than to do with wastage. So to prevent the marketing of antibiotics as they move towards the end of their patent life towards the agricultural mass use market. But it has a lot, it is actually an instantiation of an idea that's been talked about for a long time in the general medication area, which is, since the public in some sense is paying for a lot of this development anyway, why does the public have no say over the expenditure? But instead of being done through lobbying Congress to do something, it's all being done through contract. Money as an incentive, contract as private law as the regulatory system. I think it's pretty exciting and might be a model for some of this other stuff.
We're doing that, so in the Emerging Infectious Diseases world, CEPI is doing the same similar stuff, which is a coalition for epidemic prevention and innovation, money put in from a bunch of different donors, including bilateral governments, and to develop vaccinations for some of the WHO R&D roadmap diseases, Lassa, MERS, and Nipah virus, I think. Again, same thing, contracted out, money gathered into a pot, contracted out to individual companies to develop, but the trust would then stay within CEPI to pharma.
Was there another question?
I know I already spoke, but on this issue of social determinants in the income, low income, the problem of poverty, it's a problem in the developed world as well. In the United States, I will say, I'm not sure so much about Europe, but if you look at, I'm very involved with an organization called the National Academy of Social Insurance, which does research on Social Security, workers' comp, unemployment insurance, Medicare, Medicaid, all these programs. And, if you look at, the Social Security retirement benefit, the average benefit a person receives is only a few $1,000s a year more than the poverty level for individuals in the United States, right? So there's this just tremendous problem of income inadequacy kind of, across, and, and it's going to get worse with the gig economy because, Uber and Lyft and all these things are making pitches to state legislatures, our people are not employees, and then we can be cheaper because we're not going to pay the Social Security tax, we're not going to pay the unemployment tax, we're not going to pay the workers' comp tax. And at some point, we're going to have to pay because if people can't work, the society is going to have to come up with a solution to this. So anyway, we're trying to think about what some of the modifications to the way we've been traditionally thinking about these social insurance programs might be to try to respond to some of these issues, including just the basic income adequacy issues that are a problem with the existing programs. So I see this intersection between, the health programs and then these other policies, that we need to be thinking about those connections.
Right. I mean, programs in Sub-Saharan Africa and South America in terms of cash transfer. I mean, that was the root, try to address the roots of all these issues.
Right.
I thought it was interesting, like how the big corporation, pharmaceutical companies don't invest in several diseases. It's not, I think, it's a fact that they don't invest in certain diseases because they can't see a business model on how they can get a return from that. I don't necessarily believe that don't exist a model. It's just that it's not obvious, it's not compatible with the way society works today. So I think as the example, by taking welcome trust and creating these kinds of private contracts and companies may be one kind of solution. I don't know, it's a definitive, may not be the definitive solution, but that's one problem. I don't think we necessarily need or should demonize big pharmaceutical companies in some ways, but in other ways, we should. The point is, more than half of the cost of a big pharma is legal cost, advertisement cost, and then it's very little that actually goes into research and to manufacturing. And whatever is left is for the shareholders and all that. So the point is, like, how can, if you want to cut the cost of, like, to invest more in development, these companies spend a lot of money on advertisement just because they have a narrow window to recuperate. And they are, like, I can say in the case of dengue, Sanofi is going to take a loss of 2 billion euros, more or less. It's like, it's a big risk. So that's the reason I don't want to demonize, because they have their risks. Yeah, and I'm not saying they did a bad job. I think they did the best job they could do in the circumstances, just that in the end, disease is more complicated than anticipated. But the bottom line is we need to think in business models and ways to let's say, to incentive investment and find ways to return. You can see that it's not a matter of socialist or capitalist. You can see this disparity in the most socialist places. There is virtually zero drug innovation or medical innovation in a sense. Even if they manufacture the drugs locally, they just keep repeating and producing the things that are available off patent. They don't put money in making new medications, new things. And I think a key point to start actually thinking about business models is to actually have a better sense of the actual cost of several of those diseases. How much it's gonna cost, and where this cost is coming from, like where this expense is coming from. Because then you can find ways of who should pay for that or who can pay for that.
Was there any other questions?
So in response to that, a little bit, just add on to that, as I was thinking about this, the way to potentially generate funding, we talk about tax incentives and government incentives for, the automobile industry and things like that to save, or banking. Similarly, if you're talking about pharmaceutical manufacturers and their R&D risk, incentivizing them with those government breaks and things like that might be a method to use so that they have the incentives to make the investment.
I mean,
I don't know. I think they got lots of breaks.
Yeah. I mean, because even one of the other things that has even come up is how sometimes pharmaceutical companies will partner with academic institutions to kind of start up their research, and so like I feel like that's a tax break too, like where they're kind of using, us to kind of to execute their
I'm
work.
not saying I think that's what I would want, but if they're not doing it already, so what else can we do? If that's what we've decided is needed, that might be one strategy.
I think there is a gap between industry and academia, and huge. And to have the two working together is still a huge challenge because of actually several legal impediments and there are many issues. Actually, the philosophy of one institution is totally different than the other. I wouldn't be surprised that a reasonable business model related to attending emerging diseases or neglected disease could be some kind of step that could grow out of academia. Like academia create their own business model to invest in public health care, but that would be the academia in science-based type of technology being developed and marketed and distributed. But it would require a change in academic philosophy in this sense. It's like on the private sector industry, they either will have to go into this benefactory or kind of philosophy, or us going more on the, let's say, more business side. So, or create joint ventures or institutions as joint ventures to deal with this. But right now, it is a gap for many of these neglected, and there's no necessarily institutions devoted to this area. You can look at NIH, or they don't manufacture, they are not distributing, they have to license to someone, and even when they give the license for free, when was in some case of the Zika vaccines, people just, I don't want it, I may not, to do the final investment to transform this into a product is huge, and the chance of return is very risky. And if someone comes say, oh, I want to assure that you're gonna make this vaccine available for X price, they back out. That was exactly what happened.
This will be our last one.
It's just more of a response. So Del Cioda, who is one of the inventors of invention of Amoeba, he tried to address this in a sort of a university setting with something he called Drive, which is to try and create a model where you can, it's like a portfolio of drugs, right? So you have a portfolio of drugs, and then some that are more lucrative that subsidize, some that are less lucrative, but they're all building on the technology platform, right? In his expertise area. And so there have been efforts like that. The problem is, and it's the same problem with some of these social entrepreneurship sort of efforts, is that this idea of sort of a double bottom line or having private investors kind of help to develop, it has a tendency to drop the lower budget projects. And so I don't know that it's, the industry does work. Well, it's a longer conversation. I'll leave that there.
Thank you so much, everybody.
So I wanted to just talk a little bit about the format because it's a switch from this morning. And so this morning was great. We had a number of really interesting presentations, lots of really great discussion. And so what the afternoon I envision being is continuation of that really great discussion, but grounding it in some works in progress. And so each author that's seated around the table will speak for about a minute or two, and our timekeepers there in the back are actually going to be pretty vicious because you're not actually presenting your paper. Instead, what the focus is having the commentators, which is why we actually have the commentators centered. The commentators will then respond to the author's paper, will give a sense of what they thought the strengths were, what they thought the weakness was in the piece, where they see the piece developing. They'll also give critical feedback in terms of teasing out your hypothesis and other really great stuff. And so that would be the format, and then the author can, after the commentator speaks, either respond then or take some more questions from the audience, and then the author will have a chance to respond. So we're decentering the author, but of course you're very big deals. We've looked at your bios, and so we have our moderator for panel 2. This is focusing on public health. This morning we began in the biomedical, social medical, clinical perspective, which is valued and necessary. I heard somebody say, I don't belong here, but we all belong in this space, and this is why we're having this interdisciplinary workshop. And so now we're segueing to our public health folks. So please.
Hi, I'm Link Lin. I'm actually a children's, I'm an pediatric infectious disease doctor, but I also do a lot of work in tuberculosis. So I am going to moderate, and so we have Dr. King and Dr. McMahon in this first session. Just a reminder about the agendas. I understand that our timekeepers are going to be steadfast, so get your comments in quickly and appropriately. Dr. King? She's down there. Oh, sorry. Where's Dr. King? Oh, hi. Okay, so Dr. King, just quickly, is a Fulbright scholar and faculty in sociology and assistant professor in the School of Public Health. She's an MD PhD, so she is going to be our author. Deb McMahon, who is the clinical director of the UPMC HIV/AIDS program and is professor of medicine at UPMC, will be the commentator. Would you like to go ahead and start?
Yes. Okay. See how the microphone will work. Okay, so hi, I'm Elizabeth King. So the paper that I presented you all with is part of it's a smaller study within a larger program of research that I'm conducting in Russia. I've been doing work on women's health in Russia for quite a while, about 20 years, I guess, and have been working specifically around issues of HIV in Russia since I was an MPH. I did my MPH internship on a large cohort study among people who inject drugs in Russia. And I was really wondering, with that study, there were a lot of men in the cohort study, but not a lot of women. And I was interested to know, thinking about some of them with the ideas for gender inequities and gender dynamics of injection drug use. And I quickly learned that the reason that there weren't so many women in the studies was because they were clinic-based. And to think about, most of the cohort studies are clinic-based, and then also the harm reduction services in Russia were largely at the time clinic-based as well. I did my dissertation research looking at women who are involved in street-based sex work and used a community-based approach with harm reduction outreach services that weren't clinic-based, and thinking about HIV and then this overlap with injection drug use among that population led us to these research questions that I'm currently working on, is to think about, what are the gender-specific factors that influence women who inject drugs, risk for HIV, and risk for not being on HIV treatment from a gender perspective that looks beyond just involvement in sex work. So a community-based study, we found 63% of women who inject drugs in Russia tested positive for HIV in a community-based study, and looked at both drug and sexual risk more from the epidemiological point of view. And then thinking about the shift in, for our conversation of thinking about HIV in Russia continues to be a neglected infectious disease, in the sense that the global health community is largely neglecting the region, Russia and Eastern Europe, and because it doesn't always fit into the categories that we think about from global health, and then also thinking about HIV as an infectious disease that continues to be neglected by the Russian government. I'll leave it there for your comment.
Okay, so I have it, thanks. I'm Deb McMahon, and I read Elizabeth's paper several times, and I enjoyed reading it. As she said, their paper outlines their preliminary findings, and what they did was a series of interviews over the past, in 2018, for a period, I think 5 months, with female injection drug users, and some of whom were living with HIV and some were not, and they conducted it in St. Petersburg. And they wanted to identify gender-related issues that either facilitated or acted as a barrier to accessing HIV preventive services or HIV treatment or drug rehab programs. And she reported that the issues encountered specifically by female injection drug users in Russia have not been well examined. And I looked at her reference list, which was extensive, and I laud her for that, despite a worsening HIV epidemic. And that is clearly, if other places are making progress, Russia seems to be regressing. And their overarching goal is to develop an effective intervention or interventions to address one or more of the challenges they identified in this population. The scope of the work was challenging, and they had to identify and recruit disenfranchised women, injection drug users, and also network with the organizations that serve this population. Some of these populations overlap, but sometimes there's distinct differences. And their group consisted of both U.S. and Russia-based collaborators, which was, they engaged local folks on the ground, which I thought was good. And they considered gender domains, and as they analyzed the interviews, including norms, roles, relations, and control of, or access to resources. They did the work in St. Petersburg, which, if you know anything about Russia, you realize that's probably about the most Western city there is. It's probably one of the wealthier cities, and there's some areas that are less economically well off. But that's where they did it because they had an ongoing collaboration with there, and she can speak more to that. And during the 5-month study period, they went around in a van and did in-person interviews with these agencies, and they found their study population through needle and syringe exchange programs. They used an IRB-approved protocol, and they linked to people through referral. They didn't do any cold calling, at least that was my understanding, which is really not optimal to do it that way. They did it properly through referrals. They modestly compensated participants for their time, and they met with 20 organizations and 30 women who inject drugs, some of whom were living with HIV. And as I read the paper and the themes that kept recurring, I thought, this is what I have in my clinic. This is what I see. I see women who struggle to access healthcare resources, navigate healthcare systems, are poor, have low self-esteem, sense of hopelessness at times, transportation barriers, particularly across county lines here in Western Pennsylvania, hard to get into a drug rehab bed. I mean, this was all like, it just sounds worse there, but it's here in Allegheny County, I can tell you that. However, unlike there, people with HIV, if you can get to care anywhere, you can be treated. And you will be treated pretty promptly, and hopefully in a non-judgmental way. At least that's what we strive for, but there it is quite different. Women there who inject drugs have to be registered as drug users, so that's stigmatizing. They also, and sexual inequality, as it is in many parts of the world, is a big challenge for women, and it's hard for them sometimes, if they're doing sex work, to negotiate for the use of condoms for safer sex practices. And although Elizabeth didn't really mention it, there's a rising wave of social conservatism in the USSR, and maybe some of you have seen that. There's a lot of stigma against the LGBTQ community there. They are also opposed, their health ministry is opposed to the use of harm reduction strategies such as methadone programs or Suboxone, which we do promote. Actually, in our clinic, we have every Wednesday afternoon, we have a Suboxone clinic on site in our HIV clinic. Resources are limited, and the Global AIDS Fund pulled out of Russia in 2010, deeming it to be a wealthier country. So, and the Russian government hasn't really stepped up. So some thoughts that I had as I read the paper, and I want to just throw it out for Elizabeth to respond to, is why did you, in your paper that you gave to me, there were a couple main ideas that you put forth, even though this isn't your final manuscript, it's just areas of focus that came up in your interviews. Do you want to comment on why you chose the ones you did for today?
So thank you, Deborah, for those comments and putting some kind of more context into the paper that I probably didn't put in. So yeah, I mean, I think that, you know, why we focused in St. Petersburg. So St. Petersburg, I mean, if you think a little bit earlier on in the epidemic, it was definitely one of the epicenters of the HIV, well, I mean, Russian government doesn't call it an epidemic, but the HIV, whatever lack of word for epidemic is in Russia. But, you know, we're seeing now kind of the geographical disparities with, I mean, Russia's a large country across 11 time zones. But I think as far as like, one is around St. Petersburg in some ways is around their harm reduction services. And the kind of the civil society or non-governmental organizations being in place. It's one place to continue to do work, but also the need is there. I mean, across Russia, statistics aren't that great, disaggregated data, but antiretroviral coverage is about 35% in Russia. So thinking about, you know, issue of like access to what if people become registered, and then as you mentioned, you know, methadone, other things are illegal in Russia. And the Global Fund, you know, definitely ended in 2010, but they continued funding organizations. They gave a grant that was not to governments, but I think it was the first time for Global Fund to give grants only to civil society organizations who worked with key affected populations, namely people who inject drugs, female sex workers, and men who have sex with men. So we picked St. Petersburg, I mean, for this study for a lot of those reasons. And also, I mean, you know, as you mentioned, it's this collaborative project. I mean, they've been working with these collaborators there for also over a decade, and so this is kind of, you know, continuation of the work that we're doing there. But knowing, I mean, again, I could only give you one paper, I guess, but, you know, thinking about the HIV epidemic and how little information we have from other places in Russia, I have a current project that we're looking at postpartum adherence, and that's for women living with HIV with a subset of women who are have a history of or current injection drug use, and that will be done in one city of one's representative either city or region of the 7 federal regions in Russia. So it will also be interesting to see how these patterns hold up across the regions as well. It will be interesting.
Thank you.
Does anyone have any other questions? Sorry.
I have several, but I'll do one more. Just throwing this out because it might be a little controversial. Do you think women there, we promote PrEP with Truvada for any at-risk population, MSM, injection drug users. I realize the Russian government isn't funding that, but do you think the women you met might be open to that?
Yeah, I mean, I think that, you know, a few years ago, a colleague had asked me, like, oh, let's do a PrEP study in Russia. It's like, well, considering that the availability of antiretrovirals is so limited in Russia, and especially as Global Fund was pulling out, et cetera. So, I mean, there haven't been studies on PrEP in Russia. I think for some of, probably lots of reasons, but some of that. I think it probably depends on the reason that people aren't, you know, for people who aren't living with HIV and thinking about, I mean, probably could look at some of the barriers and to being on treatment could help think about, you know, what might be some of the facilitators or barriers for then accessing PrEP, but then also thinking about, I mean, there's been a lot written around the world about kind of disparities in the prescription or provision of PrEP, and so it would also be, if we were going to do that study, it would be really interesting to think from a provider's point of view, like who should get PrEP in Russia, right?
Yeah,
I mean, it's been so long for Russia to shift its position to being able to, for a long time, a person couldn't be on antiretrovirals if they were an active injection drug user, and to think that, you know, 80% of HIV cases have traditionally been among people who inject drugs. And that's probably why one of the reasons that adds to why the treatment coverage is so low.
Okay. I guess I have to stop.
You can finish yours.
Okay. Well, I'll jump to another question I had. Given the information you have, do you have any preliminary or early thoughts about what intervention or interventions you might want to move forward with?
I mean, so that was some of the reason that we conducted this study, to kind of think, and at first we were like, oh my gosh, there's so many things, even after the first interview, it's like, okay, well, we could design an intervention, but there's so many interventions, maybe the scope is too broad. But I think that we're planning on designing an intervention for focusing specifically on women who have been diagnosed with HIV and know their diagnosis, and thinking about linkage to care, especially given, I mean, St. Petersburg is one place, which is another reason for doing it, is because that people who are injection drug users can be prescribed antiretrovirals, and the AIDS Center in St. Petersburg is very much open to providing people who inject drugs with linking them to antiretroviral care. So I'm thinking that that would be probably the spot of intervention, and then thinking of how that will look is what we're spending.
I think that's
now
a great
designing.
next step. Thank you.
All right, we are going to move on to our next presentation with Dr. Quark. So the title of this one is Mainstreaming Environmental Determinants of Health and the Prevention and Control of Arboviral Disease in the Americas. That sounds really easy to do. Dr. Quark is the Unit Chief in Climate Change and Environmental Determinants of Health from the WHO and the Pan-American Health Organization. And we have Dr. Marquez as the commentator, who is an associate professor at Pitt, and the focus of research has really been on viral vaccine prevention. So this is a lot like speed dating with an article, so let's go.
I'm done.
Nice job.
No, so the reason behind why talking again, as you said, very easy question on the mainstream environmental determinants in a way should be easy. For those that do not know, the creation of the Pan-American Health Organization was back in 1902. And back in 1902 was created because of the yellow fever in Panama when there was built the Panama Canal. Water and sanitation was one of the issues that really tried to, say that we'll really do something about it. So 100 and how many years later, looks like we are back in the first place that we were before. The question then is why and how to move forward with it. The reason why is there are many ways throughout history, but in the past 20, 30 years, we can say that the issue is really what we discussed this morning, what really we didn't want to talk, which is about governance. Really, at the end of the day, it's an issue of governance. It's an issue of ministers of environment and ministers of health, that they divided the pie of the environment, but neither took responsibility of how to move forward. Vertical strategies on the disease control, that they were so vertical that they could not include determinants, and really how that will be included in different initiatives. For those that they don't know, the Pan-American Health Organization, the WHO, the same way we are just regional for the Americas, besides being a separate agency, we move really by mandates of our member states, meaning we can do what they allow us to do, we cannot do what they don't allow us to do. However, recently we finally were able to have a resolution with the countries to mandate on a strategy and plan of action on an integrated strategy finally for arboviral diseases, as well as a plan of action for entomology and vector control, which opens the door then to include other issues that are not really just a vertical strategy on how to move forward, like we have, for example, in the case of malaria, that is still in that particular way. And so very recent, our unit got reformed, and we were created as a unit only a year ago on the environmental determinants. So since then, we started to break the silos on trying to work on the issues of how to include environment in the arboviral diseases. And that's how really what the paper is all about, how to include it. But this time it's not only included just as the typical let's give water, let's give sanitation and solid waste, because we know that and we know what happened. But it's really about tackling the issue of governance through a human security approach. How we really work at the protection level means with government to really have the picture clear, whose responsibility is whose, and at the same time with the community to understand what their issues are from the essential freedoms in the overall picture, and look at that from a human security point of view, meaning it's a multidimensional issue. It's not just giving water, it's just not having sanitation, it's just not really managing solid waste. So that's how we're really moving forward in this strategy. Yes, it's not an easy task, but definitely it has not been for 120 years, and we're still in some cases in the same place. So I guess I have 120 years of work to really move forward. So with that, Ernesto, I'll give you the microphone to you.
I will try to be as, let's say, clear and concise as you were. But, well, I think he explained the paper very well. And my take on this is that most of the global population lives in the city, and a lot of this vector transmitted disease can be mitigated by better water supply, by all this, and I understand that the challenge in this fractionation, like environment department, public health department, transit or traffic department, all these play a role in that, on what to do. And these entities need to work closer together. And from my perspective is that urbanization code or building code could be a way to integrate all this in a let's say, you could have legislation from each municipality that could meet a certain criteria or answer certain issues that related to, let's say, reducing breeding sites or like removing plastic, trash, tires, whatever. In terms of water supply, all this. I think there is another issue that has like a disconnect. What is science to society and their understanding, and this, let's say, explanation to society of how to do things, that is not going very well. And I think after social media, it actually got worse. And I know an example that during some of the yellow fever outbreak a year ago, there were a lot of news spread in social media saying the yellow fever vaccine would kill you. So, and that's the kind of thing that, so science, society, and lawmaking needs to come closer and try to work on these certain standards for urbanization law. And I think another key issue is that relates to this communication is that health information, or public health information that is disseminated needs to be more accountable in what is being told and what is being said, because it has a huge impact on how people perceive the let's say, public health measures and actually the research itself, and make things a lot more difficult. I know for a fact during the Zika outbreak, there are all kinds of rumors that would be the cause. Was a bad vaccine, was a sugar that was causing that, or there was all kinds of bizarre proposals, and that created a lot of waste of energy, time to investigate that, refute, and all that. Anyway, so I think the denominator of this could be urban law in having let's say, an understanding on how the environment creates a cost in human health. And most of people live in cities, and how communication about health needs to be scrutinized more closely. That's my take on this.
You want to respond?
I thought that you wanted to take some questions and then we can put it together as you prefer.
questions.
No, it's okay. If not, I respond to that question. Oh my God, I know, I read
So, let me take some time. So I just wanted to add on, if you're going to take questions first. What is the so we've seen a lot of trying to, like, some tactic to motivate policymakers to do more against climate change based on the threat that it may cause through a disease route, right? To say climate can affect disease, that's why it's a security problem, that's why we need to do something now. So how, in what degree have you seen, from a policy point of view, working with governments, that has given any traction?
Can I just hop onto that one?
Sure.
I mean, while we're talking about that, maybe we want to just
just talk a little bit. We talked this morning about the securitization of infectious disease and whether that's a good idea. And now we're talking about the securitization of climate change, which is sort of a favorite issue of mine because I see it cutting both ways, right? It's maybe a good idea to bring attention to climate change as a national security matter, but maybe it's also problematic for the same reasons treating health as a security matter rather than a simply health matter is problematic. So maybe we can put that into the discussion.
It's an interesting point that we started talking about that. So.
Do you mind just repeating some of the questions?
Sure. It's about the issue of the global health security agenda. If it's really securitization of health as securitization of climate change is really, we are going in the same direction. That's really, what do we think about that? And the issue of climate change, that we talk how countries are really responding to that as well. So let's start with the urban thing. Yes, I think the urban agenda, in a way, is crucial. And as we know, the main cities in Latin America in particular, that's the area that I work, the main urban areas are really in chaos. There's no urban planning, are chaotic, there are no really services in a way. That really has a lot to do with many variables, but among them, part of the decentralization process of governments as well. Not to blame decentralization, but is a variable in the sense that, let's face it, most or many of these governments they have a corruption going because they may have laws. They have the best laws in the books. You read the laws and they're fantastic, but the enforcement of the laws are absolutely nil. So the question is, we moved from one corruption to 5,000 corruptions in Brazil, let's say, because we have 5,000 municipalities, right? And they all receive funds from central government. And let's say that that's very different than the United States, that they really are a collection of taxes at the local level, things like that. Most of the money that these governments at the very small urban areas receive still comes from the central government because they give that money. So it really is a combination of the way that the decentralization has worked, combined with, now it's a blaming game. No? Yeah. I blame you for the problem, so blaming is easier than doing. So let's blame, no, that's really your responsibility, not mine. And that's where the issue of the urban planning goes. So that's with respect to the urban, but necessary, definitely, especially in the big cities. I mean, that there's no planning whatsoever. Urban planning is zero or not respected. And at the national level, definitely we looked that we need to develop national policies of at least on environment and health, because in the particular issue, nobody really knows what their roles and responsibilities are, or they don't want to take them. So really is something that we need to move forward, and then how to enforce them. With respect to climate change, yes, that's definitely the direction has taken of disease, but the issue that really in the Caribbean has gained a lot of track. The English Caribbean countries, because they see it every day. As a small islands, developing states, they see that, they're moving forward with the adaptation plans. I will not say the same thing about the other countries, that they don't see just in front of them that where they see the changes due to the current extreme weather conditions or extreme climate issues. And finally, with the securitization of that, yes, it maybe can be eventually a necessary evil. Personally, coming from the determinants, I don't see that that's the direction to go. I see it in my own organization, that when we need to talk to the people from the international health regulations, we just clash. I think that the rest you can understand what that means. I mean, it's like it's two different ways of looking at the world, and we have not been able to find a common path. So I feel that that's what's going to may happen again, in this case, if we do it in that way.
It's just separate discourses.
Yes.
Just don't really.
So far, yes. If somebody can be able at the high level of leadership to really put it together, that's what's needed. Strong leadership to a one health type of view type of thing, right? The one health type of view that really is, which is a good, I'm very, very, sarcastic here, but it's like, yes, it sounds good, but let's walk the walk and talk the talk, right? So far, we are the smallest unit in the whole organization with the lowest budget in the whole organization. So I'm just trying to take money from all the infectious diseases, non-communicable diseases, and move forward.
Yeah, I just want to complement a few things that in terms of to get traction on urban law, I think the basic point is to explain the community how much bad urbanization costs. And it costs in many different ways, not only infectious disease. We talk about diabetes. Here in Pittsburgh, there was a while back a program that was Michelle Obama organizing, and they did in several neighborhoods here, looking where the schools were, library, what kind of food services were being around that schools and all that. So planning can take account of a lot of things, like promoting health, like health in walking, and have a healthier environment for the children, and all this. I can give another example. In Brazil, actually, as socioeconomic status or the purchase power of the community grew, especially the poor communities, they started buying more air conditioning in the favelas. However, there was not good maintenance or not air exchange. So TB incidents grew, because you have a bunch of people in recirculating air instead of open windows. So improvement of individual economic status actually created one more health problem. So I think militants, in terms of explaining how much it costs and making sure that maybe some of the investment banks like World Bank be focused, okay, we can lend money for this project, but you have to follow certain guidelines in urban laws. That could be a driving force.
Can I make a comment on that? That's very quick.
Yeah.
I totally agree with you, but I will expand it. I will call it public engagement. I think that information is really one component, but we need to go all the way from the information all the way to empowerment, and really in a slow process with the community. So it really definitely is information, but it's really a public engagement process.
Yeah.
And in that formula that you're saying of understanding the cost, the thing that really needs to be understood by the banks, by the economics, is that the way it's accounting. We don't account for many things that they need to be accounted for, and therefore we cannot believe many of the things like natural resources are not being accounted for in the formulas, for example.
Yeah.
Therefore, we don't really have a good cost of how much things cost, that all the contamination cost.
Yeah.
And that's really one of the other issues. So that's just to complement your.
Yeah, okay. So
Anyone else with any questions, comments?
Comment/question. I guess I know we shied away from it earlier today about our government and partisan issues, but I think particularly as a physician, since I don't know the law and policy, I think bringing up climate change and partisan issues, I just want to get a better understanding of, even if you engage the public, if the government actually is not necessarily not supporting the law or not enforcing the law because of a different government or head in place. How does that work? Isn't that going to be counteractive?
Well, I hope in a democratic society, the government will be a reflection of what people believe and want. I have this faith. It's a faith.
Right? Because there's so much science supporting it, and we know that we don't want to believe it.
When you deal with a disease, let's say that mosquito bite, you get dengue, you get diarrhea, and then people feels that more in their skin, what is going on, literally. I think you have to explain that. You have actually, that was one of the things that I said first, is you have to connect science to society and lawmaking together. And I believe today one weak point in this whole link is this dissemination of false information. And that has to be looked more closely, because it's not a matter of fake news. It's fables are being disseminated, and people take that as science and believe on that, and start to make decisions based on that. So needs to be accounted for. If you're saying that something is bad for your health or good for your health, even if it is informally and you are not a professional, if you don't know, you shouldn't say. But if you decide to disseminate information, you have to should respond for that, especially for disease that involve public health questions. like such vaccine is gonna kill you if you take that vaccine during a yellow fever outbreak. So whoever is spreading that has to be accountable for what we are saying. So I would say medical news or health news has a big role on play in this, in newspaper, TV, and all that, and should be taken more seriously. It's not a government advertisement campaign, like there's a bunch in Brazil, like look for places. It's not that. It's like real news on whatever media exists. That's what is actually reaching people. And that's it.
All right, I think we're going to jump to the next one. I think this is great fodder, actually, for a New York Times op-ed piece. Just saying. Pressure.
I'm not the one right.
No, but I think this is very poorly understood, and you guys both articulated it very well what the problem is. And it's not anything that your normal person walking down the street would actually think about unless it was laid out to them. All right, so now we're going to move to things that are a little more practical. The next article is Home versus Self-Initiated Art Refill, Clinical, Immunologic, and Virologic Outcomes. And the author is Jane Natega, who actually was at Stellenbosch University in Cape Town. He was the director of the Center for Infectious Diseases there and is currently at our Pitt Public School of Health as an associate professor. And our commentator is Dr. Anita McElroy, who is also at the Children's Hospital in Pittsburgh. She's an associate professor and works on a number of different tropical diseases. So I'll go ahead.
Yeah, thank you very much. Just to put the context, which going to echo somewhat the Russia talk. So this is now in South Africa, one of the places where HIV is the most prevalent. The country with the highest number of absolute number of HIV, about 6 million. So there is now we're focusing to try to make sure the cascade of care is optimal. As we heard from Russia, in that setting, Pittsburgh is not. Globally, we're still falling short. About 37 million people globally infected. Only about half of them are linked to care. And those who are linked to care, only less than half of them are retaining care. And those who are retaining care, only about 30% are virologically suppressed. So we still really have a long way to go. So UNAIDS target for 2020, which is not far, that's next year, is it? It's to have 90% of people linked to care, first of all diagnosed, and then 90% linked to care, and then 90% virologically suppressed. So that's quite an ambitious target that was set somewhat time ago. So we need to come up to meet those targets. One need to come up with some innovative way of making the cascade very optimal. One of them is to try to move the care from clinic to home. And that's where the idea of, in South Africa, we say, well, decrease the frequency of people have to access to go to refill their medicine, but also try to make easy for them the refill. Maybe we can organize in middle kind of income people, courier pharmacy to deliver medicine at home. So we look at a huge data set in private sector where we've been able about 40,000 patients over a 10 years duration. We've been able to analyze those who are assigned either to home refill or to courier pharmacy and look at all-cause mortality, CD4 viral loads, using a retrospective cohort analysis and also Kaplan-Meier survival analysis, Cox regression, adjusting for propensity score. We've been able to find that actually home refill had better outcome in terms of all-cause mortality, change in CD4 and viral load from improvement from baseline. So we're thinking that this is as part of intervention to try to make the target of UNAIDS something we should look at, maybe to implement widely at large scale. So I look forward to hear my commentator some suggestion and advice, weakness and strength, so we can see what to move for next step. Yeah.
Sure. Really excellent study by Dr. Nachegan. He did a really good job of doing what I thought we should start with, which is highlighting that the HIV is still a problem in the world, right? We don't hear a lot about HIV anymore. I feel like it's left the media, just like Ebola left the media after 2014. You'd never know there's 1,000 people in DRC with Ebola right now, right? Or there have been a huge outbreak. HIV faces the same dilemma, where people don't think about HIV like they used to. 37 million people in the world, right, have HIV right now. And there's 1.8 million new cases just in the last year of accounting, which was 2017. So people are still getting infected with HIV, and this is an ongoing problem. So the question is, well, what are the challenges that we're facing? And the UNAIDS goals outline these challenges really explicitly, right? We need to identify people who are infected. We need to get medications to those who need them, and that second topic is exactly what Dr. Nachega's paper is all about, getting medications to those who need them. And we need to monitor people's response to those medications. So if there are adjustments that needed to be made, they can be made. And I think we can't talk about HIV in a population of folks like ourselves that is so diverse without me taking a second to remind everyone, if you put someone on medications, there's some things that we follow clinically to make sure that those medications are doing their jobs. We look at CD4 T cell counts, which is the cell that the virus likes to attack and infect and kill. So it's important to know if those cells are present or not. And we look at what's called viral load measurements, which is another thing that Dr. Nachega measured in his study. And that viral load tells us how well our medications are doing at suppressing the virus, right? We want to see viral loads that are undetectable or below a certain level, and that's measured by viral suppression. So his study asked a very important question that was, if we make it easier for people to get their medications, will it make a difference? Will they do better? And so, as he said, this was a retrospective cohort analysis to be commended to include over 40,000 participants, right? This is a huge, huge study. All of these were adult patients who had HIV who were on antiretroviral therapy. The study years was a very long study from 2002 to 2010, and he compared patients who had to go to a pharmacy to pick up their medications on their own, that's the self-refill group, to those patients who had their medications delivered. Importantly, there's a third group that I think we should talk about a little bit in the study, of patients who started on self-refills. They had to go themselves, but then they were switched to home refills. So clearly there was something going on that indicated that switch should happen. Outcome data are reported over a 10-year period in this study, and then viral load and CD4 count data are reported over a 5-year period. And there were 3 endpoints, as he mentioned, very straightforward. Do people live longer, right? Mortality outcome. Do we have better viral load control? And the measurement there was for viral suppression. And what were the total CD4 T cell counts? So the questions, again, in more layman's terms, if we make it easier for people to get their meds, do they live longer, have better viral loads, and better immune systems in the process? So the answer to his study was yes to all 3. Statistics bared that out, that home refill patients had better survival, better viral load control, and better CD4 T cell counts than self-refill patients. There were a couple of sort of caveats and limitations. It is a retrospective study, so that's one challenge. And there are some potential confounders in the mortality outcome. So patients who were older, who were male, who had lower baseline CD4 counts at the time that they started therapy, and who had lower BMIs, i.e. not very good nutrition, right? Those patients were more likely to die. Although when you compared the home refill group to the self-refill group, they were similar in between those 2 groups, right? But there's just a little bit of challenge, and you just have to take those into account, which is why some of the additional statistical analyses were done to try and control for those variables. And I guess one of my major questions for you is how it was determined who was on home refill and who was on self-refill, and who made that decision. And if the patients were switched, how was that decision made? And then I have some other comments, but I'd love to hear your input on that particular topic.
Yeah, so that actually the key question. And that's the whole problem, major limitation of this retrospective or kind of observational study is that the allocation was not a random allocation, so people self-selected themselves So they may do better just because they have some other factor that make them to do better, but not due to the intervention. So this is just a signal we try to sell here, but our next step is in terms of trying to make our analysis robust. There is a technique some of you may know, which is called marginal structure modeling, which kind of mimic a randomized control trial, which we're planning to do. But actually, the ultimate study is to do a prospective randomized trial. It's going to be a bit tricky for this type of intervention, but we're thinking of really carefully think about it, because we have here some preliminary data which are quite promising. So those are our two major next step to try really to solve this out. We're looking actually for a funding to conduct that study.
Okay, great. Another thing that I was curious about is all these patients had access to antiretroviral therapy, everybody in your study, and it wasn't at cost, right? You mentioned that. So everybody had access to free medication, that's correct?
So that's another point I want to point out here. In the context of South Africa, majority who are infected are, I would say, a majority are black in the public sector. So this is also a different type of population. People who are privately insured, who can access medical insurance, are more likely to be middle income, with a middle income, and likely also to be of Caucasian. So that's why we cannot also extrapolate this result actually to do a courier pharmacy. So it's some kind of making easier to a middle class. But the middle class in South Africa is quite important also. So that's also something important I want to clarify here. Our data cannot be generalized to the whole majority of HIV infected in South Africa who are black.
Okay, that's helpful. The other question I had for you is about compliance. So one makes an assumption that you're going to take your medications if they're delivered to your house. Is there a way you were able to measure the differences in actual medication compliance between the self-refill and the home refill group?
So the whole hypothesis is that whether you are in public sector and private sector, and whether you can afford medical insurance or not, there's still some kind of a structural barrier. People have difficulty to go to refill their medicine for whatever XYZ reason. So that's why we think this is something that an intervention that may work for different type of population. But what you just alluded for here, given the retrospective nature of this study, we could also not go in detail on measuring other kind of adherence measure like self-reported, or so prospectively we can measure all that, do some qualitative analysis, but also have some more objective measure of adherence, which we used to do in most of our study, which can include electronic monitoring and cell phone feedback through SMS.
Great. Do I have time for a couple other questions? Or
Does anyone have any other questions?
Okay, so the treatment modifications, treatment regimens and recommendations by WHO, by anyone who does anything with HIV nowadays, has changed significantly since the time of your study. Do you think that the outcomes would be different on some of the newer, possibly more forgiving regimens than you saw?
It's possible. What we try to also address that by looking, by updating our data, and if we now look at some more recent, the last 5 years data, we have, patients who've been on recent regimen, which mostly are once daily, like the one used here in the United States. So we are updating our data. So actually, our plan is to submit this data to the Annal of Internal Medicine, and so we'll be able now to compare in time period the different type of regimen as the guideline change in South Africa and access to the new regimen, which are now universal and used here in the US.
Good. I think that'll be a really nice addition.
Any other questions?
Just very quickly, are there, I guess this is a hugely important sort of policy finding,
Are there particular obstacles in terms of cost or other obstacles that would make it harder to have this be a more universal approach?
That's another major importance of our study is that since it's been conducted in the private insurance context, so we have really a treasure of costing data that we can do some cost analysis and cost effectiveness. So that's another part of the work that we're gonna get a separate paper, just look at those aspects. And given the context of South Africa and the context of universal medical insurance, I think this is gonna be an interesting paper, separate paper.
Great, anybody else?
I had a question about the control group that did the self-retrial, because what I'm noticing with them is that their CD4 count actually increased, even though it was significantly lower than the interventional group, but it still increased over time. So I just wanted to know about what the thoughts of the group regarding that even though it was lower, it still improved.
Yeah, so that's a small, something that also we notice. We don't have a clear explanation. So that's why also we think that by doing some more prospective analysis, we may have missed some confounding there that we don't have a clear explanation.
All right, we're ready to move on.
Because actually people who start lower tend also not to respond quite usually. That's what is known.
All right, so our next paper is entitled The Dynamical System Model of Global Emerging Infectious Diseases and Its Relation to Social Political Instability. Again, another straightforward topic. Our author is Dr. Bulwitty, is that correct?
Yeah, that's correct.
Great. And then our commentator is Dr. Harris. So Dr. Bulwitty is an assistant professor at our University of Pittsburgh School of Public Health, and Dr. Harris is the professor of the Division of Infectious Diseases and Vaccinology at UC Berkeley, and the recipient of a MacArthur Genius Award. For comment.
All right. So I guess the reason we're here is to kind of understand the question why emerging infectious diseases outbreaks occur in the equatorial belt, and those regions are often tied with violent conflicts. These are questions I've been thinking about for a long time as a faculty here at Pitt in the Department of Infectious Diseases and Microbiology, and also as an Army officer. So one of the things we all know about emerging infectious disease and violent conflict is they all follow this calendar-based dynamics. We know there's this spatial, temporal dynamics that pretty much that go along with the calendar. And well, if you think about calendar-based dynamics, really what you're talking about is geophysics. And really the goal of this work is to go to the fundamental level, like what exactly is going on. So when we think about the geophysical structure of our planet, the equatorial belt is very different. We tend to sort of translate everything from the northern hemisphere and the southern hemisphere to the equatorial belt, but those are completely different regions. So I went back to the inspiration for this paper. Really went back thousands of years to the Limpopo River Valley in southern Africa. Indigenous Africans used to burn their villages during time of climate perturbation, which is associated with disease and civil strife. So they burn clay on the surface of the villages. But if you sort of think about African culture, sort of how they see diseases, really is the manifestation of sort of geophysical forces that are emanating from the earth. So, and I know this might seem like sort of postmodern way of saying diseases, but I think there's something there because there's an emerging field that looks at biology strictly from the perspective of physics, particularly quantum physics. It's called active matter, and really that's sort of what I looked at in this paper. So I looked at the geomagnetic perturbation in Africa, particularly occurring along the equatorial belt. One of the first things you realize about Africa is the only continent that sits on this massive structure called the low shear large velocity province. This structure perturbs the magnetic field. You can actually follow the perturbation all the way from the core mantle boundary, so that's where our Earth magnetic field is generated, all the way up. There's two magnetic anomalies in Africa, one in Western Africa and one smack in the middle of the Congo Basin And so you can actually follow where Ebola hits by looking at the low magnetic field strength. You can actually, in the paper I show in West Africa, you can predict the number of cases in each county in West Africa, strictly based on the magnetic field strength. So, and I also show, if you go into Congo, you can see, you can follow it. If you actually model it, you can see there's a ring structure. The structure is based on the Bangui anomaly in the Congo Basin. You can actually predict the number of cases. If you look in West DRC and East DRC, which the outbreak occurred last year, you can actually predict which region are going to have higher number of cases strictly based on the magnetic field strength. We actually looked at the violent conflict basin. If you look at it, it's a spherical shell. Conflict in Africa is not random. If you look at certain countries like Ghana and Togo, there's no conflict there, even though they have issues. If you look at that spherical shell, you can sort of go around. So, I mean, that's pretty much the summary of that, and I look forward to questions. Thank you.
So, Dr. Guidi just explained, but I'm supposed to kind of give an overview also, looking at equatorial belt in particular, the high degree of social and political instability and its clustering spatially and temporally with emergence and spread of infectious diseases, and he's trying to relate this to dynamics of the physical space, which he calls the lithosphere, atmosphere, ionosphere coupling, or lake, and kind of add this human element, or H-lake. And then kind of bring this active matter, or human active matter concept, and then relating that to these magnetic anomalies. So he uses as an example the Ebola epidemics in West Africa and Zika epidemics in, well, it's really all the Americas, but he focuses on northeastern Brazil. And he uses some geographic imaging and of the magnetic anomalies, some association analysis and comparison of temporal patterns. So I think the question, at least that I took from this, was I'm trying to tease out potential physical factors from the dominant overriding factors that are kind of what we look to not usually to explain these. And so first, I should just give a background that first of all, this is very different to our current understanding. And I am, anyone who knows me, I'm not into dogma, and I'm definitely not a mainstream person. However, I do know something about the Ebola and the Zika epidemics, and so I felt that that the alternate explanations, saying yours is now what we're looking at and the others would be the alternative, I feel those alternative explanations are extremely plausible and have a lot to back them up. And so I would just, first I wanted to lay out the historical context that I think plays into the situation, as well as the biological, epidemiological, entomological issues that not issues, but explanations that I think need to be taken into account. And then that would be the first piece, and then hear you, and then I have a question about mechanism, which is my second aspect. So you mentioned this a little bit, but I do think that it's really critical, especially in this region of sub-Saharan Africa, essentially Equatorial Africa, is the whole history of colonialism and massive exploitation of natural resources. And so I feel that and also kind of all the dehumanization and kind of unnatural boundaries and all of this, which led to this, kind of current or past and current centuries, of conflict because of scarce resources being, and also because of and continuing now the extraction of natural resources precisely from these regions. So I mean, looking up in Guinea and Sierra Leone, et cetera. I mean, there's ongoing, and Congo as well. I mean, there's massive exploitation of diamonds, there's iron ore, uranium, oil, and gold, actually. So there's, and there's a lot of international interests that are behind this, that are fueling, what look like potentially a toxinous warring among people, but really it's because of a lot of money, resources, extraction, international interests that are kind of behind. So I really feel like that it's very difficult to look at the situation as that it's completely removed from that massive historical and current socio-political, economic dimension. So that's just one thing I felt needed to be addressed. I also feel that there are some plausible epidemiological, and as I mentioned, entomological, et cetera. Let's look at Ebola, for instance. You have a situation where the previous epidemics from the 1970s on were often in small rural areas where they were began to be recognized because there were a number of these small outbreaks, but they also burned out because there were not that many people. They were more remote. So what you had was you had in West Africa, you had Ebola in a place that had not seen it before, so it went unrecognized for a long time. And then when it really became recognized, it was already in an urban, like very large urban areas because of strife. You had very weakened health systems, and then a completely chaotic international response. And so, and then a lot of mistrust because of, kind of decrees about burial rights and not respecting local conditions. So there's like a big disaster on many levels, which I feel could, also explain, both the situation, also just the transmission from what we know about, how Ebola is transmitted, et cetera. You look at, for instance, the West in northeastern Brazil and in the Amazon region. So that he looks at some of the regions of the blue, which is the low magnetic, and then the red, which is high magnetic fields. And you'll have like in the Amazon region, there'll be low levels, and there's actually not a lot of Zika there. But there's also not a lot of people there, and Zika, and there's also not Aedes aegypti mosquitoes there, and that's what transmits Zika. So I think you can kind of look at the entomology and the epidemiology of, we know that Zika is transmitted by these Aedes mosquitoes that breed in clean water around urban habitats currently, and so that's what we understand, for chikungunya and Zika and dengue, that they're all kind of using the same vector, et cetera. So I feel like there's plausible explanations, and the biology too. There's some mention of kind of viral fragments being in genomes, which is true. For sure there's viral fragments in our human genomes, but but in terms of whether they're kind of re-emerging from the genome, I would say in the case of Ebola and Zika are filoviruses and flaviviruses respectively, and those are actually acute viruses, that they are not retroviruses, and they don't have a latency period like herpes. So they're, as I'm sure so the biology piece. And so I felt that there were some very plausible, like I said, biological, entomological, ethnological, and then up to the historical context. And so I'm not saying that these do not play a role, but like I do feel like we can't just dismiss those other very kind of plausible, I guess you call them mainstream, but I actually, in this particular case, think that they're reasonable. So that would be my first piece.
Does anyone else have any questions or comments? Do you want to respond?
So yes, I do agree with the colonization issue, but one of the things is sort of tie into these society has structures in place. It's one of the things people forget that actually mitigated interaction with some of those spaces. But if you look at the countries, right, Botswana, very peaceful country, Ghana, and if you actually look at the structure of the conflict, you actually see there's like a center and there's spherical shells. That you can actually predict strictly from quantum physics. And I understand what you're saying, like in terms of the diamonds and those regions actually fall along the edges of the large low velocity province. They're called the large linkages province. That's where you have all the kimberlites and everything come up, the diamonds and all those minerals. So yes, there are going to be co-localized because you have these magnetic fields that are located right at that scene. So you are going to see that. So that's predictable. As opposed to the rural, the changes, what's happened over the last, I would say 20 years, there has been a significant perturbation in the Earth's magnetic field. Most people probably not keeping track of that, but they correct it every time their GPS might go off, but there's been a huge change we've seen over the last 20 years, including even in the United States. That's been changing, particularly the last few years. So yes, that has been occurring in those regions, never occur in those regions. You sort of think about it as oscillations. Once those places get excited, okay, those regions, this disease manifests, at least from the perspective of that theory. In terms of Brazil, you're absolutely right. In the middle, there is no, but there's other parts of Brazil that didn't see a Zika, like the southern part, and particularly look in 2015. So I did a correlation analysis to show that the scintillation, the activation of those regions, it was directly correlated with that. So, and if you even look at dengue, it wasn't directly matching Zika outbreak during that same period. So that's a really important thing to sort of like distinguish that from the vector per se. And in terms of biology, you're right in the sense, but these viral elements are actually in the genome itself. There's been there, it's not just humans, this has been in primates and insects. This is millions of years. Okay? So this is relatively new. Over the last 10 years, the evidence has been coming out. And you're absolutely right in terms of the plausible explanation in terms of why Ebola outbreak might occur in West Africa in terms of interaction between primates and bats. But how do you explain the fact that you can actually draw a direct correlation in terms of the magnetic field, lower magnetic field strength, and the number of cases in those regions, and particularly in regions like Northern Guinea where you didn't see any Ebola outbreak? To me, that's like the plausible explanation in terms of where I'm coming from. Yeah.
Yeah.
So I guess I just wanted to, so there are a bunch of things that sort of occur together in the world.
That's exactly.
But it doesn't necessarily, so they correlate. They happen around the same time, but it doesn't mean that one thing is causing the other or one thing is like affecting the other. Or they might actually just be occurring together randomly and they have nothing to do with each other. And I guess I think what I read from your piece is that you're saying that you think that this is actually sort of a causal factor, and I guess I'm just trying to figure out, what the mechanism is, like how is the magnetic field impacting, if at all, this the disease outbreak, and then I guess related to that, just how this framework discounts sort of competing frameworks of understanding the trajectory of Ebola and whatnot.
So one of the things, I probably didn't put it out there in the paper, but if you look at Western DRC, the Equator region, it has pretty high magnetic field strength. You look at Kivu going up to Ituri. The Ituri, just small part of it has low. Down Kivu is all low magnetic field strength, so you can actually predict based on that. The mechanism, to address the mechanism is, you got to think of it from a perspective of quantum physics. And I get it, that's not where we biologists gotta go when we think about how biology works. But at a fundamental level, we're all made of matter. I mean, it's pretty much atomic interaction that's going on. And those electromagnetic waves can interact with the human genome. And that causes transformation of those genes, where that virus sort of emerges from that. To put it another way, just like cancer. If you get irradiated, you get a disease. It's really a transformation of your own cells. It's sort of the same concept that's sort of, you can sort of see it from that perspective.
So my question was exactly that, the mechanism. So first of all, I'll just say that, and Esther and I both work intensively on immunology between dengue and Zika, et cetera. So there are actually ways to, other than the entomology, there's a lot of immunology that explains the waves of dengue in relation to Zika, and actually might have an explanation for actually the microcephaly, et cetera, which is a really interesting thing we were talking about this morning. But I mean, I think that there's that as well. But I think that what you were getting at also is that you have correlations and you have association. I didn't actually see a predictive model here. What I saw was correlating. You said you predict the number of cases, but regardless, I feel like you can correlate things and associate, but it doesn't mean it's causal. And I think that that's a really critical point. And I also think, again, going back to those viruses, I mean, there are pieces of it, but the structure of a filovirus or of a flavivirus is of a particular, as you know, right? I mean, there's like 3 structural genes and 7 non-structural genes, and it's packaged in the lipoprotein envelope, et cetera. And that's not what's actually in the genome. So I'm not sure how that's going to, cause that flavivirus or that filovirus epidemic. And maybe I'm misunderstanding what you were saying, but I'm still kind of. One issue is kind of the causality piece, and the other is what the actual mechanism. And I can totally believe that magnetic fields are affecting people in ways that we do not understand. And I'm all open to figuring, seeing new ways of explaining things. But I do think that, just trying and figure out what would that mechanism be. But in this case, these 2 particular cases, I think that there's a lot of evidence, that is kind of, though it be mainstream, is still plausible.
2 other questions.
So and I was sort of struggling with this as well, but I wonder, is one connection possibly that it maybe changes the susceptibility to initial things, right? And then you have everything else is going to determine how a disease pattern unfolds. And then it would be interesting to look, are there, surely it would have other effects, like in animal populations or like some other effects. Could you use this sort of pattern to show patterns in other areas, which would then be really interesting to see that maybe there is some susceptibility, and you don't need to say this is an alternative explanation. I don't know that you need to do that to say what you need to say.
Yeah, I totally agree with you. You can actually argue, we've shown that mosquitoes are affected by electromagnetic field. That's been demonstrated in terms of the feeding. Bats are also affected by electromagnetic field. So yes, there is a plausible explanation in which you can argue that mosquito bite more, and that's been demonstrated in the laboratory, bites more with perturbation, and bats might move further about. Yeah, I totally agree with you on that. I took the route of following, because that was basically the insight, where the insight came from. And yes, I'm quite aware, and I think I did put in the paper, there's an alternate explanation for all of this. I completely agree with that, but I took that route because that's where the insight came from. Yeah.
Just an anecdote. I think there was in a news recently that certain songs like dubstep from Skrillex inhibit mosquito mating and reproduction.
Come again?
All mating. No, they don't like that song. They don't like it.
On the record?
Yeah. I think they're now big hits. Yeah, I don't know. Maybe if they put, I don't know, other kind of song, it would have the opposite effect.
Party at Ernesto's house later.
Yeah. Not with.
Ernesto's going to sing a song at his
Any other
house.
comment at all about this very intriguing paper? Yes.
So right now, are you at the stage of just observing and making these connections? Because I'm just trying to think about, so if you're right, there is this connection, and maybe even at some point the causality is demonstrated, what then? What do we do?
Yeah, so
Is it planning?
right now, the paper is really sort of drawing up a framework, and so Dr. Harris is actually right. I didn't predict anything. I just show that there's this really good correlation between these. And like I said, a lot of it was looking at these actions of these individuals and say, is there something else to that than just sort of dismissing it and saying, it's sort of based on a primitive belief system or superstition beliefs. And really sort of thinking about it, sort of going back to these cultures, how did they live? Because if you sort of look at it, it has certain structural arrangement in terms of how they move around in the social space, in relation to geophysical changes, in relation to day and nighttime. Maybe that's something we ought to consider, even if just sort of testing it out, by, let's say, restricting access, because one of the things that you will find that these outbreak occurs around water regions, okay? So one of the reasons is because water sources, lakes, they have really poor clay content. Can you restrict that and sort of see any changes in that? And yes, I completely understand the germ theory and where it's coming from, and there's strong basis. That is how I propose hypothesis. That's what I do in my lab.
I know.
I saw that. And trust me, I know it sounds, you might think this is absolutely crazy, but if you look at it from an anthropological perspective, you sort of get blinded by the way you think and the way you see your society, how it's structured, and how you see other people. And I think part of it, I'm a soldier, so everything is situational. You always question your own planning. You sort of war game it and say, okay, how can I be wrong? How can I be totally wrong about the way I'm seeing my enemy or whatever, okay, my adversary? And there's really this perspective of how could we be wrong about how these people are seeing diseases? And is there some plausible explanation for the way in which to see? Really, that's what this paper is about. Is there a plausible explanation for what they're saying, that these aberrant forces are emanating from the earth? And I mean, the correlation is pretty strong. If you look at the large low shear velocity provinces, they come from exactly where you see these outbreaks occurring. And if you look at the ring structure, I don't have it in the paper, but if you look at the ring structure, how these conflicts occur in Africa. And if you even look at Nigeria around the 2014 and 2016 period, okay, so West Africa and Northeast Brazil had the highest amount of scintillation. If you look at a conflict in there, it increased and it went down, and you sort of has shift. So really, that's sort of the driving motivation to sort of propose this new hypothesis.
All right, I'm going to close this up and we'll move to our last article. Thank you for everyone's participation. Do we need to get a microphone?
So the last article is entitled High Resolution Vaccination Coverage Data to Assess Spatial Heterogeneity and Inequality of Vaccination Coverage and Disease Outbreak Risk in Countries Around the World. And our author is Dr. Van Pugh, who is an assistant professor in the Department of Biomedical Informatics at the University of Pittsburgh. And the commentator will be Dean Burke of the School of Public Health and the Associate Vice Chancellor for Global Health. Go ahead.
Thanks. I had some slides that I wanted to show as part of this intro comments. Okay, thank you very much, and thanks for asking me to present the paper. Just a few quick introductory comments about high resolution data for vaccination coverage. So now I am going to go to the next slide. Yeah. So of course the idea that is driving this and all of our work at the Graduate School of Public Health that I'm leading is the idea that there is epidemics that come and that are always threatening populations around the world, but that are we really prepared for them? And I'd like to show this quote from Bill Gates in the New England Journal of Medicine saying that you know, he's been very actively talking about the possible next flu pandemic or other pandemics of disease X is that we need a global warning and response system. And do we really have a system in place that if we get an outbreak that is starting somewhere, that we can respond quickly? And from our perspective, we are looking at, are the data systems ready to process and present and disseminate information rapidly to researchers and policymakers around the world to respond to appropriately? So one thing is that in our work, we found that the status of health data and public health, especially going back in time, is not great. Especially if you want to have a global warning and response system. The ones that I'm showing here are not the ones. Because and these are data about epidemics. And as we like to say, we build models of disease according to the future. But we have to look at the historical patterns first to understand and to anticipate what's going to happen. So here you can see our travels around the world. Here is right next door to Hillman Library, a repository of federal documents about disease. Nigeria, but also Netherlands, where I'm from, same situation, Nigeria, and then going to Pittsburgh here as well, Allegheny County Health Department. These are polio records. And so all these data, and we're talking about data and evidence-based public health and using data for decision support, et cetera, but nobody's using this. And this is just one of the challenges, which is a technical challenge of data entry, data processing, data preparation, and that's what I'll focus on a little bit now during this intro. That's why I want to introduce Project TICO. This is one of our projects at the School of Public Health, a repository for data. One thing that we do is we take data from all kinds of places that are difficult to use, and we transform that through hard work, standardization, and integration into ready-to-use data that are actionable, that can immediately be used for policy support and research. Currently, we have US data going back over a century in time. These are weekly data for about 50 notifiable infectious diseases, and we have global dengue data for about 100 countries, also going back to the 50s. There's about 4,000 users now that have used these data for all kinds of nice additional research that we didn't do, showing the value of open data. Just one quick thing that here you see a lot of hard work. I won't go into much detail, I've got 1 minute left. But here is the graph that we did and then some of the values. So now you think about these data sitting in boxes, right, and in these books. Who can do something? But now we digitize it and you can do these graphs for the scientific results as well as advocacy, talking about misinformation, for example. So here is data, weekly measles incidence rates from 1928 to the 2002 for the whole country, right? You can see here, epidemics of measles. And then every state in color coding. So red is high incidence rates, like here. And blue is low incidence rates. Some states have very low incidence rates. And then black is missing data. So here you can see some states with no data. Each state is listed. And so you can see all these measles outbreaks everywhere until we see this big red line. And that's the vaccine. That's the measles vaccine licensure year. And so after that licensure year, you can see immediately the drop of measles incidence rates. And the contrast between the era of measles and the era of measles elimination is very, very stark, right? And there are very few things that happened right there that could have caused such an abrupt change. And so this is a very powerful image of the success of public health. Okay, so here you can see weekly data by state for measles cases. Now, you know, what is the status of the vaccine coverage data? So you know that this happened because of the vaccine. Here is the vaccine licensure, and there are subtle differences between each state that must be due to the differences in vaccine introduction. And currently, we see a resurgence of measles. I gotta stop. Resurgence of measles in the last couple of years, right? Due to vaccination issues. So what do we have for data on vaccination to explain the disease patterns? And this is what the paper is about. Currently, if you look for data, it's mostly state-level data. So this is the map we can draw about vaccination coverage in the US using publicly available data. One color per state. And so the idea is to go to another example, which is California was really spearheading this. So where you see each school listed on the map and their rates, right? And you can see red schools with bad rates and green schools with good rates. And this is the level of resolution that the data are being collected. So you could make a map of the US with every school showing and their vaccination coverage rates and have really detailed information to explain patterns like we see here, right? And so that's the goal. And that's what we advocate for in the paper at the global level, is to say we should go away from these high resolution aggregate data. We should, in the current day and age, we have the possibility to go to very high resolution, very detailed information, and bring like local health situations all the way up to the global level. And that's what the paper is about. Thank you.
Okay, Dr. Burke.
Well, thank you. Dr. Van Penhouse has taken on what is a very important issue for public health. In the paper, he goes into more detail on measles in Massachusetts, in several, and other diseases in Nigeria, measles in Nigeria, diphtheria, tetanus, and pertussis in the Philippines, yellow fever in Angola, and several countries, and takes the same approach of looking at not on what are the coverage at the national level, but what are the coverages at the subnational level, and getting as granular as you can. And not surprisingly, when you do that, you see that there are islands of susceptibility that may be scattered throughout a country that otherwise has relatively good coverage for the general population, but with these pockets of susceptibility. It's been said that all politics is local. I suspect it's all vaccinology is local as well. And we're seeing that in the United States, of course. Most of the outbreaks that have been seen so far have focal beginnings in populations that are anti-vaccine for whatever reasons, and they are you have groups that are clustered together. The challenge is to how to get these data into a form where they can be used systematically. So we have these state data, but right now in the United States, that they are not put together anywhere in a coherent way. And interestingly, and what Dr. Van Penhouse showed was that even the severe disease reporting wasn't put together in a national data system until Wilbert did that, which was a heroic undertaking. And as he says now, it is an example of what can be done by looking at large-scale patterns and understanding. I have a term for this. I like to call it synoptic epidemiology, that you could get a feel for a lot of things at the same time by doing it. That he didn't go into is that there are many barriers to making such a system work. And in another earlier paper, Dr. Van Penhouse and colleagues did do a systematic review to ask what are the things that keep us from doing this? They fall into, and he got into some of the issues of the technological but there are political and interpersonal and financial, and there are a whole series, and so I applaud his approach to turning this issue into a science in itself. Is how do we understand the sharing of information in a way that allows for sound decision making? And so in the paper he gives several examples of aligning data where we have granular data for different diseases and what the disease consequence of that is. Like in the United States, we've seen that measles is where the measles immunization rates are low. And at this point, I think we could, with good maps, we could say there are the risks, and if we want to mitigate the risks, what we need to do is focus there, and there. And the same could be said for yellow fever, the same could be said for pertussis in the Philippines, the same could be said for measles in Nigeria, and the question is, can we put these systems together? The challenge is that currently most of our international data systems they get aggregated on the way up. And so when you get data from the World Health Organization, it tends to be data which is at the country level. And although that's good for comparison of countries, it is not very useful in terms of operational decision making, nor is it very useful for analytics to understand what are the processes and what are the thresholds and the like. It doesn't help advance the science of disease prevention. So again, I applaud the paper, and more than that, I applaud the effort to try to get the international system moving in the direction that it should. I should say, of course, that PAHO has this locked. It's not a problem for PAHO, so I'll put.
Sure.
I'm trying to be polite. It's a problem for the United States. It's a problem for everybody now, because we now are able to take primary data at the granular level. We couldn't do this 10 years ago, 15 years ago, and now we can. And so, but the systems aren't in place. So, I would, my question on all is maybe, one straight down the middle to you, but as a fastball down the middle. Maybe So are we making progress in this area? Is it going to be possible to solve these problems? Are we going to have international data systems that actually help us make decisions at a mechanistic level anytime soon?
Define soon.
Yeah, thank you for those comments, Don. And
wait a second, I called you Dr. Van Haas.
You're esteemed Dean of Senior Vice Chancellor. I would say as long as there's WHO, I'm not sure. No, that's not true. No, it's. I think there's a major encouragements in moving forward with this field, as you said. Even now, I was at WHO last summer, and they're collecting disaggregated data. So I think the global health community, I don't know PAHO what's happening, but actually there is. So they are collecting individual case records, for example, for measles or polio from around the world, even at the top of the global health level at the World Health Organization. So instead of collecting aggregate data, they are collecting individual case record data now. Okay, 5 minutes. So, and vaccination coverage data the same way. They are moving towards asking countries to send admin 2 district level data, which is a county here in the US, up to WHO. Which is really encouraging because, as you said, policy making is going beyond country-to-country comparisons. To understand what's going on, we need to go within the countries and identify the areas. So for measles elimination in the US, it doesn't help to say the US, you need to improve your coverage rates because the average coverage for the US is already very high. The reason the measles are not eliminated here is because there are pockets there, and so even at the global level, you'd want to know all these pockets. Globally to make real recommendations for strategies and for investments and campaigns. And for research as well, the same kind of constraints. Otherwise, we can't get to a mechanistic understanding. And I think PAHO has been leading the way, from what I hear in WHO, in showing and making online portals for disaggregated disease surveillance data, disaggregated vaccination coverage data. The only caveat I would say is that the current system in global health is siloed. There are different repositories in many different organizations, and even within WHO, there is PAHO that has its own organizational structure and data system, and then there is WHO that has also its own organizational structure and data system, and then the World Bank, and so on and so on. So what we're trying to achieve is some kind of system that can link data between these various repositories, not trying to tell everybody to do a different thing, because that's not gonna happen, but to try to encode things in a standardized way where the standards can be linked to each other. And then you can come to kind of like what they call a federated or network of data systems where people can actually, or computers could retrieve information much more rapidly. And then we can take out the human data munging component that I just showed. And that's kind of where we're trying to head. And I think there is a lot of encouragement, and I think we'll see a lot more progress in the next couple of years.
I think Dr. Burrs had a question.
Vaccination, and just talk about the U.S. here, is an area where behavior has been highly influenced by policy. The rules basically work. That's why we have a high level of vaccination. But by going to schools, as the unit of analysis, then you likely, to me, you probably put your finger on your data finger on the fact that the implementation, the sub-rules, the way that the principals or the school nurse handle the exemption process, and the follow-up for people who are hesitant or haven't gotten every shot, so they're behind on the full spectrum. My hypothesis would be that's probably one of the biggest causes of difference among schools. Because the people, there's certainly going to be, Marin County and people who, believe in crystals and stuff. But by and large, those people are sort of distributed across the terrain, and in places where the rules are enforced, and they have to choose between having their kid go to school or not. Chances are they're going to send their kid to school. So it seems to me that this is a great instance of where the need for data to really do something about this problem is not just for the epi data, it's for essentially for the policy implementation data. And that's actually probably quite a manageable task. I did have a grant application from somebody who wanted to do that, and unfortunately the rest of the group gave it to somebody else, gave the money to somebody else. But I think this is an example of why this kind of data is incredibly actionable, very rapidly actionable, because it gets us down to microcosms of the country where we can look at specific factors that are valuable.
Yeah, I think to respond to that, I think that's a really excellent point. The one observation I would put with that is we've done some analyses of behavior and of the laws, vaccine laws, and so it's not against the law to the vaccine laws are state specific, right? So the states decide what's required for school entry. And there are three types of exemptions for vaccination: medical, philosophical, religious. Some states offer all three exemptions, some states only medical exemptions. So in the states where only medical exemptions are allowed, vaccine coverage is high because it's illegal to send a kid to school without medical. And I don't know the enforcement at school, but we don't see outbreaks in states. Mississippi is one of them, and some of the other states that have those. West Virginia, yeah. On the other hand, states that have allowed philosophical, religious, and medical exemptions, you see them being used. And school nurses sometimes just need parents to bring a form and say, I'm against vaccines, and that's it, to legally enter the school and not be vaccinated. And so you do see some areas where there is community sentiment against vaccines for some reason. They go to specific schools, they know the routes of getting the exemptions, and there you go, and they know the doctors who would give medical exemptions if the medical exemption are the only ones allowed, or they would know them. And so it's a massive landscape. And I totally agree that this level of data, I think we should have this map for the whole US. partly for the legal to see that, but also partly for advocacy. I mean, I'm not a parent, but I would want to know where to send my kid. And so we were going to do a whole social media campaign and say, is your school safe?
Entire day.
And this is about security. Yeah, okay.
Three more questions. Then I think if you want to talk to Dr. Penthouse by yourself, that would be great.
Just a question is, can you tell us a little bit about how you are doing with the quality of the information, the difference in quality of information between different systems, or what you know about it, and how you're using it in order for the user to understand?
You got 30 seconds.
Okay, I got 30 seconds. What we try to do is go back and capture information about the methods that we use to collect the data and have quite detailed source information. In the end, users at this point have to decide what to do with that. So we don't try to police the data, although in the future we do try to rank sources based on their methodological rigor that they've been using.
More questions over here, I saw.
So just quickly, to build on this, so one of the things I worry about is the political sort of choices made and what gets measured. And I wonder if you sort of looked at this or how to fit this in, right? That what you're doing increases the power of data, right, to influence policy. But in order to use that data, it has to be where you have to have funding to collect things. And so I'd just be interested in the political landscape of, are there foundations now that are thinking about this and engaging? So entrepreneurship would be a good example. There was a sort of there was a political sort of basis for creating these whole metrics we have now to measure entrepreneurship indicators in different countries.
Yeah, excellent question. Just a point in case, at WHO there was this discussion with unmeasured populations, for example, and saying, okay, we've got all these vaccination coverage data for all these different populations. How about migrants and refugees? They don't get covered, and they're not part of the constituency, so they're not. And so there are people that are aware of this, but then we as data aggregators can only use what's been collected, but we can absolutely advocate and point out where the gaps are and what the unmeasured parts and populations are.
Okay, last question.
This happened last time. So this is fantastic, and I would say again, from my perspective in the social sciences, to be able to use this kind of material is absolutely fascinating. One of the things that I would say is that I think there's a real opportunity and space for collaboration in terms of the kind of data aggregation you're doing. I think this speaks a little bit to the point that you're making about how it's being used and what is included and what is excluded for qualitative studies about these kinds of historical phenomena that you are tracking, to then sort of meet up and to communicate that material better. You and I talked briefly about this before, but just from the perspective of the kinds of research that could be generated by history grad students, by anthropology grad students, that could feed into these kinds of conversations, I think the possibilities are fascinating. It's really exciting stuff. That's just a great job, Wilbur.
Thank you.
Well, so great job, everybody.
Good afternoon, everyone. My name is Professor Gwendolyn Roberts-Majette. I am a health law professor at Cleveland Marshall School of Law. I write in the areas of healthcare reform, global health law, and think about health equities. And so I'm delighted to be here and to be a part of this interdisciplinary panel and to hear from the scholars that have written articles as well as the esteemed commentators. So we're going to begin today with our first article from a paper written by Mr. Eric Friedman, who is a global health justice scholar at Georgetown Law School. He works on their framework convention on global health. He's responsible for working on that project. Prior to joining the O'Neill Institute, he was a policy advisor at Physicians for Human Rights. So Eric, if you would please.
Sure. So thank you very much. So just very briefly, the basic background for this paper is that on the one hand, we know there are these gross health inequities within countries. And so a basic thing is, if Thank you. If you're going to address these, what are you going to do? What's your plan? So the basic question is, do countries actually have comprehensive plans to address health inequities? But from what we could tell, most countries don't. Sorry. So most countries don't actually have plans to really address health inequities, despite the huge promise or problem it is. At the same time, we have a window of opportunity, particularly with the SDGs. There's all this, we say the big phrase with that is leave no one behind. So we're actually going to do that. How are we going to do that? And that led us at the O'Neill Institute to develop a framework, what we call the Health Equity Programs of Action framework, that would actually hopefully encourage countries to develop plans to address health equity comprehensively, looking across both health systems and social determinants of health, looking at each population, recognizing that there are a lot of similarities across factors causing inequities across populations, low income, poor education, discrimination, so forth. There are also very specific factors that are different if you're indigenous or a person living with disability and so forth. Those need to be addressed too. So with these and some other points, we developed a 7-principle framework. And just to highlight, the very first principle is actually how these plans, these frameworks we envision being developed, which is through empowering participation, because the idea is that even though the plans might not actually be implemented, at least the process itself could be empowering, could make a difference, change the political dynamics. So we developed a comprehensive guide about this, and now we're trying to encourage countries to actually do this. This paper is part of that project, submitted to a journal, submitted to a journal as part of publicizing the effort. We had limitations with that. It was 2,000 words. It was actually more than, this version is a little more than that. I also, with apologies, when we submitted to the journal, there were different files you had to send for the boxes and tables and all that, and I didn't realize that until yesterday that I hadn't sent you the table and boxes and table to which the paper refers, so sorry about that. But that's the basic background to this paper.
So we're a little bit different. We are co-commentating. So I'm Tina Hershey. I'm with the School of Public Health. I'm a lawyer as well as I have an MPH. So I'm going to start off. I first wanted to say that this was a fabulously written paper. It was really a pleasure to read. So it's always nice to have a well-written paper to comment on. The idea you propose, national health equity programs of action that focus on social and structural determinants of health, it's a really interesting idea. As we've talked about extensively already today, the evidence is very clear that these social determinants have a significant impact on health. Therefore, approaching the problem of health equity by establishing, as you say, targets, a set of actions that are costed, as well as accountability frameworks and a timeline framed within the principles you developed will provide countries with a more concrete plan of attack. And I just wanted to say to the group what these principles are. So I'm going to read these from the paper. There are 7 principles. The first one is empowering participation and inclusive leadership. So basically talking about engaging diverse populations and communities who are experiencing health inequities. The second principle is maximizing health equity by addressing deep structural determinants such as systemic discrimination, political exclusion, and control over resources. The third is health systems and beyond. Governments need to integrate equity through health plans or policies and programs. So really moving beyond just talking about the health systems, looking at sort of systemically. For the fourth principle is every population counts. So really looking at all the populations that are experiencing the health inequities and identifying those populations, underlying the factors that are influencing their inequities, and then proposing policies for that specific population. The fifth principle are actions, targets, and timelines. So moving beyond sort of the conversation, but actually having goals and targets. So the program of action must be action-oriented with specific policies and programs developed. So really getting into the heart of the matter. 6 is comprehensive accountability. This is where we talk about governance, including transparency, curtailing corruption, and accountability. And also reporting on progress and having that transparency. And the last principle is sustained high-level political commitment, which is required for successful intersectoral action, coordination, and implementation. And so this is really asking for the heads of the governments to oversee the development and implementation of these health equity programs of action. So I wanted to provide that sort of context as we begin this conversation. So I really liked in this paper that you talked about moving beyond the assumption that improving health overall will improve equity. These 7 principles that you proposed really get to the heart of the matter. That in virtually every society, there are these structural and systemic barriers that must be understood in order to achieve equity, in order to really dismantle those barriers. You also emphasize the need for community engagement in this process and how every population counts. And I think we can tie that back to the conversation we just had about national programs or more localized programs. So I wanted to ask you, we just talked about vaccination and how it needs to be more localized, and that's really a data conversation. But do you think these are really national programs, or should they be more localized?
So, one second. As we developed the program, the original idea, we actually originally called these national health equity strategies. A lot of feedback, part of it was just too many strategies out there, don't call it that. But part of it was the idea that we want something that's more flexible for countries. So I think we envision, ideally, there would be a national strategy, or maybe integrated with the National Health Plan. But we hope that presenting it as 7 principles of framework and not just the strategy, is that most of these could be applied in various ways at various levels. So it means, like in the US, probably with the government now, a lot of cities are really taking the lead on this where the national government isn't. And so they can't do everything. There's things that have to happen up above, so to speak. It's the same way you can't try to achieve complete health equity just by looking at a single disease, but a lot of these principles could be, most of these principles could be applied both particular diseases as well as at different levels of government. So the ideal thing is what we focused in this paper and in the guide, especially on national strategies plans. The idea is that they'd be flexible enough that you could, just as you say, apply them at any level, any sort of health.
You also raise a really important point in this paper about data and the need for data over time and disaggregated data. We've talked about that during today's conversation. And I think this is a point that really can't be emphasized enough, that we need to collect that data, we need to report on that data, because without good data, we won't really know if we're making progress in the fight to end health inequities. So I just wanted to commend you on making that point in this paper. I did have a question for you about how the law fits in within the health equity programs of action and these 7 proposed principles.
I guess in talking very broadly 2 ways. One is the basic, the basis of them is in many ways human rights law. So countries, this is a way for countries to actually implement their right to health obligations, but it cuts across so many things to implement many human rights obligations, to say the least. And the other is what actually has to be changed to make this happen is that, it's at the legal, it's the laws, it's regulations, it's policies, it's strategies. Countries should, especially, at the very least, you need to get rid of anything that discriminates against people, so it's a big task in your legislation, but also be much more proactive as well, whether it's, setting national funding targets or, laws, implementing the Convention on the Rights of Persons with Disability, which includes legal tools and accessibility, different ways you're addressing indigenous people's rights. And so certainly one of the key policy levers that would, one of the key things that need to be changed in a whole bunch of areas would be.
Okay, so we divided ourselves, we kind of got together since we had to talk about, so agreed, totally great paper, I'll start with that. My thought was just, I was given more the practice role. So my thought was really, how can we make this feasible? Like, what are those things you need to think about to really put this into place? And so totally agree with Tina, and I'll start first with measurement data. So I think it's really great that you added that in. Really important to be able to show, as you said, if we don't measure it, we're not gonna be able to tell whether we're getting there. Questions that would be really, who would manage these efforts? And knowing we only have a couple minutes, I'm not going to get you to necessarily answer them all, but so maybe take them more as your comments, and I'll let you discuss it then. Kind of really, who would manage this? Knowing I work at the Department of Health and Human Services on Healthy People, which are our U.S. national health objectives. We've been spending a year with hundreds of people working on coming up with about 300, 400 measures of what we as a nation want to measure. How are we going to get to that for everyone around the country, knowing the resources that we have to do it? And if we want some type of common measures or data, really, how do we get there? Who's in charge of that? Is it someone like the UN or WHO? Is it each country? And I know you mentioned, which I think is super important, technical assistance and having others to help out. But just thought some of the statements are, I think looking at them, exactly, I agree with them. They're idealistic that we should help those others, but knowing governments who are really strapped, how are we going to get them to put those resources kind of into actually doing it to make sure we get that goal as a global look at, are we achieving health equity? So that was just kind of one take. Otherwise, I think as far as political feasibility, I think some of the examples you had around maternal mortality in Namibia and Peru, or your participatory slum upgrading program, I think were really helpful. What you mentioned later, the boxes you sent, I think had more examples. Our thought was really to make this real. Anytime I read something high level and visionary, I leave it and I say, this is great, we should do this, but I don't actually think I take it home and think this is how I'm going to do it. And so I think examples like that, did those communities use these 7 principles? How are they seeing a difference? Like, how did they actually do that to kind of show the data and the difference they're making, I think would really make it approachable for people and something that they can maybe see taking on themselves. And maybe not taking on a whole health equity strategy. These groups looked at something like maternal mortality, maybe picking out a couple goals to start with to figure out how they integrate and look at the data and how they might move forward together, that at that point maybe they can share lessons kind of globally with a UN or a WHO or someone like that. And then I have, I think, one final kind of, I don't know, it's Friday afternoon, I figured might as well put something out there. When I looked at the goals, I know you focused on health equity. I totally agree with you, huge goal, something that really needs to be focused on. But knowing that you really structured it based on meeting our SDG goals, was actually wondering, I think as a health person, and I'm a health person, so I think I can say this, we tend to put ourselves in the center and make health what we're measuring. But we've talked a lot, and you talked about the fact that we're really trying to bring other sectors to get the high-level government involved. Was almost wondering, what if you made this an SDG equity framework? Because if you look at the SDGs, health is only one of them, climate change is one, education's another. I think what we've seen in the US is that if we reached 4-year high school graduation rates and some of these others, we actually might see the biggest health impacts. And thought maybe that would also get some of that high-level buy-in of the government saying, hey, we need to address equity for these broader principles and get the sectors involved in health. And I'll let you give thoughts on that, but it was just I'll throw it out there since you already have a paper accepted and have great people on it. Promise.
Thanks so much. So all great points to address this best I can, I guess, are the 3. First is who manages. It's an excellent question. I'd say at one level, it's very much sort of in each country it will be different, I assume. Yeah. And one of the reasons that we're not, and even in our longer, we have a 100-page sort of framework on this, that's not particularly descriptive about that. I think because it will be different in each country, and we see the process itself as so central, sort of this empowering process where even the Salon Cleaning don't sort of say, here are the solutions, it's more about here's the people you need to involve to find the solutions. That's sort of what I would say with that. In terms of my answer more than your question, but sort of making, the examples and making it real. So, I mean, in terms of actually our particular 7 principles, I mean, they're not new in terms of empowering participation. No, that's a new idea. But it's sort of in this framework way it's new and hasn't been used, so it's not like there's examples of countries that have done this as such. But I do think in terms of, as we sort of look at how we actually get countries to do this, sort of 2 thoughts we had. One was examples on each principle, and even possibly our hope is to work with PAHO we're sort of in early discussions with them in terms of going forward with some of your help there, that maybe there are examples from that region elsewhere to say, well, you haven't done the 7 principles, but here's principle 1, principle 2, here's what that can look like. And even for some, particularly the participation, here's sort of a practical guide to principle 1s, especially, I mean, the participation, because I think they're very real obstacles. So how do you work with communities? Who are the ones? And so I think some very practical guidance, I agree, would be useful. And also that it could be more disease specific. The talks we've had early with PAHO are, could we actually find a country or two that would be interested? Or to your earlier point, Tina, about localities, maybe there's a province within Mexico or Brazil or somewhere that would be interested. But also talking to a group that has more of a maternal, sort of looking broadly, but still more maternal health perspective. And so maybe is that the lens, because that people have just totally laughed this idea out is a little surprising, because it is a very big comprehensive approach. And so starting smaller and building up realistically makes a lot of sense. And then SDG equity framework, I think that's a great point, since one point I think we make in the paper is that countries could see this as a lens to SDGs overall, because to actually achieve health equity, you need to literally, there's not a single SDG of the 17 goals that doesn't touch on health equity. I come to what you said, we come to the health space, so it's about health equity, but it's true that basically you need equity within each of these to have health equity. And so we've thought of it in terms of, who would organize it, and it'd be a point person. Maybe if there's an SDG plan in the country, it could be through that, or if there's an SDG advisor to the Prime Minister President, they could take charge. I think that's really important point to make, that if we sort of frame it alternatively, that would just, you make the education sector and just get a lot of people on board. That is, we're not just helping those health people, but this is also about us. I really appreciate that.
And I think I was going to say,
we actually are not going to be able to take any more questions because we have 3 more people and they're supposed to get 18 minutes. I know. And so we're going to continue this lovely conversation later. And so our next presenter is actually going to be presenting to us all the way from Kenya online. That's so awesome. So the next paper is going to be Addressing Global Health Inequity in the Global South Through Reform of Procurement Process for Medicine, from Vincent Mutai, who is an SJD candidate here at the University of Pittsburgh.
Can you hear us, Vincent? We can't hear you yet. You might still be on mute.
Is there like a button?
Act it out.
It says mute all at the bottom.
Yes,
I was looking for the mute.
he was already unmuted, so.
Can we hear him now? Turning off mute is also what's that? Is it a big there so we can see it? Yeah. Since we're taking
It worked before. Can you still hear us?
Hello, everyone.
Yeah, we're here. There we go. Go ahead.
Hello?
Yeah, we're here.
I don't think he can hear us.
Can you hear us now?
I don't think he can hear us.
Talk.
Tell him to talk.
Talk. Just
Sign language.
Where'd he go?
Hello?
Yes, talk.
Yes, yes.
Can Good evening. Good afternoon. Thank you. Good afternoon, everyone. Today I'll be focusing on enhancing access to justice through a reform of the procurement process, particularly the Global South. I apologize for the technological hitches. The reason why I started this research was because of statistics that are fairly damning, to the extent that 80% of the deaths from communicable diseases and other such conditions, which represents about 20% of the global total, occurred in the poorer countries of the world. Yet these are conditions that can be cured or can be managed through the procedures and policies that are available in the developed world. And part of the reason I attribute this is on the shortage or lack of access to pharmaceutical medicine and the availability of ineffective medicine. It is through the procurement system that you determine availability and quality of medicine. Yet in studies, these two items are seen as disparate or discrete for purposes of analysis. The global international trade regime, which covers everything from cars to medicine, is one and has generally excluded the rules designed to limit favoritism against against foreign producers. Unfortunately, particularly for the developing world, they are net importers of pharmaceutical products, and the types of conditions that need to be addressed are not presenting or do not present profitable opportunities for foreign pharmaceutical companies. And so my thesis, or the point in this paper, is to encourage or at least look at the idea of acceding to the WTO agreement on government procurement as a first step in enhancing access to medicine in the global south. This would facilitate movement of pharmaceutical products across the boundaries, and also a greater transparency in conduct of trade in pharmaceutical products. Thank you, and I look forward to your comments. Thank you.
So Vincent, can you hear me? No.
Yes, I can hear you.
Oh, good. Great.
Took you by surprise.
Okay, great. All right, well, this was a wonderful...
I hope you heard me.
This was a wonderful topic and very provocative. My background is as an international economic lawyer, but I have to say I know very little about either medicines trade or procurement. So in trying to learn for reading this article, first, what the material Vincent's already put together is extremely helpful. But second, I came to realize that it does seem to fill a very important gap in the literature, because there seems to be very little on the nexus between access to medicine, corruption, and procurement in the developing world. And Vincent does cite a couple of pieces that are useful jumping off points. But those pieces don't really seem to discuss the trade regime. And at the same time, in the trade regime, there's some discussion of the procurement rules, especially after the 2012 reforms to the government procurement agreement at the WTO. But there's not that much on the impact on developing countries, and what little there is sponsored by the WTO. So there's a book put together by Sue Arrowsmith and Robert Anderson, which Vincent cites. And then there's another lawyer who writes in that book, who's a German-trained lawyer, who's now working at the WTO, talking about the impact on developing countries. So there's a sort of gap in voice here that really needs to be filled, and I think this is a very important paper for that reason. I think Vincent's argument is very well stated, that the WTO procurement agreement is one which has some very deep-reaching reforms into the state to alter its procurement process to be more transparent and open. There are very specific obligations surrounding tender processes and all these other very technical things that go on when governments buy things and have open bidding processes. The theory, I think, is that a more transparent and open process can lead to better quality and price. That happens through at least two vectors. One is that if you open up your market to competition, you just get lower prices and more innovation and better efficiency. So if previously local firms were getting sweetheart deals from the government, they're extracting rents that are now being sort of removed by increasing competition. And then the sort of second vector, which I think Vincent focuses on, and rightly so, is that less corruption means less rent seeking from the people who are benefiting from patronage, and is more incentive for foreign direct investment or trade to come in, and because they won't have to deal with bribes, et cetera. And so all that can lead to a virtuous cycle, and joining the WTO government procurement agreement is stated as being a first step in improving the procurement process. So, so Vincent's paper sort of sets the table, and then there's a part 4 about how this is all going to come together to do this virtuous cycle that's yet to be written, which I think is great because it's sort of a canvas on which we can paint in this workshop and carry it forward. And so what I'm going to do is just try to throw out as many challenges I can think of to this thesis that there will be a virtuous cycle, and together, we can sort of try to come up with some responses to those challenges. That was a little hard to do, I found, at General Point, because it's hard to find straight talk in this field. So if you look at statements by governments on why they aren't joining the procurement agreement, those are governments, and you really can't trust governments to sort of talk straight. And then academics are also invested in institutional actors. As I mentioned, the literature on this is copyrighted by the WTO, like the leading book on this. So it's very difficult to get straight talk. But you can start to see where the problems are when people who are arguing for, it's often very evangelical literature, if you just let the WTO procurement agreement into your heart, then everything will, just work for you. But you can see where that literature pivots from being an economic argument to being a political normative argument, to being a practical argument of like, oh, well, we wish we could do more, but the WTO is structured this way. And when those pivots happen are where the gaps in the arguments are. So that's sort of a general suggestion for reading into this literature and trying to find the problems. So why, other than corruption, might developing countries want to avoid open or competitive procurement? So they may want to protect either declining or emerging industries. They may want to protect particular regions. They may want to protect particular populations. And so a piece that Vincent cites from Christopher McCrudden and Stuart Gross in the European Journal of International Law suggests that sometimes government contracts are used to sort of preserve a delicate political balance between maybe a ruling ethnic or religious minority that may be relatively wealthy and powerful, and a ruled ethnic or religious majority that may be less powerful but may be getting certain benefits through a constitutional structure. And that article was focusing on Malaysia. There may also be national security or sensitivity reasons to want to not open up certain sectors, and there may also be sort of capacity and scarcity issues. One point that was made in the debate over TRIPS, which is the intellectual property agreement in the WTO, was that some developing countries spent the equivalent of 1 year of their GDP to implement the domestic reforms necessary to comply with TRIPS. So you might think that there's a scarcity reason there. Other reasons to be wary of signing up, some of these apply generally to procurement reform and some just apply specifically to the WTO. There are economic, legal, and institutional reasons. So economic reasons is we may wonder whether there's empirical support for the virtuous cycle. So on the economic theory, does opening up the market to competition really lead to lower cost or more efficiency? In my sort of dive into the literature in preparation for this, I didn't actually see a lot of empirical support. It may be out there, but I didn't see it. If it's out there, it needs to be amplified. And then, same point on corruption. Is signing up to an international agreement a good way to tamp down corruption? So Kevin Davis has a useful paper in the Hague Rule of Law Journal where he distinguishes between sort of optimistic and pessimistic views on transnational interventions around corruption. And the story being told here is a relatively optimistic one that, you know, top-down reform can catalyze, you know, can actually impact corruption. And then furthermore, there's sort of if you build it, they will come. If you have like a practice, like institutions with integrity, that, you know, investors will show up. And both of those could be challenged empirically or theoretically. And so those are sort of open questions that we can discuss. As far as legal challenges, so the way the WTO government procurement agreement is structured, which, for those of you who don't know, which is probably most everybody in the room, and it was me until very recently, is that it's a treaty under the auspices of the World Trade Organization, but not every WTO member is a party to the treaty. You have to separately sign up to the government procurement agreement, which is an unusual thing for the WTO system. And the reason for that is there was a lot of developing country resistance, among others, to signing up to this. And the agreement, as Vincent notes, has gone through, you know, sort of a series of reforms over the life of the WTO and its predecessor. And the current agreement has some very specific obligations with respect to transparency and tender processes and notice to potential suppliers of goods and services. It also has general non-discrimination requirements, so you're not supposed to discriminate among foreign suppliers. You're not supposed to discriminate among domestic suppliers within your own country on the basis of how much foreign content is in their products. So if, you know, firm A is producing syringes that are mostly manufactured in Chinese Taipei, and firm B is producing syringes that are mostly manufactured in your home country, then, you know, you can't discriminate against A and B on that basis. And that's sort of from the general non-discrimination obligations of the WTO. You don't have to open up all your sectors. When you sign up to the government procurement agreement, you can sort of specify what you are or aren't opening in various ways. And the system is linked up to the WTO state-to-state dispute settlement system, which means that if you don't abide by these commitments to impose all these transparency requirements and such, then the United States or whoever else is interested can bring a dispute against you and generate a legally binding judgment that forces you to comply. There are some nuances around that which we can talk about. So the question with the specific obligations is, can developing countries actually do these things? Can they, do they have the capacity and the budget or the foreign assistance to actually generate these reforms? For the broad obligations, there's a sort of a different set of questions. So for example, Article 4, Paragraph 4 states that procuring entities, that's government procuring entities, shall conduct covered procurement in a transparent and impartial manner that prevents corrupt practices, period. That's the obligation. So if we read that really broadly, a common lawyer would call that an obligation of result. I circled it when I first saw it. I wrote, wow, is this actionable? Do you really have an obligation to prevent all corrupt practices? It turns out it is actionable. Nobody knows how much content it has. If it's really broad and has a lot of content, bootstraps in obligations from other corruption conventions, which is definitely a possible reading, then that's very burdensome on the acceding state. If it's toothless, then maybe the signaling effect is lessened and the benefit of signing up to the agreement is less. So that's just one example there. And then finally, the institutional factors. So the way you get into this agreement is what's called an accession process. So if your country wants to sign up to the government procurement agreement, You put together what's called an offer package. You say, these are the sectors I'm willing to open, or the procuring entities that I'm willing to sign up to this at the national, subnational level, state-owned enterprises potentially. And then, the existing parties to the agreement are essentially a club or a cartel, or however you want to think of them, and you negotiate with that club to sort of gain entry. And they're going to say, no, we want access to more, and countries that produce X good want to see the procuring entities that buy X, open up. And so if you're just going in there saying, I want to open up the Ministry of Health because I want access to medicine, are you really going to be able to do that? And I don't know what the political economy of this is, but can you make that happen without also giving up other concessions in other areas that may make this more costly? Another institutional factor is the entry into force. So we've described so far as signing up to the procurement agreement as a first step, but it's not exactly a first step. So once you have acceded, you have 30 days, at which point all of your laws need to be in compliance with the government procurement agreement. So really what you need to have done is set all this up in advance, and actually some of the literature talks about maybe implementing a model law first or doing some other stuff so that you're ready to start the accession process. So it comes a little bit later, and we can talk about those dynamics as well, the sort of intertemporal nature of this. And then another question is flexibility for developing countries. So Article 5 provides for certain flexibilities for developing countries. They can sort of delay the impact of certain obligations or implement certain special schemes. So I'll wrap up. Those flexibilities are also heavily negotiated, and they don't afford certain things like preferential market access in developed states, which is what I think the developing countries would have most liked to see. There's also not a lot of linkage with other areas where developing countries may be able to sort of trade off and get more value. The final thing is expertise. So in time zero, before anyone signed up to the government procurement agreement or et cetera, who in the developing country knows how to get good prices, if anybody? Where's the expertise? Well, it's probably in these local businesses that are getting the sweetheart government contracts. Afterward, once the reforms are implemented, then you need the procurement agents within the government structure itself to know how to get good prices, negotiate for quality goods, et cetera. And you've got to transfer that expertise from one place to another. There's no mandate for financial and technical assistance. There's a lot of should and are expected tos in the agreement, but I didn't see anything that says, the United States is going to pay a bunch of money to make sure that such and such a country has the institutions it needs. So that's the final question. So throwing out some alternatives, are soft law and guiding principles alternatives? Other sort of capacity building outside the WTO system, are they alternatives? Model laws, pooling practices for medicines where a bunch of developing countries get together and form a club that then goes out and purchases on the market. That would force a little bit of transparency there, I would expect, and would also maximize their purchasing power. Maybe these aren't strict alternatives because you could be doing this while you're also slowly making your way toward a session, but these are things that might be cashed out as the next one or two sections of the paper is written. So anyway, that was it was a really provocative paper for me, and it got me thinking a lot. So thank you very much, Vincent.
Okay, so we could just take one question. She had one. Yes, thank you. Can you hear me?
Just
There's a microphone. Yeah. Okay.
So thank you. I think this is a really interesting idea about how to promote access to interventions in some low-income settings. But I wanted to point out a tension that I see that kind of worries me about this, which is that entering into this kind of procurement agreement might ultimately undermine efforts towards local capacity building. in the following way. So entering into this agreement might have the sort of the long-run effect of making certain countries more dependent on the health and health research economies and industries of the global north. And this in turn might, in the long run, undermine the future ability of these communities to prioritize the health needs that they want to prioritize, right? Because once they enter into this procurement agreement, I take it, they're signing on to source their pharmaceuticals from particular sectors and to not compete with them. And so this might undermine the ability to, produce generics if they trigger the certain piece of TRIPS that allows you to produce generics in the case of an endemic or something like that. It might undermine their ability to build up their own local pharmaceutical industries so that they can research and create the kinds of interventions that would be most valuable for them. So it's just sort of a comment or an observation about sort of a tension that I see here. I mean, I think the idea is really interesting, and I'm interested to read your paper, but I think it's worth some consideration.
Can hear us.
Vincent, can you hear us?
Yes.
Okay, so now
I can hear you.
Okay, so you couldn't hear anything at all just now? Did you hear the question?
I heard pretty much what Benton had said. It's just that the questions after Benton were really very unclear, or comments.
Okay, I think the summary of the question was, is essentially this going to undermine the ability of countries in the global south to use generics by signing on to the global procurement system? Will they essentially be forced to use the procurement system provided by mainly countries in the global north and not be able to use some of the flexibilities or maybe even act outside of the TRIPS regime?
Okay, I think with respect to the generics question, let me just give a very brief comment that it really doesn't affect much because generics then become available from other countries. For example, India and Brazil, which have manufacturing capacity, and even other developing countries, if they subsequently develop their manufacturing capacity to produce generics. So I think it would encourage that bit of trade with respect to generics. But then more importantly, I think it would make available the other drugs, particularly for the private healthcare system.
So the worry is actually that...
I hope I have...
So the worry is actually that the entering into the procurement agreement is going to undermine the development of manufacturing capacities within these states. That's my concern.
Did you hear that? Yes? Okay, respond then.
Stop me.
Oh, sorry.
Your time is up.
Exactly.
No more thinking.
Or maybe it isn't too late.
I think, did he hear?
He looks frozen. He's stunned.
Vincent, did you hear the clarification of the question? I see you guys are giving me a hard time. Vincent, did you hear the question rephrased?
I just had snippets of it, and then the whole room back.
So maybe I'll try again, and this time I won't mess it up. The question was just, will it prevent the development of a generic industry, the manufacturing capacity, because you're dependent on this procurement system? That's the question.
Okay, I don't think it would be, especially if the generics are produced upon the expiry of the patent terms. And perhaps it may affect issues like trade-backed medicine, but I don't think it would affect medicine that whose patent terms have expired and are then subsequently sold as generics.
Thank you very much.
Hello.
Thank you very
Thank you.
much. We're going to move on to our third paper by our wonderful convener and presenter of this conference, Matianga Sirleaf. She is going to be presenting her work in progress, Racial Valuation of Treatment.
Sorry, Vincent, I think you and Ben will continue the conversation offline because there's a lot there. And so you guys should have a Skype or Zoom call. So I'm going to reduce you a little bit. You're still here, but I just wanted to get to a slide that I have somewhere. That one. Yeah. Yeah. And the slide is actually not meaningful, so it's great. Once it comes up, it will. Well, there's one thing I want to show you. There's okay, great. So I wanted to really just show that slide, and this is a pretty informed crowd here, so I will dispense with the sort of usual introductory remarks about NTDs. But basically what I'm trying to do in this project is to use critical race theory to help to explain a gap that I see in the literature on discussing the dominant argument for why there's global health inequities with respect to pharmaceutical innovation is that there's a market failure and it's largely sort of political economy story. And that is the conventional wisdom that I'm writing against. And I came to this project by just thinking about what the analytical tool of race would bring to the story. And so the benefit of being the convener is that I can give you an incomplete draft. And also the benefit of giving an incomplete draft is that there's actually lots of space for this project to be developed. But essentially what I'm arguing is a tweak on the political economy story. So it's not just about the interests in the global north driving pharmaceutical innovation, but it's that there are particular sort of racialized interests that are historical and that are tied to the ways in which bodies of color, and in particular Black bodies, have been pathologized historically to be diseased and inferior, and not deserving of investment of either public health interventions or pharmaceutical innovations. And using a theoretical framework of essentially racial valuation, I tried to show how the closer either a pharmaceutical innovation or a disease is to white interests, and the further it is away from historically subordinated groups, the more likely you are to see some development in that space. And my RAs are being vicious with me as well, and so I'm now out of time, and so I'm gonna stop talking. Well, I should at least say the map. The map shows the distribution of neglected diseases, and I wanted to show sort of both the geographic distribution of the diseases. This is showing where the diseases are endemic. The darker areas on the map correspond with more endemic neglected tropical diseases, and the lighter areas on the map correspond with no endemic NTDs. And there is actually really a stark sort of global south, global north divide here in ways that I find illuminating. And then I will just also say that I'm working with others who I think have left by now, but we're developing a historical database of how research trends have changed in this area, trying to map out trends in R&D, and hopefully I will be able to soon query that database so that we can see how historically basic research, clinical trials, pharmaceutical innovation in this for these diseases has changed over time, and I think I will be able to use that data in this framework that I'm developing. So all of the work is in the theory space and less so in the law space, which may be a good or a bad thing, we'll see. But I welcome your comments and thoughts.
So I am the commentator on this particular paper, and I want to say that it was very interesting to read, and I really enjoyed reading it, and I think it's really raises a lot of issues that we should think about when we think about the role of the pharmaceutical industry in all of this. So I wanted to say a few words about the issues that I thought that that the paper was trying to raise, and then you sort of start to tease out some of the proposals you have for solutions, and maybe we should throw those on the table too to inform the discussion. So I think, as I said, I think it's a really important topic to identify and highlight the racial character, some of the way the disease, the approach to these neglected diseases has evolved, and I really appreciate that the recitation of the history, which is quite extensive in the article, and then the next part of the paper is to try to identify the central problem for-profit pharmaceuticals. So the paper starts with this, sort of defining the idea of racial capitalism, and then scientific racism, how the scientific community, historically has, as Matiangi has said, has tried to pathologize people of color. Then she talks about the racial evaluation and diseases. This is her concept of racial evaluation and diseases. Defines, the kinds of diseases she's talking about. Talks about the intersection with the WTO intellectual property regime, and then she ends up with her proposals. So one problem I had with the article that my research assistant, who I asked to read it too, helped me with, was I think that there is a danger of conflating the problem of the drug development with access to existing drugs, because I was trying to figure out how the whole IP regime related if the problem was really no focus on developing drugs for the entities at all. And so I think sort of clarifying the distinction between those two different problems might be really helpful as you think about refining the paper. And I don't know if you agree with me or not, but I just sort of see them as two different parts of the problem and not the same problem. And it perhaps, leading with different solutions. On the history part, there is a lot of information in the history about things, like the 19th century, the early times, and then a little bit of a fast forward to the 1930s or so, and then a few things in the footnotes about the 1990s, how some of this stuff on historical attitudes and scientific racism continued and up into that point. I would make more of that this is a continuation of throughout time and that it hasn't stopped. And I think putting the stuff from the 1990s in the footnotes and maybe even coming up with more contemporary things, I think of the president's recent comment about, expletive whole countries and so forth, will really emphasize that's really still going on in the political realm. And, somewhat in the scientific realm, I know you're probably all familiar with the whole Pfizer thing and there was at issue in the Abdullahi case a few years ago on, it ended up being about the Alien Tort Claims Act, but I think is evidence of the continuation, further evidence of the continuation of this racialization of, racial ignoring on the basis of race for these diseases. Oh wait, no, I don't have the time card yet. Good. Okay. I'm now terrorized by the time cards. And then, and I don't know how much you want to get into it because you've just described it as really a theoretical paper, so maybe this is a different paper and not your paper. But in the area of development, There's the issue of the focus on diseases, identifying the diseases that need to be focused on. The clinical trials problem in the whole Abdullahi case was involved. It was similar to the example that someone else raised earlier today about the British coming over and taking blood samples and then running back to write their papers. And well, how about translating that knowledge to the benefit of the public that you relied upon to produce that information? And that's a real concern always with these clinical trials. And I looked at one paper that said that there's an increasing number of clinical trials that are not conducted in the United States. They're conducted in these LMIC countries. And the reason, because there are all kinds of reasons why it's easier, which I don't need to go into for this audience. Then there's this manufacturing problem that we just talked about in relation to the last paper, and the procurement problem, and the problems with procurement now are what quality of drugs are coming into these countries when they can get them. A few years ago, I spoke at a conference in Vietnam where we were interacting with a lot of people, scientists in Vietnam, and this is a real concern to them. They won't buy the drugs that are produced in Vietnam because they're worried that they're not as good as the ones that are slapped on with the American pharmaceutical company labels, even though it's probably the identical product because the American drug is made there too. And so that's a real, that's another issue, sort of trying to build confidence in the quality of the drugs. And then I wanted to ask you, one of my questions for you, is what you thought about the Gates Foundation and all of this, because they have, I was looking at their website, and they have this whole idea to work with universities, academic centers to try to do the basic science and the developing of some of the underlying science to produce treatments for some of these neglected diseases, and then to create partnerships with the pharmaceutical companies to do the final drug development aspect of it, to bring it, to make it marketable. And they say every partner we work with is required to make products developed with foundation funding widely available at an affordable price. So, I just don't know how that's going to work, and I don't know. I didn't have enough time to look into whether they'd had any of those drugs, available yet, and what the experience had been. And then I guess, then the last comment, and then I'll talk about the proposals a little bit, is I totally understand that the point of your paper is this global north, global south divide. I think people might think it was more, I don't want to say credible, but more, they would be less resistant to the idea of it if the paper acknowledged, it doesn't have to be a big acknowledgement, that some of these problems of access exist also in the developed world, and that it's just a heightened experience in the global north, global south. And I'm not trying to use a false equivalency thing or minimize the extent of the problem in the global north, global south range, but just because people don't like to hear that, yeah, it might be. It's just that. So then to the proposals. So your proposals are, and she hasn't developed these yet, so this is totally not.
Tell me my proposals.
Yeah, well, she has 1, 2, 3 here at the end. Okay, so recognize special situations of need in one or more countries with epidemic diseases, and we've been talking a lot about that today. Number 2 is to assign greater responsibility to those who have contributed more to an epidemic. So I'm interested to know what your thoughts are there. And then 3, to assign greater responsibility to those who have more resources or capacity to deal with an epidemic. And this has come up in the earlier conversations, right? Getting the pharmaceutical companies to really engage, getting the academic centers to engage their research tools and their the capacity to treat or to give advice about how to structure governance systems and things like that. Really more engaged in trying to deal with some of these resources, in a prospective way and also in response to crises. So I think that there's a lot of opportunity there, and I think it's a good framework for discussion about what some of the possibilities might be.
Sure. I'm actually more interested in hearing other people's thoughts, so I will just do 2 quick clarifications and can talk to you a little bit more offline.
Yeah.
So why the IP? I think the IP regime internationally structures the incentive system for research and development through this 20-year grant, the monopoly grant. And so that's why I'm talking about the IP regime, because I think it limits innovation in a whole bunch of different ways, but there's a disparate impact on the global south. And I hear you, because I'm not trying to make it seem as if everything is, hunky-dory here in the global north.
Right.
There are huge access issues. There, as you said, are problems with magnitude, so just need to make that clear in the piece. And then the other clarification thing that I would just say, yes, I do plan on separating out sort of clinical trials, the ways in which the benefits are not shared equitably into a completely other piece, because I think that conversation might consume this entire piece.
Right.
But I hear you that that's a huge issue, and I'm thinking about that and appreciate all of the comments. And so if there are any other questions or comments, I'm happy to hear.
Scott, and then Lisa.
Well, I was just thinking in thinking resources for inspiration as you continue to develop this and think about the proposals are. There's a way in which this project kind of reminded me of Richard Rothstein's book, The Color of Law, in that it's telling the Faulknerian story that the past isn't dead, it's not even past, and that we sort of decided that all sorts of things that have structured the world in the past deliberately no longer, they stopped doing that, so therefore now we're in a new.
Right.
So I think, and that gets to from the legal point of view to the question of when do we sort of let the statute of limitations run out? How far back can you go on a remedy, which is sort of in a way what we're talking about here, at least in part. So I just thought that might be useful to have for inspiration.
It's one thing that I was thinking about in the context of your paper is this idea of the economics, the story of economics as driving this versus a racialized account. And in some ways, I think that this is because we simplify the role of the market. So it may very well be that at the end point, pharmaceutical companies are making choices based on profit margins, but that's neglecting the structural components of markets. And I think that's sort of and a lot of your proposals, I think, are at the abstract level suggestions for objectives of structural change, right? Structural change in how we regulate markets, structural changes in how we construct markets. And I think that piece is neglected in a lot of literature, the fact that there is no such thing as a perfectly competitive market, particularly not in this space. And so there are government interventions in all kinds of ways. And we need to unpack that through your lens and look at where do those structural changes need to take place. And so just as sort of a thought in terms of unpacking that narrative a little more, it's not that you're not saying that economics is not a story, it absolutely is. It's just that there's a process behind that then results in that also explains disparate impact.
And it gets into this whole conversation. Just having taught the civil rights cases in con law last week, the sentence about, we've given them special rights long enough, so now we're just going to have equal rights. And I think that's the mindset that we're fighting against here, is that, that idea that if you focus special attention, then somehow you've denigrated other people's rights. And I think that, I think we have to make the argument about why that's not true. But great, it's a great idea.
Great. We're moving on to our last paper. I really want to make sure everybody had an opportunity to present these wonderful, thoughtful papers. All right. So our last presenter is Lisa Vertinsky. She is a professor at Emory University, and her paper is co-written with two other authors, also from Georgia, but Georgia State. And her paper is Why Healthcare Companies Should Become Benefit Corporations.
So I'm going to keep it short and really tied into sort of some of the themes. So many of the papers today have questioned assumptions and presumptions that we make about global health strategies, whether we frame it as a global sort of security agenda or an economic as opposed to a sort of racialized account. And the emphasis, I think, the what? The emphasis, better?
No, it's fine.
Oh, okay. I'm sorry. Yeah, sorry. Yeah, it's on. And I think it's, so one of the takeaways is that we really need to pay more attention to the presumptions or way of framing the issues in your paper also, right? So let's be critical about how we're framing issues and think of alternative accounts. So this paper fits into a larger project that I have, examining the role of the market in driving how we think about and respond to healthcare and disease, and the commercial construction of healthcare and disease, and the role that corporate actors play in shaping this market and the outcomes. And the reason I wrote this particular paper, which is really simply saying that we should have some way of injecting public interest into corporate governance, doesn't come because I think that will solve it, but because of my concern with the lack of regulatory oversight, and the lack of adequate enforcement of public interest objectives through something outside of corporations. So this is seen as sort of just one of many efforts to focus on the significant role that companies play in shaping the healthcare agenda, and to think of ways we could improve those outcomes. And so one of in the context of this global conversation, I also interested in how much we export, or what I think of as somewhat of a pathological approach to kind of relying on a market-based approach to healthcare with very imperfect markets as our mechanism, to think about how much impact does that have abroad and through what pathways. So impact on trade negotiations and treaties. Who's at those trade negotiations? And what rules do we get? Replication of policies abroad. So we have the Bayh-Dole Act here, which influences how universities, how funding works and who owns the inventions. Well, we export that model even while we have concerns about how well it works at home. And why do we? Who's lobbying that? It's often the pharmaceutical lobby influencing. How much do we export our approaches to IP and data exclusivity abroad? So all of these different pathways by which some of the challenges we have domestically with corporate control over parts of our healthcare agenda, I'm interested in understanding the pathways through which that might have a broader impact.
Okay, so I get to comment on this paper, and I really loved reading it. I think it does a terrific job of describing and explaining the kind of disconnect you talk about in the paper that exists currently between the private incentives for healthcare organizations that dominant corporate governance standards create, and then the public interests in advancing the health of populations and advancing health equity. And so it's kind of interesting to have this paper at the end of the day, because there have been glancing talks about the importance of governance, but not a whole lot of focus on governance. But it's interesting because we're not looking at governance like at the WHO, we're not looking at governance at the nation state level, we're looking at governance at the corporate level. So just a really interesting paper. And essentially what I took from the portions of your paper where you use examples from the pharmaceutical industry to illustrate the harms that flow from that disconnect, and when you describe distinctive aspects of the healthcare market, was an argument that the problematic aspects of corporate governance regarding its sole focus on shareholder value, sometimes short-term shareholder value, are really exacerbated by the distinctive characteristics of the healthcare market, which produces an outcome where the public spends a whole lot of money on healthcare and private corporations gain a whole lot of profit from healthcare, and public health outcomes are, in your very gentle language, suboptimal, both domestically and internationally.
I'm an economist.
So I think that descriptive part of the paper is really excellent, clearly and cogently written, supported by a wide range of sources, and I think the examples that you provide to illustrate from the pharmaceutical industry really are spot on. Prescriptively, you suggest an approach that complements potential regulatory approaches by trying to change how, from the inside, how healthcare organizations act. by requiring, or at least by strongly incentivizing them to become benefit corporations so that the directors and officers of those corporations can be duty bound to serve some kind of public health goal in addition to shareholder interests. And I really love that you're kind of expanding the frame of what's possible in terms of thinking about approaches to address these issues. But in the end, I'm not entirely persuaded that your suggestion is likely to work, at least as currently framed. So I'm just going to make several points in my comments. The first kind of pair have to do with awareness of the historical moment when this is coming out, and thinking about how your points are also occurring in parallel discussions. One has to do with the scope of your proposal, and then the final one kind of expresses my skepticism, but also comes around to thinking about another way in which your proposal might have some legs. So the historical moment. Early in the paper, after referring to the broken state of the healthcare system, you state that current proposals for fixing it are focused primarily on regulatory changes, efforts to increase competition, et cetera, that share the assumption that the provisions of healthcare products and services will remain in hands of corporations operating in a market-based system. I'm someone who watches too much political TV, sometimes in horror, but sometimes with hope in my heart. And there actually are serious debates going on right now in the United States about whether we should continue that assumption, right? That you're acting, your article is premised on. And so I think that some readers could read the descriptive part of your paper and really see it as evidence that building a healthcare system that relies on any kind of for-profit corporations for its operation is a fundamentally bad idea. And so some of those readers, if you don't at least acknowledge that there are still debates going on whose outcome are uncertain at this point, right? But if you don't acknowledge that some of your readers may resist. In addition, beyond getting readers on board saying, yeah, I know this conversation is going on, but if that doesn't happen, we need to figure out what we're going to do. Also, if, for example, we do end up with a single payer system, you want your article to have some durability, right? You want it to still be relevant.
I'll just be happy if we end up.
Yeah, right. Who will care about anything else? Fair enough. Then we'll have a fun time. But so a related point that kind of goes to framing, and in some ways it echoes the conversation this morning about, do we frame this as a matter of security or as a matter of public, human rights and morals. Similarly, I think there's a framing question that goes on with respect to part of your paper, because you framed the question as being what distinctive aspects cause healthcare markets to produce suboptimal social welfare outcomes when for-profit corporations develop and sell products and services. Right, so I read all that and I'm like, this sounds a lot like the conversation that we have in Health Law and Policy, Amber and Taylor, but they haven't given me signs yet, about is there something about healthcare that is special such that it should not be left to market allocation at all? Right, and that's a conversation that folks who look at the world more through social justice lens tend to have. And it draws on many of the same points that you made, but it also tends to draw in some of the points about the demand side that have to do with the unpredictability of the need for healthcare, the unevenness of the distribution of the need for healthcare, and it also tends to highlight how healthcare is an instrumental good because decent health is needed in order to enjoy so many other aspects of life. So as with my first point, I think just kind of acknowledging that the discussion you're having could also be had through a different frame. Again, you will pull in readers rather than to cause them to say, but what about, right? So my other point, or another point, has to do with the scope of your proposal, and this is a smaller point, but you focus your illustrations on the pharmaceutical companies industry, but you state at several points that your argument extends to all healthcare organizations where the market operates similarly, but you don't really look at that assertion, and given that nearly $1 in $5 in the US is spent on healthcare, a proposal that extends to all healthcare organizations would really cut a vast swath through the economy. And to my mind, a lot of the force of your examples have to do with the fact that they have to do with product development and pricing decisions. So I wonder whether whether those arguments really extend to questions about healthcare financing, healthcare services as well. And I think that the article probably would be just as valuable if the scope were somewhat more limited. So my last point, because I know I'm short on time, has to do with the persuasiveness of your prescription. Because you correctly acknowledge, I think, that the proposal that we move towards B Corps is likely to be effective only if it becomes the dominant form. I think there are real problems politically and probably legally with trying to mandate that all of these pharmaceutical companies become benefit corporations. And I don't know how likely it is that, as you suggest, there might be a critical mass of states that come up with really strong incentives for them to do so. So I find the idea of changing organizations from the inside really intriguing, but that's kind of where I get skeptical. It reminds me of the Grinch who stole Christmas, right? Remember the real problem that his heart was 2 sizes too small, and once his heart grew, the story had a happy ending. So I kind of feel like if we can just make these pharmaceutical companies want to do the right thing, if their hearts can grow, that's all we'll need. I'm skeptical, especially because, as you acknowledge, the evidence regarding the empirical base regarding how benefit corps work is undeveloped at this point, and to the extent we have anything, it's probably benefit corps who chose that form voluntarily because they wanted to be that kind of corporation. So it did occur to me, though, that one alternative future scenario where your proposal could have some legs is if, in fact, we ended up with some kind of healthcare reform where the financing of the healthcare system is taken out of for-profit hands and is assumed either by the government or is entirely not-for-profit. And these are big ifs, if the government is willing to use its bargaining clout to say, we will purchase only from or prefer sources of drugs or devices that come from benefit corps that incorporate public health or potentially even global health equity goals into their decision making. And I think that, that kind of might give this paper another way to be the foundation for what I think you want to talk about in the future. It's not impossible to imagine that with a progressive federal government operating some kind of single-payer system, that they could discipline pharmaceutical companies, not only with respect to the domestic market, but also with some of the global market. And so I think that it was really interesting to me to think that, actually this single-payer discussion that we're having as a national conversation now has salience not only for what happens in the United States, but it could actually have some salience for how we approach some of these questions. And I'll just throw out for you a couple of ideas, not necessarily that I think these are models that would work in this scenario, but the other thing that does is by giving Medicare and Medicaid, the federal, well actually Medicare for all as a single payer, the federal government, that bargaining clout. Think about EMTALA, right? The federal government says to hospitals, if we're gonna pay you to take care of Medicare patients, if we're gonna give you all this money, you have to, in your emergency rooms, provide emergency care for anybody who comes in. Hospitals do it. They don't love it, but they do it. You think, we talked earlier, I think you were talking about how risky it can be to develop drugs for some of the neglected tropical diseases. Well, in the Affordable Care Act, there was a real concern about risk and how these insurance companies would deal with this risk of patients who have health care needs. So there were, the premium stabilization programs, the risk corridors, the risk adjustment. So, conceivably you could use models like that among pharmaceutical companies so that the risk of trying to develop new drugs could somehow be equitably shared among them with the government as a manager. So I really like your paper for providing this foundation, and I'd just be kind of curious to think about whether any of those models might resonate with you or whether you have other thoughts about moving forward with it.
I know we're out of time. I totally agree with everything. And my goal, I don't think this would work at all. That wasn't really the goal.
how people never put that in the paper.
You know, in a world in which we didn't have a law review system the way we do, it wouldn't be in the paper, right? It would be, here's an idea for one factor we should look at in improving our health system. But so just really quickly, in terms of the scope of the framing, so I left healthcare exceptionalism out because that's a massive, complicated literature, and I couldn't do it justice. And how that interacts with an economic argument is interesting. Like, how do you talk about those? The normative aspects of healthcare is just different from and sort of an economic argument if markets don't do a good job. And so that it's an interesting area to explore. I find bioethicists don't often hang out with economists, right? And it would be really interesting. They should do it more. But they talk in different ways. So it'd just be interesting. We see this with genetic exceptionalism now. Should we treat genetics differently in regulation? And awareness of the historical moment. So we are moving. I have been watching these sort of this moving towards talk about Medicare for all. I worry about what happened with the Affordable Care Act, where we had some movement in the direction of sort of expanding coverage with some really problematic consequences in terms of not disciplining the market. And would we have been better to just wait and to redo it, right? So I worry about incremental changes that don't address the market and where we might go with the current kind of political talk on that. But just finally, absolute, I love the ideas of the specific examples. That was my hope, is that if we could change the way that government funds things, then you could incentivize change. I think all companies should be benefit corporations. In fact, when they were first formed, if you look at the history of corporate law, and I'm not an expert, the historian's gone. They were formed. They were formed with the public interest as part of what they did. So that was originally how corporate charters were, and it got lost somewhere along the way. Anyway, I'll stop there because it's. But thank you. I totally agree with everything you said.
Okay, are there any questions? Because this idea has been alluded to throughout the day.
I have one, the two comments. One is the, so in Massachusetts, hospitals are mostly public charities, right? But, they look at the bottom line, just like as if they were Pfizer or something. Right. And so the Attorney General has these, public benefit activities, and they're supposed to write a report every year. It's not clear to me that any of this has had any effect. What has really had an effect has been the trying to get to the cost, the total medical expense targets, limitation targets. That's what's had an effect. And then the other example is the financial services industry. So I can't remember if it was the SEC or the CFPB tried to impose a rule that all these financial advisors, like again, I'll use the Massachusetts example, Fidelity, had to have a majority of independent directors on the board, right? Well, needless to say, the Chamber of Commerce went after it, with many AK-47s, and the rule got thrown out by the DC Circuit. So the level of, I think that you're absolutely right about the history of corporations, but the level of opposition that this idea will attract is really quite stunning to contemplate. And that failure of just trying to get more outside management, and then the fiduciary rule, right? That the financial advisors had to, be fiduciaries for the customers they were advising, and that Congress, got rid of that too.
No, with data privacy.
Yeah.
Yeah.
Net neutrality, all of these things, right? Yeah.
So I had a similar thought. UPMC, I don't know if UPMC is really big here, but it's basically it's a nonprofit, but it's a nonprofit. Yeah. But it's like one of the most profitable health.
It's better than Emory. We have a nonprofit that's non-profitable. Good job.
So as I was reading your paper, I guess I just kept thinking so is changing the sort of what the signal, what the label is, actually going to change what's driving things, right? And so is this model going to direct things at improving health outcomes, being more patient driven, or is it just going to be essentially another label but just
functioning the same. And I think it's sort of impacting on yours. And I have to think about UPMC because it's the behemoth here, but there are other, like in Emory, and there are other places like that where there's
Partners Healthcare.
Yeah.
Partners is the largest private employer in the state.
And we
right.
just changed our insurance plan, so it's different. It's really taken over. Yeah.
So absolutely good comment. So what we didn't have time to do in the paper, and is harder, is to also show why this might have advantages over nonprofit. But again, the emphasis really is just to focus on the fact that corporations have so much control, and now they're writing their own laws, right? That's my next project, right? That they're not only controlling the market. And I think markets work. I mean, this is not against the markets, but they're also writing the regulations that regulate the markets. And so this would be one piece where we look at optimal organization size, but it's not going to work if there's not some regulatory structure around it. And you're right. So you can talk all you want about the form, but is it just going to be another form without some regulatory change? Yeah, absolutely.
Just kind of piggybacking on that question. So, in a lot of states, North Carolina, UNC kind of expanded, so these nonprofit health systems are really kind of expanded out throughout the state. So there's a change in terms of the for-profit versus nonprofit expansion of that. How will that change sort of your framework if all these nonprofits are expanding? Would that sort of defeat the argument that we need to have this benefit corporation when they can argue that they're already nonprofit?
Well, so the argument, so the response would be that there's problems with the nonprofit form as well, right? It's not clear that nonprofit form is better, and there's some studies. The empirical work is not great in this area, but so it's not clear. So the response would be, well, we're not sure that benefit corporations wouldn't do a better job than nonprofits. But that goes back to your point that if we don't have some regulatory change, then it's probably not going to help, regardless of what form you have. They'll all end up doing similar things. Although it does worry me that there's a shift in the insurance providers towards for-profit, right? So isn't it like Blue Cross, right? So the Blue Cross Blue Shield, right? So there's very few for non-profit insurers left, which is worrying.
All right.
So lots to worry about.
Yeah.
On that happy note.
This has been an excellent panel, and we get to see how law is a determinant. It's a structural determinant that impacts health and health inequities around the world. And it was really great to see all of the papers because the first paper gave us this idea of strategy, and it shows us the importance of having strategy in this particular space. And then the second piece talked about procurement and the impact of purchasing on quality and access and prices. And then Matiengo's project, which is not finished but is very good, is giving us that historical look. And then finally, the last paper by Lisa and her cohort are thinking about what the private sector should be doing. And we really do need to be talking about that because we know that in the United States, in our bailiwick, that they always want to have the market do things. And so to be thoughtful about how we can challenge what the market is doing and redirect what the market is doing, I think is very good for this discourse. And so it's been great. And now I'll turn it back over to Matiaga.
Scott Burris is a professor of law and public health at Temple University, where he also serves as the director of the Center for Public Health Law Research. Burris began his career in public health law during the early days of the HIV/AIDS epidemic and spent several years lobbying and litigating on behalf of people with HIV as an attorney with the American Civil Liberties Union. Since joining Temple faculty in 1991, his research has brought, in his own words, law and policy into the public health datasphere. He founded the Public Health Law Research Program for the Robert Wood Johnson Foundation, which has supported multiple empirical studies on the impact of law and health, including Law Atlas, an innovative policy surveillance portal. His scholarship champions a transdisciplinary model of public health law that presages a necessary shift in the norms and expectations of how policy information is created, analyzed, and made available to professionals and to the public. Speaking from the topic, a strategic approach to spreading healthy law, please join me in welcoming Professor Scott Burris.
I mean, obviously, you can trust that anything I say is going to be really perspicacious, because I'm the guy who had the foresight to agree to give the talk at 5:30. And I'm sorry to see Angie, are you?
She's here.
She's here. She should be.
Yeah.
Well, she will. That's good. I won't embarrass her. But the Public Health Law Research Project, which is the font of all this stuff, the RWJF project, was really her idea when she was the program officer at RWJF. So credit where credit is due there. I have this task. I'm the guy at the end of the day. Everybody's tired, and also it's been an incredibly rich day of ideas. And how does that all get sort of stuck together? And my charge was not only just kind of stick it together, but to do that in a way that talked a little bit at least about how we do something with all this. And we are in the information business. We work to create information or to use information, knowledge, expertise, medical expertise, or legal expertise to make the world a better place. And on the one hand, information, knowledge, expertise are really powerful ways to change the world, and on the other hand, they ain't money. I mean, there are other equally or more powerful tools for changing the world, and often it feels that ours are pretty blunt in comparison. I actually think that it's wonderful to be in a group like this. It's wonderful to hear these ideas. By nature with ideas, a lot of them are wrong, a lot of them are hopeless. But the process of making them is really valuable, and we have kind of tried and true ways to sift out what's strong and what's weak, and to spread what's strong and to implement what's strong. And what I'm basically be talking about today in terms of strategy and kind of giving you an example of is the idea that while there is no magic bullet for taking ideas, or in this case, legal models, legal interventions, legal changes, and conquering the world with them and changing the world with them. There's nothing new in sort of law or advocacy or science that's fundamentally different from what's been in the past. What we can do is do everything better and faster. We can reduce the frictions and reduce our own mistakes. We can be right more often than we have been in the past, and we can be better coordinated and better organized. And in a sense, that's the kind of underlying systems thinking about what we do that I think people have been alluding to throughout the day. But since I am the last person and I knew everybody would be kind of worn out, I thought I would start by kind of capturing the problem in a more entertaining way. I thought we should start with a film. Well, not exactly a film. In fact, not even a button that works. Something's wrong. Yeah, I'm not starting. That's it. I'm going. Do I point where? Is there something? I just use this.
Battery. Oh, it's just not on.
Oh, you have to turn it on. That's
Not the battery.
okay. Then I will take this convenient handheld thing and try that.
You have the mouse? Just click on the PowerPoint.
Who's Martin?
Over there.
Yes, mouse.
Okay.
Just click on it. Maybe it is active, and it's just not, like the PowerPoint's not active. There you go.
There must be something other than doing next, though, because I'm.
Left click.
Which is the top? This is the top, right? Ah, there we go. All right, well, there's the big reveal. You didn't realize. This is the closest I can come to a movie in PowerPoint. But probably most of you are familiar with that exciting tale of love and loss. You didn't realize that it's really a story about the challenges of addressing health inequities. But it is, trust me. So here comes the boat. You know that part of the story. It hits the iceberg. Chaos ensues. People go down. The ship goes down. Don't be too excited. There's more. But what they neglected in the Hollywood version is the obvious. The next step was obviously an epidemiological investigation. And of course, for us, the much more exciting part than all the romance And the epidemiologists looked at this and they figured out, well, look at this, a lot of deaths, 2-3/4 of the people died. The main causes of death, hypothermia, drowning, and then they tried to think about, well, what really caused those causes. And we had a bunch of things here. Not using a lifeboat, that was really dangerous. Huge odds ratios there. Traveling third class, that was dangerous. That was a bad choice. Male gender, another big problem. So now we have a greater sense of why this happened. Why did all these people die? And you have to start thinking about, okay, well, how should we think of this as risk factors that we can address? So one problem is passengers don't appreciate the value of lifeboats. This is what they found in 1905 or whatever this was. Another is that third-class passengers, particularly, were too irresponsible to use lifeboats. They were busy dancing to Irish jigs with violins and stuff, just didn't appreciate the need to get off the sinking ship. Another thing was that people had very poor lifeboat skills, so that as they tried to negotiate, if they realized they should get on a lifeboat, they had problems. And then, of course, male risk-taking culture. This is a big explanation of why so many men died as opposed to women. So you see the obvious things we have to work on, various kinds of counseling and educational interventions. And maybe you get some policy ideas coming out of this. And in fact, some policy ideas that come out, like ships shouldn't travel so fast in iceberg-infested waters. Maybe we should have some rules, similar to the law. We should certainly mandate that there are a larger number of lifeboats on the ship so that we don't have a shortage problem. Maybe even develop some system to track icebergs going really deep to think about the causes of causes. And this one especially, get rid of the women and children first rule. I have to admit, I kind of liked that when I was younger. But as I've gotten older, it doesn't seem like such a good idea. It seems like we should have everybody get on, especially older people. They're the ones who have the most to lose. The problem is that we typically we have a lot of knowledge, and we have a lot of sort of risk factor analysis, and we have a lot of sense of immediate causes, but it's harder to get to the deeper ones. So you don't see too many of these, kinds of events where people fundamentally question the class. Why do we have boats, or in the case of those of you who came here recently, airplanes that are segregated by class? Why is class such a determining factor of basically why is your zip code your fate? And of course we never get to the real problem, which is reducing the prevalence of icebergs so that ships have fewer icebergs to run into in the world. That's really how we want to okay. Well, it's true that eventually we're going to get there. At the moment, we're kind of having the opposite problem. I'm hopeful that we're getting to fewer we're talking about inequities. Inequities come from social structure. They come from economic structures. And they are ultimately the target. It's the icebergs that we have to get at, but that's sort of always the last thing on the list. Now, I think there's some ways to think about this that maybe help us push against that, but they also sort of help explain why this often happens. For me, the article that sort of brought me into public health when I was a young law professor was this famous article by Jeffrey Rose, which tries to talk appreciatively about the differences and the differing strategies and values of individualized models, medical models, and public health models. And he posited there was this kind of spectrum we could think about health problems. On the one hand, what he called the causes of cases, the things that lead a particular person to get HIV. And the causes of incidence, or what we would probably now call social determinants of health, the things that produce the incidence of diseases in a particular society. Some places have a lot of HIV, others don't. We talked about that today. Tropical diseases, some places, and not others. Why is that? But there's also another, a line on this little model that we think about, which is sort of the intervention version of what he was talking about. Which is the difference between structural interventions that are aimed at changing the environment and individual interventions at the other end, which are aimed at helping people cope with the current environment that we're not going to change. Right? And I suppose that when I think of this, it's the problem is where the pole of the particular you know, the pressure of actual patients with actual diseases, dying of specific things, having it on their death certificate, having that in the mortality tables, meets, which I just said basically for the sake of alliteration, the push of the plutocrats. You know, up in the other corner where we're actually trying to change structures, there's a lot more vested interests. There's a lot more resistance, there's a lot more status that people want to maintain. And it tends to mean that, you know, for just a lot of reasons, no matter what we want to do, we're kind of going to be down here. In the case of, you know, the Titanic, you know, we're going to train people to get in a lifeboat so they can avoid drowning in a sinking. Maybe we'll sort of have some environmentally inflected individual interventions, like definitely like teach me to dress up like a woman or a child, teach a third class, you know, if I'm in third class, or teach a third class person to sneak into first class. You know, it's an individual intervention to help them be more efficacious in that situation. It doesn't change the underlying social determinants. You know, this is a good policy. This does change the environment, but it's still not really changing, it's not really addressing larger gender or power dynamics or anything else. It's just and how they affect many killers. It's just making sure that if we have to get in the lifeboats because we're sinking, maybe we will have gender equity. But this one, you know, this is the sweet spot. This is where we want to be. This quadrant, if we're really talking about changing inequities, we want to be up there. But that seems to be the hardest. That's the last one we get to. It's the hardest to measure. It's the hardest to demonstrate. It's the hardest to legislate. It's the hardest politically, et cetera, et cetera. So, thankfully, I don't have any answers about how to do that exactly. And I don't have anything new to say. For me, as I say, it's all about the marginal improvement in how we do what we do already and hoping it works best. So today we've actually seen a bunch of, you know, we could plot a lot of our presentations around this spectrum and see that, you know, we're, you know, thanks to Eric, you know, we actually have somebody who's squarely talking about, you know, dealing with social determinants and recognizing that, you know, these things are going to affect lots of killers. And it's better to change up here than intervene down here. But of course we actually, and this is one of the beauties of Rose's paper, and the kind of gestalt that he projected, is that we actually need all these things. It's not like we don't need them. We need them all. It's just that what we don't want to do is, and this is sort of an idea of thinking about, you know, acting locally or acting individually and thinking and structurally, is that if we just do these things, and that's where all our money and time and effort and energy goes, and that's where our attention goes, and we're not kind of figuring out how that fits with something up here, we are, you know, we're going to have less effect. Let's just put it that way. So this is now where the things get a little thicker. I have a premise here, which is we do need interventions in all these areas, but we have to be as strategic and systems-oriented as possible. Because we are working in the information. I mean, we work in information, so our greatest currency is being right, basically. Understanding, having knowledge, and figuring out how to use that knowledge. Now, my thesis to take this as a particular application of the problem is that since law is a crucial medium for addressing inequities, and since research is an integral part of legal work for health, that the idea of legal epidemiology was to try and make us more effective and efficient at doing something we'd already been doing for a long time. And to improve our game, which I think basically is the best we can normally do, is in the absence of inventing a magic wand that cures inequity. So I'm going to talk about that as a kind of a case study of how we can be systems thinkers and use strategic approaches to do what we do in a way that's somewhat more effective. So now, you know, where we started with Angie calling me up was that we knew that public health as a field had some serious problems with law. And I'll just run through those very fast. Now, the problem wasn't that people didn't think that law was important. Everybody knows, and even the most law-phobic epidemiologists will know, that law is important to health. Pretty much any way you cut it. Top 10 public health achievements of the 20th century, all of them depended on law to one degree or another. We also actually know very well how to rigorously evaluate the effective laws, to figure out which laws work and which laws don't, because we've done it in a few silos of excellence. very well. These are the kinds of, there's research that shows how important law was in each of these areas. It's really good research. We also know that law is a great mechanism for diffusing healthier behavior in some way for healthy models. These are adoption curves of various, mostly car-related laws, but you can see that a good idea can spread really, really rapidly. If these were diseases, we'd be very scared, but since they're remedies, we can be happy. And yet, here's the problem. Basic education in law, in schools of public health, and other places that train future health workers is still really dreadful. I was on an IOM committee, I don't know, 10, 12 years ago that looked at this and hasn't changed much. Our political success, is, I don't know, on par with Gary Hart's, I guess you could say. I mean, we usually lose. We lose a lot. And we're getting beaten on a lot of key areas, so that's what we talk about with preemption. Another thing is that we often confuse passing a law with solving a problem. And so and because we don't have the evaluation, because we don't have a culture of testing, there are just countless areas, and I mean this, countless, where there's a law in place that actually is not doing what it's supposed to do for years. So let's just take the Fair Housing Act, 50th anniversary last year, I guess it was. We're still a segregated country. 50 years, that didn't actually solve the problem. Lead is still, getting way too many kids, even though we've got an enormously complicated lead paint law thing. So, but if we don't evaluate it and don't take that evaluation seriously, then failure just goes on and on and on, and the social agenda is plugged, the political agenda is plugged in that. Another thing we do is miss iatrogenic harm. This is a really great modeling study that came out last year. It's gotten a lot of attention because basically what it shows here is that looking at 10-year projections of lives saved or taken by opioid-related legal interventions, all the gains from nice things like allowing lay people to administer naloxone are going to be washed out by the deaths caused by the policies that cut off people from prescription opioids. On the fake assumption, basically, that if you cut off opioids, legal opioids, you're cutting off opioids, which is that's another whole story to talk about. But this is really actually, this is like the third round of law killing people through opioids, basically. And so largely, as a general matter, for most areas of law, we're pretty much in the dark about what works and what doesn't. And even where it's, what's happened, where law's been adopted, possible side effects. And if you think about it, like if we were talking about drugs, and I told you, well, yeah, we approved that drug 25 years ago. We don't know if it's safe or effective, but it sure has sold a lot. We would think that was absurd. But somehow when the treatment is law, we think, well, what's the problem? Part of the reason is money and resources. That's our side of things. What gets paid for gets measured. Is that the phrase they use? But here, the bars are hundreds of thousands of NIH grants in various time periods, and the line are hundreds of grants to evaluate defective law. So 247 of 218,000 in the last period that we looked at. I don't think that we should get all the money in law, but I think maybe somewhat more than 200 out of 200,000. But there are also more cultural reasons, let's face it. Not in this room, but there's a lot of people for whom law is just not something they want to touch. There are people who think it's just way too complicated. I can't possibly understand it and deal with it. I'm not trained. Only a lawyer could possibly do anything meaningful looking at the effective law. And then there's the, like my job is to paint the line, somebody else moves the tree approach to things. Like even if I see that there's a law in this phenomenon I'm studying, that's not for me. I'm just going to look at demographic features. So this is the story here is how can you take sort of a way of thinking about what we do and a way of organizing what we do and use it to help make a difference, to optimize the difference that research can make. So the first thing, you should get Angie McGowan and RWJF, give you $20 million. This is an infallible system. I recommend it to everybody. Anybody who doesn't do it is a complete fool. But, you know, after that, you know, what we did with that was to think, but, you know, this is not really, this is a cultural problem. There is actually no sort of reason in the world why law can't be studied like any other social institution. And there's many reasons why it should be. So the problem is that we need to talk about law in a different way than we've talked about it before when we're talking to health people. We've got to really make clear to people who work in health that they're already doing law, that that's actually already part of their job and they know how to do it and can do it better. And then we in law, we have to actually learn a bit and start to ourselves change what we do, because some of the things we do are pretty poor for understanding how law works or sharing that information with others. And so we defined a field, scientific study of the relation of law and legal practices to health. We set out to show through the various mechanisms of, you know, like methods books and textbooks and so on, and grant making, you know, how law is in fact, or what we increasingly call legal epi, is normal science. We built various kinds of resources, you know, textbooks and websites where people could learn and find out more, training in legal mapping and scientific methods. CDC now has this wonderful Public Health Law Academy, which has some really interesting advanced legal epidemiology and evaluation modules. So, you know, we sort of built this infrastructure. But in a way, I think maybe the most, I mean, that's all I shouldn't say. I'm not going to say what I was about to say, and you won't even know what I was going to say. But also important, though, is trying to think about how we frame this, sort of the conceptual tools, to try and spread the way of thinking that goes along with the work. And this is the area where I really had sort of a moment when I realized that I'd sort of been talking about public health law in a bad way for, you know, 30 years of my public health law career. And in that I was doing exactly what public health lawyers had been doing for the previous 100 years, which is talking about public health law as a practice of lawyers. You know, where we know stuff about law, we counsel you, we advise you, we answer questions for you, health people. And then, you know, it's sort of a lawyer-client relationship, and we know you won't listen to us, but you really should. But when we started talking, you know, what we were working on, what we call public health law research, what we now sort of think of as called legal epidemiology, was something different. It was something that was a practice of non-lawyers for the most part. It was a practice of evaluation. It was a practice of actual implementation of health laws and policies on the ground in health departments. It was about bringing science to the legal research, tracking the key elements of law that were important to health. And it was only when you put them together that you really understood what public health law ought to be. Something that is a practice of lawyers and non-lawyers, that involves a variety of tasks that require training in science and in health, as well as tasks that require training in law, and that require everybody to kind of work together and learn from each other to do a transdisciplinary model, transdisciplinary being the cool term for things that go beyond multidisciplinary, in the sense that there is a true integration of methods and tools, not simply kind of a very intense parallel play. So let me give you examples of how we've used this, because I think it shows the value of this kind of organizational marginal improvement to what we're trying to accomplish here. So one of the first things that came out of this work was what we call policy surveillance, which meant, which you can see it has a health name, not a law name, even though it's legal research for the most part. And it has a sort of health concept. Like we don't sort of call up every now and then and say, how many cases of cancer did we have this week? We know cancer is important, so we watch it constantly. We have systems for recording that. Same thing with law. If law is important, then we ought to know what it is at any given time. We ought to track changes, trends, and so on. But we also, and this is our initial rationale, we want to turn it into data, because how can you measure the effect of law if the law itself is not in a form that can be used for research? And a form for research means, well, I'll talk about that in a minute, it's got to become data. We also wanted to support the spread of good ideas. And we wanted to make law maybe more transparent, more accountable. You know, looking at, you know, like, I'm hoping that when we, in Healthy People 2030, You know, when we say if every state ought to have X law, we can tell people in 2020 how many states have that law, and we can tell them 10 years later how many states adopted the law. That's sort of straightforward accountability for recommendations. And of course also to make law more available and maybe salient to the health workforce. So part of, I won't go to this too long as this is well covered elsewhere, but basically we, this adopting science part is we stopped doing research like lawyers and learned to do research more like scientists in a systematic, transparent way, updatable, trainable, transparent, et cetera. And I mean, the big paradigm shift is this is what law looks like when we build one of those projects, right? The words have become numbers. The apparent features have been measured in a form that allows them to go wherever data goes, which is really useful for other people who aren't lawyers, who do not want to read memos, who do not want to have Excel charts with words on them, who do not want to have memos and you know, X's and O's. And what this allows us to do is to make a lot more data. I mean, we make lots and lots of data. That, you know, I used to do 50 state surveys myself as a lawyer with law students, and I can do 50 in the time it took me to do one. You know, that partially because the data approach allows us to reduce costs and increase productivity using technology, and of course also we get more value. We have more things we can do with the law. So one of the things we do with law is make websites where people can go. This is one we made for NIDA, which has a lot of opioid law, and we're in practice now making about 8 or 9 criminal justice policies that are relevant to people with opioid use disorders, or just who use opioids. And you know, you can go and interact. Every variable is shown in the form of a question that people can interact with and see how the states rank up and how they compare. These are all longitudinal. They go over time, which is really important for research use. So we can track the development of the law and get a lot of variation for research purposes. You can look at the law if you want. That's also available there. But we also have it set up. This is our center site, Law Atlas, where when you are a researcher, you can click on data, get the data. You can click on the protocol, and it's everything we did is there. So you know exactly how the data was made, which means that this can go in any good journal because it's you know, you can take it, and we give it away for free. It's all about open source legal data, kind of like the TICO project is about open source health data. And in fact, it's worked. Between those two sites that have been up for about 3 years, I think we've had something like 160 papers published using the free data, which is a pretty nice number. And now just to show you sort of where this goes in terms of equity, I'll pull out this one paper, the minimum wage paper. This is a project that was funded by NIH. It's built on a social determinants model. So the idea is that actually this project looks at a bunch of income support policies, but the idea is going to affect the outcomes of these very intractable outcomes related to infant mortality, infant and maternal health. Uses what law generally enables, a natural experiment model. But we have 30 years by 33 states by month of the state minimum wage level, which you really that's a pretty big data set, I can tell you. And what the research showed was that actually in this intractable zone, raising the minimum wage has a robustly appearing measurable effect on both low birth weight and neonatal deaths, which is, as I say, one of our weak points in this country, and this is a particularly important finding. There's also findings on earned income tax credit and other stuff that's coming out. So that's the research. Like, the research actually can help us move up into that other corner where we're talking about wealth and income and inequality in policy terms. But another thing that's nice about this, and this is an example of the diffusion part. This is a project from the de Beaumont Foundation that Kaiser Permanente has since joined, and RWJF has joined actually now too. The idea with this policy called City Health, which launched in 2017, was to get a bunch of experts who would sort of go through the literature and identify 9 healthy policies that can be enacted at the city level that all cities really ought to have. Like, why not have them? They work, they promote health, and then to use the sort of basic naming and shaming strategy to rank the cities based on whether they have those policies. So all the 40 cities got ranked for whether or not they had a policy, but also for on the basis of the strength of the version of the policy they had, right? And that's the distribution. I'll give you an example of how that works. Like in Philadelphia, we got a silver. If I wanted to go in and talk to the mayor about how we could get gold, say on earned sick leave where we got a silver, this tells me in the like 5 minutes I'm waiting for the appointment, because he never keeps me waiting, that, oh, our problem is that we're okay on the main indicators, but we don't allow enough sick time. If we want to be gold, we have to allow a worker to get 48 hours of sick time at least. And we only cover, firms with, several employees. We got to get down to, where one employee is enough to trigger this obligation. Now, the thing is, and I've been an advocate and a lawyer for a long time, now, you name a city and send me to their mayor, I can tell you, as I'm sitting there talking to the mayor, over 40 cities and 9 policies and, multiple dimensions of the policy, exactly what they have to change to move up, right? You can't do that except through, the methods that I'm talking about, really, I think, in an effective way. And in fact, it's been pretty effective. The 10 cities improved overall, raised their medal status, which is pretty good for a fairly small advocacy project. In 1 year, 24 new policy changes were made in cities that made a difference. This is where I'm finishing up in terms of strategy and leaving those examples behind. This is kind of like, I think this is Angie's slide, right? And I have often used it because it captures the basic, the sort of way we normally think about what we do as researchers. We make evidence and we hope we get it out to people, and then they do something and there's better health. But in the vernacular of today's youth, I'm gonna swipe left now, because our group of people who've been working under the RWJF Public Health Law Project, a few years sort of came up with something different that was, again, one of these conceptual models that comes out of trying to think like health people. The 5 essential public health law services are meant to sort of mirror and follow the effectiveness of the 10 essential public health services, right? And the idea behind that model is you should be able to say what you do. Like you should be able to list your key functions. And that way you can see if you're actually delivering them. And then you can see if you're delivering them as well as possible. And in this too, also, we think of integrating. So, if you think what we're talking about here is, first of all, and this is where I think we come in, the beginning of it, what this has meant, although those are 5 policies, I put them in a line like this. Some people do it differently. Because I see this as sort of the process you pretty much always have to go through to get, or the steps that have to be covered to go from having some idea of how policy might be useful to actually having widespread adoption of effective policies. So, obviously there's no such thing as evidence-based policy, mostly because most of the time when we're making a new policy, we don't have evidence because the problem we're trying to address is new. Evidence-based policy is an output. So we're beginning with a guess, usually. We have a problem, we think, what should we do about this? And that guess can be more or less educated. It can be more or less right. And we've heard a bunch we've been going through that process today, where we say, well, we could try this, we could try that. What about, health equity, strategies? What about B Corps? And to me, this is actually the most important point, the most important of the services, in the sense that once we make a decision to try something, we're going to engage in a huge amount of work to spread that around. Huge bunch of work to get it passed, a huge bunch of work to enforce it, a huge bunch of work to assess it. If it was a dumb idea in the first place, we will have wasted a lot of time and effort. And there'd be huge opportunity costs in that. And I'll just give you an example from my hometown. Our health department spent a couple of years fighting with all its political capital to get a rule that raised the fines for landlords who had lead in their houses. If they had stopped and thought, they would have realized that that worked great. It's hard work until they got to enforcement. When they ran into the fact that the city of Philadelphia routinely does not collect fines. So that was known when huge amounts of political capital were being spent to get that passed. You just know that. So anyway, so the idea here is we have to make sure that when we are, one thing we can do to improve is to make sure that we have the best kind of epidemiological, political, behavioral, social, community knowledge at the table when we're trying to figure out whether there's some kind of policy idea that might be a good idea. I know that's a really important legal step, but lawyers are only just, lawyers are probably not the key participants. And usually, in fact, new policy ideas don't come from lawyers. So we got to have that done. But of course, you do need the lawyers, because once you have an idea, you got to figure out, well, can we actually do that legally, and what would be the best way? And there are huge questions there, ranging from whether we should do it at a city level to the federal level, to whether it should be a law or an order or some kind of softer policy. Lawyers are definitely needed there, but even there, because of the political considerations and the practical considerations, you actually can't just leave that to the lawyers. Once you get to advocacy, one of the things we have to realize, all of us, is we are all part of the advocacy picture, even if we just make data. That's, I'm not a believer in the model that says every researcher should be able to write an op-ed or talk to a legislator. But every researcher should understand and think about how the work that they do gets into the political process, and how they can contribute something. And if we don't focus on how you engage all the people that have to be engaged to make this work, you have failure. In the city of Philadelphia, we're having a failure now with safe injection sites, and the reason is Philadelphia is one of those places where the elites just tell everybody in the communities what's good for them, and tell them and hope that they'll listen, expect that they'll listen, and so we have a breakdown here after all the work it took, to get 2 years of work. It's kind of leaving aside the federal court. Running into trouble. We have almost no technical support, capacity building, or training in enforcement and regulation even in law schools. There's more now with compliance training and stuff, but in schools of public health and places that train health people, we don't really offer that, and the CDC doesn't help people with that once they're out in the world of practice, even though, enforcement is actually where law comes to life. Oftentimes, in fact, as in the case I told you in Philadelphia, enforcement is already over by the time the law is passed. There's nothing easier than to get a law passed but compromise on the budget. We won't take any new staff, there's no appropriation, no fiscal note on this bill, so isn't it great, we won, we got our bill. But it'll be a dead letter because you abandon that and things like that. And then, finally we get back to what we do, policy surveillance, evaluation. Like I say, look at the pharmaceutical model. We can't usually test law before we use it. But the first time some innovative thing is in place, NIH ought to be on that like white on rice, as we used to say. Right? Now we say brown on rice because we're more healthy. But it ought to be there because Richmond isn't the only place that's going to try and pass a soda tax. Philadelphia isn't the only place that's going to succeed in passing a soda tax. We can start getting information about how well those work right away. And then as those curves happen, in fact, one of the dangers in law is it progresses too fast. If your curve is like this, then you get 50 states implementing a solution that might not be a solution. So getting in early and trying to figure out what's working or not is really important. And of course, that also feeds back into every other step, because implementation studies inform your legal design. So when the next person does the statute, they don't just cut and paste into theirs. They actually revise it to reflect what we've learned about implementation. Research is really important for politics and advocacy. We know that studies can make a huge difference in defining what a problem is, or in defining or pointing to a solution and helping build support for it. So this is the part at the bottom, right? That's important. This is the bottom line, I guess you would say, right? Because nothing here is new. Like I said, like everybody knows, we got to develop policies, we got to turn them into law, we got to do advocacy, we got to do implementation, we got to do research. But if we just let it happen and hope it'll happen and just figure somebody else has got it organized, it's organized, then it takes 20 years. And then you find out, well, yeah, actually, seatbelts work. But if you could find that out in 5 years, And you can spread something that works to every place, and you've made a huge difference in terms of morbidity and mortality. So I guess my view is we're not going to win them all, and all our ideas won't be good. But if we can be better at making better guesses about what will work at the beginning, and if we can be more strategic and systematic about launching them, testing them, and diffusing them, then we can really shorten the time it takes for the ones that work and the ones we can win on to get one on and do their work. And this is sort of a message for funders. I don't think, I ran 2 RWJF research programs, and we didn't really, unfortunately this only occurred to me afterwards, we put it that way. We weren't really we weren't using our resources strategically. NIH certainly doesn't in too many cases. It does occasionally, like it has with tobacco, it did with road safety, but we could do it much more. We should do it with housing, for instance. That's a huge area where we should be working on that. And we as researchers, by just kind of realizing that we got to think about how what we do over here or over here kind of can somehow be linked or connected. Who can we talk to? That doesn't reinvent the wheel. It just makes the wheel turn smoother. So that's my concluding talk for tonight, and I hope, because I got the stop sign, and I hope that was to some degree illuminating inspiration.
All right, so do we have any questions for our speaker? Yes.
I'm very glad. Oh, sorry. Yeah, thanks. I'm very glad that in your model, the final model you have there, you really talked about the enforcement component. At the same time, I see that really is where the weakness in finding the right variables in your model would be. Because in having a policy or a law, you have a paper. Enforcement, usually you have stories. And like you said, they don't really enforce this, they don't enforce that. And they have corruption. That's also a way of non-enforcing. So what are your suggestions in order to really develop variables that are strong enough that somehow can really measure enforcement?
Well, I guess I would say in short that enforcement behavior is just behavior that is in theory observable. So oftentimes, domestically where we're fairly well endowed with observation capacity, the problem we've had in funding research, and I know Angie can attest this from grant reviews, is that just somebody hadn't made that data. But if you take the case, say, of seatbelts, this was recognized as a problem early on, and they said we're going to have data on how many people actually wear their seatbelts. You can think of that as an enforcement or implementation measure, right? And so they were, researchers got funding from NHTSA or NIH to go and actually develop a generally usable method for estimating seatbelt use by, systematic random observation, right? So it was a problem, but it was solvable. We most of the time when there's some question we have about how a law is being implemented, it's conceptually solvable. But the question, and especially now, now increasingly I think we may have big data and other sorts of things that may help us solve. But you still have to pay for it, and someone has to do it. So I guess that's how, I agree with you. It is a really big weak link. It is a big problem, but it is not an insoluble problem.
That's why I asked you about the variables, right?
Thank you, Scott. It made me think of what's going on here. Unfortunately, in academia, we work in so much silos, right? So you have the School of Public Health with many health policy researchers there. And I'm not sure, are we collaborating with our colleague in the School of Law? I don't know. It seemed like, and so I'm thinking now of your model as almost like what you excel and what the people in the School of Public Health here are not doing as well is actually translating, advocating for these policy into action and monitoring it and evaluating it. So I wish that's, you see any opportunities for kind of people to come together, especially from the public health and the law? I mean, we even have a little center, right, for health law, something. I don't know what they do. So,
Center for Public Health Practice? Center for Bioethics and Health Law.
That's health law, yep, yeah.
So I mean, this is why we thought of it as kind of a cultural and intellectual problem.
Yeah.
We've had pretty good we've mostly focused on the health people because in some ways to do the evaluation side, it's mostly in their hands. And so younger people who really sort of say, I'm looking for something new to do, they get very excited by this. And the whole legal epidemiology name came from CDC, and I think it's spreading very nicely at CDC. There's a legal epidemiology section now in public health reports, and we certain people know what that term means. It's appearing elsewhere in the literature. So I think part of the uptake is going to be just recognizing, we can do this, and it's important to do. I think there's then going to have to be a bit more of a process of bringing the lawyers into it, because public health law, as any public health lawyer will attest, is not a high status part of the law school ecosystem.
Maybe I didn't realize that.
For
me, it's the highest.
I mean, law professors are generally interested in what the legal system says, or what laws say, and they're interested in sort of legal events that are caused as a result of what the law says. It's a smaller proportion of people in law and a smaller part of legal education to think about what the law actually does out in the world.
So I noticed during your talk, you mentioned cities, you work with cities. So there's a sort of political aspect you can already see from this. Say a city is implementing a solar tax, and you want to sort of expand that to the broader state level, and then you might have some political conflict with the governor and the cities, because there are different political parties in the. And so how would you, if you have sort of a law that you're trying to implement, pretty much to improve health, but how do you sort of frame that so it doesn't come up as some political tool? Because it's very easy to sort of exploit that and say, okay, that city, they're implementing solar tax, they're infringing your rights, and when you try to implement it on the state level, then you sort of run into problems, and how do you sort of distance yourself from that political aspect of it?
You don't. There's no distancing yourself. We win some when we lose some. Right? I mean, one of the things to keep in mind is that you have a biased sample usually in what's available to you when you think about laws. You hear about the things people fight about. Legislatures pass lots of health laws every year, often by bipartisan majorities, because there's lots of areas of health that aren't that controversial. So you got that, first of all. Second of all, you got to, to the degree that we are actually involved in a fight about health equity, which means we're in a fight about social justice. It is a long-term fight in which, the bodies of failed efforts are all around you on the battlefield and, sticking the place up for decades, to be really gross about the whole thing. Because this is a really long-term fight. And one of the things now turning away from this stuff to just sort of thinking about the politics of public health, is that we got to be fighting those fights. We got to be more attuned to those fights and fighting them more. That's why resistance to, in sort of structural injustice is really important. So when we were doing that project for de Beaumont, I said, you ought to put alcohol tax, raising the alcohol excise taxes on there. Many cities can do that, and it's proven to work, and they're really low. He said, we can't deal with taxes. That's too controversial. My view is if you're in public health and you won't deal with revenue, then you've lost. Because there's not much you can do in public health without money, and at least, it's also an effective mechanism. But there are big fights we have to take on, and I think that's one of them. And you just have to lose them and lose them and lose them, but keep coming back, keep making the case, keep developing the evidence base, keep the research coming, and hope and keep the faith. I've been in it. I wrote my first article about legalizing access to naloxone in the year 2000. Right? And I can tell you that people I was working with to try and spread access to naloxone could not get anybody to listen to us for the next 12 years. And then suddenly, so these are long fights.
So I wanted to address the point about public health. From the School of Public Health. I am a lawyer, a healthcare lawyer, a public health lawyer in the School of Public Health, so it's a kind of a unique position. And I have started guest lecturing in our health equity programs about the power of the law. I call it, spreading the gospel of the law and what you can do, because I think in public health, we're gathering a lot of data. And there's a lot of information, but we're not doing anything with it. And so teaching the future public health practitioner about the power of the law and what they can do with it, and advocacy and policy work. So that's what I'm trying to do to change that, the impact public health can have.
You change the culture here.
Yeah, I had a quick follow-up to that, because I'm thinking about during my MPH degree, we weren't required to do a public health law class, so I was thinking that it's possible to add that as an integral part of like your required classes to kind of have some type of public health.
And that would be a great thing to do, to have that be a required
sorry.
element.
Yeah, I'm just wondering if that could be a requirement, but you had because I had a question, but it's okay. Go ahead. Okay. I had a question about the Law Atlas Project website. So if a medical research lab wanted to do something about an impact on the law and health outcomes, would it be possible for us to partner with the project and maybe get because I was looking at a law I personally would be interested in. Would you be able to work with us to kind of look at that and
Yep.
and so
Yeah, we do a lot of what it's sort of a motley collection of laws up there. Some things that we just thought, well, this is interesting, it'll illustrate the problem, or this is a hot idea, there's going to be a lot of change. And then we do a lot of work where we work with somebody, we get funding, like that NIH project. That's all funded by NIH.
Okay, thank you.
Absolutely. To use just the commercial portion of our evening, if you have a project you want to work on, do consult us at Temple.
We have time for one more question.
So I have just a high level one, Scott, and I think, do I need the microphone? So maybe I'll give you the softball then, I don't know, but the focus was big picture kind of on health equity. I think you did a great job of talking about the public health issues looked at. What do you see coming up? Like, what would you focus on if you were going to start to think about how legal epi could help us with our health equity?
But you always have to say, I think you always have to say, like, first of all, let's just take a moment and think about climate change and realize that everything else we do is pointless. Okay, now. I mean,
women do.
Well, Dean Burke was talking to me about his paper in Science last summer that shows that we've been having this sort of exponential growth in drug-related deaths since the 70s. When I was born 62 years ago, we had just about the lowest income inequality in our nation's history. And now we're coming up to record levels. I mean, the fundamental problem we have is inequity, is the fact that too many people lead lives that are too full of stress, that are too hard. The biggest public health issue is most of us are just not that smart. And we need a world that's not smarter than we are. It can't be too hard to find a house. It can't be too hard to get a job. It can't be too hard to get your kids educated. Like, it's got to be just, you got to have a little time off. You got to be able to, have some peace and quiet. And if you make that impossible for people because the resources have been distributed in a way that cuts most people into a position of desperation, then you're going to have bad health. I'm working on drug stuff. I think that's really a great measure of that. I mean, who's at risk? Why are they at risk? Why are they using drugs? Is a pretty good window. But I think housing is another one that's really crucial. I mean, housing has to become a much bigger issue in this country in a lot of places because it's really pervasively impacting people. And then, of course, education. I mean, it's all the social determinants. And the law piece is, to what extent is law helping or hurting? Like in the area of drug policy, law is actually incredibly iatrogenic. And beliefs about the law are even worse. Like, we've had these 3 waves of law-driven harm. When FDA sort of said, oh, go ahead and sell those things and advertise them as much as you want. That was law. When we said, we got to cut back on people getting at these drugs. And, suddenly you had people going out to the street. That was law. The belief that if you cut off legal opioids, you're cutting off opioids. And the belief that the market wouldn't respond by bringing them to a higher demand, by bringing in a more potent form, those were mistakes of policy. So those are big. But with something like housing, it's much more complicated. The biggest problem in housing is we're not spending money, building the housing. We haven't intervene with the market. But the law problem is all over it, and then we have all these solutions that aren't solutions, or things that make worse. The zoning, all the sort of governance systems that make it impossible to plan regionally and to plan rationally. So there's plenty of work for us, but a lot of that work has to do with not, I think, so much starting with new ideas. Well, I think it involves new ideas. Like my view is like when we have an innovation, then we should test it like we would test a drug. It should be in a framework in which it is being observed. And we sort of have all these systems in place, and we find out as fast as we can whether it's a good innovation and how to tweak it. We also have a lot of brush clearing to do, because there's a huge amount of stuff we just absolutely don't know about laws that supposedly work. I just published a piece in the new Northeastern Law Review that's not even complete because I'm doing more work on it now, but a partial 30, 40, 50-page look at all the things we don't know about law related to housing, which is a huge amount. And we just really don't know does it do what it's supposed to do. There was an academic legal argument about the revolution in landlord-tenant law, the implied warranty of habitability in the 70s, and the big fight was this going to destroy rental markets, or was this going to completely empower the tenants? And it was in the top law reviews of the top professors. 30 years later, it apparently is the case that almost nobody has ever used an implied warranty of habitability claim in an actual housing case that anybody can find. Like, it just never happened.
That speaks to the messaging and making it understandable to regular people. I think that's a big piece.
We've got a lot of talking to the world to do, and that also means that part of I think research is a great way to talk to a lot of people across a lot of disciplines. That's one reason for lawyers to talk research more.
You would even think like legal partnerships that would have come up too, because
it does. I guess I would just say that I think it's an access to justice problem. I think that if we were getting tenants to lawyers in time, then these claims, the law students are chomping at the bit to make these arguments. They want to bring these cases. We can't find the clients.
Is it time sensitive?
And it is time sensitive. There's a window of time where you have to bring the claim because you're going to get evicted otherwise.
But it's the other, this is my mantra that you've heard before, is that this is all fine, but there's also this ideological component of people who, the reason why inequality is the way it is because there's this ideology that markets are fine, and if you can't win in the market, then you don't deserve the help of the society, right? And, it's across all of these areas. And you have got to, try to convince people that actually the ideology doesn't matter if people are living miserable lives, that actually we should be looking at what works.
I think ideology is, on the one hand, incredibly important. We as a group of people trying to work for change are a loosely organized conspiracy. And we need big ideas so that our unconnected actions can still be coordinated and can be supportive towards common ends. But ideology, it blinds as well. And one of the to me, what always attracted me to public health is the first commitment was to look at, we don't always honor it, but our first commitment is to look at the data and try as well as we can to understand what's actually happening out there. And increasingly when we think about equity, we've been realizing, and we can't know that just from the data. We have to be engaged with the people who are living, with these problems, the people who are working on the streets to solve this process. The whole idea of science is to recognize bias, and that's an important bias. But I think that's pretty good. That's pretty strong, and then that hopefully can lead to an ideology, to a vision that is, you should have a right to a house. You should have a right to health care. However you want to phrase it, you have to. People have a right to an income that gives them a decent sufficiency of life and a minimum of stress. And to compare that pretty modest vision to what we have now. That hopefully that sooner or later will get people to see we can't keep going down this same path, and that what people are telling us about how everything's great because it's great for me.
You have your freedom.
Not going to work. Yeah.
heard that.
Thank you so much. Yeah, so thank you all so much for coming. I'm getting the wrap-up symbol from Professor Sirleaf. Thank you for your time and attention, and let's keep the conversation going. Exchange business cards, exchange emails. Let's put some of these things into practice. Thank you.